The FDA did post-marketing studies indicating a 5% rate of culture-positive scopes despite reprocessing. That's a huge failure rate. 1 in 20 patients is at risk. That's something that should really wake us all up and have us look at what we can do better and how we can redesign scopes. Disposable types of scopes will help, but it's not the long-term answer. Either the reusable scopes have to come out of something better, where complete sterilization is actually possible, or I think the future is going to lie with disposable scopes.
Clearly, where the field is going is towards use of single-use device. And the more we try and the more we get familiar with it, because it's going to be a game change for the field of interventional endoscopy.
Once I began the procedure, I completely could not tell I was using a disposable instrument. I forget I'm using a disposable scope when I'm working on this.
I think what we're living through right now is the beginning of a transformation in healthcare, where we're going to look back 10 years from now and say, I can't believe we were using, scopes that we reused over and over again. So it gives us a nimbleness to address clinician needs. It gives us the ability to iterate on a pace that has never been seen before. And it manages some really serious problems in endoscopy in a way that no one's ever been able to do before.
The Acquire Endoscopic Ultrasound Fine Needle Biopsy Device is a new biopsy device designed for the targeted sampling of submucosal and extramural lesions in the gastrointestinal tract. It's able to do this through the accessory channel of a curvilinear echo endoscope. The system comes with a handle and customized sheath similar to our Slimline family of needles. and it provides the same great performance you've come to expect from our products. What differentiates the Acquire FNB needle tip from FNA aspiration needle tips is its cutting surfaces. While other needles may only aspirate cells and perform minimal tissue cutting, the design of the Acquire FNB needle provides an increased number of cutting surfaces, thus increasing the chances of getting a visibly larger tissue sample for histology. This tip design is similar to percutaneous biopsy needles used in interventional radiology. The Acquire needle also has custom sheath sizes, designed to improve passability and help advance the needle out of the sheath. The 3 needle points are designed to afford greater control at the puncture site. They also provide stability to the tip at all times, allowing for easy penetration. To facilitate puncture and potentially minimize tissue tearing, the tip of the needle is electropolished, a manufacturing process that removes all imperfections. Aided by aspiration, as tissue moves through the needle tip, it's pushed into 3 symmetrical cutting heels. These are fully formed to maximize sharpness and cutting capabilities. In addition, these heels cut tissue from 3 different angles, making a more circular cut before it's pushed into the needle. Compared to the FNA needle tip designs, the Acquire needle is designed to capture a larger volume of tissue with minimal fragmentation. Along with the Acquire's optimized tip design, the system is also made of cobalt chromium, which delivers superior penetration and leads to less needle deformation than stainless steel alloys. The Acquire fine needle system features control zone and lubricomp on the handle for actuation, making it one of the most versatile biopsy devices on the market.
Janssen Immunology has been contributing to science and medicine for the past 23 years, providing innovation in molecules, formulations, devices, and even clinical trials designs. On the occasion of the World IBD Day, this year, 8 renowned IBD experts from Lebanon came together to share their experience with Janssen Immunology portfolio and showcase how the available treatments improved their patients' lives.
During the last 2 decades, Janssen has been playing a crucial role in the advancement of IBD therapies. We, as Lebanese Society of Gastroenterology, expect to maintain a fruitful partnership with you to offer our patients, through your innovative therapies, a better quality of life.
Let us travel back in time to 1998.
I remember the IBD patients that I used to see in my clinic when I was still a resident. As physicians, we really struggled to find the appropriate treatment for each patient. That's why we often opted for surgery, given the limited options that were available back then.
Fortunately, Janssen launched Remicade, which was a real breakthrough at that time. Honestly, I couldn't wait to initiate my patient on it and witness the great results seen in clinical trials in my own patients' lives.
Also, it was great to see that Janssen didn't stop there, but rather introduced Symphony, which is another innovative molecule offering UC patients the convenience of a once-monthly pain-free injection.
However, our patients were still asking, searching for treatment that better suit their needs. This is where Stelara came along, providing a complete solution for our IBD patients. I still remember how it changed the life of one of them who had Crohn's disease. He is a medical student who had almost lost hope, but had durable control of this disease till graduation. His family is still grateful and thankful till date.
As an IBD specialist, having in my disposition a large arsenal of therapies allowed me to provide a personalized treatment tailored to every specific patient. Now, with Stelara approved also in ulcerative colitis, we are moving our patients' experience to a higher level, especially if we provide them with a medication early on in their disease course.
Nowadays, looking at the current situation in the country and the massive challenges we are facing in the healthcare sector, it is not enough to have a variety of patients. However, we need to ensure patients have access to those medications.
Global guidelines highlight more and more the importance of considering the patient's status and preference while prescribing a medication. Therefore, it's our responsibility as physicians to take those into account in every decision we make along the patient journey.
And this journey continues.
Our patients rely on us
to provide them with the best possible solution.
We are all looking forward to what the future will hold with Janssen promising pipelines.
With this exceptional heritage, we are committed to standing by you to break the silence around inflammatory bowel disease and to support you and your patients in every step of the way.
Break the silence. Join our mission and give your patients their best chance to live free from IBD.
الحمد لله على سلامتكم من اللي جايين من كل المناطق من كل البلاد. أيها الزملاء، أهلا بكم في لبنان المنكوب، في لبنان المذبوح، في لبنان الذي يتهاوى رويدا رويدا، تتآكله الهموم ويمعن الأوغاد فاقدو الحس والمسؤولية في ذبحه. هذا لبنان درة الشرق، لوحة الجمال الإلهي بطيبة شعبه الخلاق، عملت أيادي الشر على تخريبه من الداخل والخارج، وعاث اللاعبون فيه فسادا وراحوا يدحرجونه يمنة ويسرة كالكرة بين أقدامهم حتى أغرقوه بالدواهي العاتيات. تصوروا أيها السادة كيف أن بلداً رائداً بالحب غارقاً بالخير مشبوباً بالجمال يتحول إلى مقبرة مظلمة تجوبها الخفافيش ليلاً وتدوسها الأرجل الأثيمة القذرة نهاراً. تصوروا كيف أن بلداً محورياً في ريادة النهضة العربية، بلداً مبدعاً يضخ كل ألوان الفنون ويقدم مناخ الحرية والثقافة. تصوروا كيف يتحسر في القرن 21 على لقمة العيش، وكيف يتحول أبناؤه مع فقدان المازوت إلى ثيران هائجة تتقاتل فيما بينها وتنهش أجساد بعضها البعض. هذا هو لبناننا اليوم. وشكرا لأنكم تجازفون بالحضور إليه حاملين رسالتكم الإنسانية التي هي النبل والشرف والعطاء. أهلا بالقادمين من كل أنحاء لبنان يحملون في طيات قلوبهم البؤس والأسى والمرارة، لكنهم يمثلون بحضورهم أيضا قيما معنوية عظيمة، قيمة الإصرار، قيمة إعادة المحاولة، قيمة التمسك بالحلم، قيمة الأمل. فما أضيق عيشنا اليوم لولا فسحة الأمل. أهلا بالقادمين من الدول العربية الشقيقة، وأهلا بمن حضر من رؤساء الجمعيات الطبية أيضا. أنتم ربيع يختلج في قلب كل لبنان، وأنتم فجر يبتسم وراء كل ليل. مرحبا بالقادمين والمشاركين، لأنه في مشاركين كانوا قادمين وما قدروا، وأكيد نحن بنعذرهم. مرحبا بالقادمين والمشاركين من كل دول العالم. أقول لكم تكبدتم عناء السفر في زمن الكورونا الخبيثة التي تعم بويلاتها كل بقاع الأرض وتجهز على ملايين البشر مستنزفة الجسم الطبي في الأرض قاطبة. وأريد هنا أن أحيي ذكرى كل الأطباء الذين كانوا في مرمى نيران العدوى وفارقونا وهم يخوضون غمار الكفاح لمعالجة المصابين، وأسأل الله أن يرحمهم ويسكنهم مع الأبرار والشهداء. أيها الزملاء، إن الطب رسالة حب وكرم وتضحية نبذلها من أجل الإنسان حتى نعطيه الأمل والشعور بالأمان والشفاء بعد يأس ومعاناة وألم. إنه رسالة ومسؤولية إنسانية، بل هو السلك الخفي الذي يربط الأرض بالسماء. فالعناية الإلهية التي يوصلها الطبيب إلى مريضه هي التي تحرك الدم في العروق، وهي الوكالة التي أعطاها الله للطبيب لتكون عونا ونعمة للإنسان. أيها الزملاء، إنه المؤتمر الرابع على التوالي الذي نقيمه وأنتم فرسانه وأمراء ملعبه، فلا تنسوا أن الله أوكل مهمة الطب إليكم حتى تكونوا رسل الرحمة لبني البشر. يعطيكم العافية. وهلأ رح نبلش نقدم أول كيس. اللي عنده أسئلة ما يتردد، في مودريترز. أنا متكل على مشاركتكم كلكم، كلنا إن شاء الله إيد وحدة لحتى ننجح.
Good morning. We're expecting to start the live cases now.
Good morning, everybody. I want to start with the first case. It's a case of 84-year-old female presented with painless jaundice and elevated cholestatic pattern. MRI abdomen and pelvis with MRCP showed significant intrahepatic biliary dilatation and CBD dilatation. Focal heterogeneous nodular abnormal signal intensity of segment 6 of liver extending over 2.2 centimeter. Dilated main pancreatic duct and ill-defined heterogeneous central necrotic 3.2 centimeter times 1.9 centimeter lesion of pancreatic head and acinated process. MRCP showed 1.36 centimeter distal CBD stricture, and MRI abdomen showed 2.2 centimeter liver lesion. Therapeutic ERCP was failed a few days ago. So it's a case of colodecoduodenostomy versus hepaticogastrostomy with Dr. Mu'in Kashab and Dr. Ammar Ghazali.
مرحبا. It's a pleasure to be here. وبهني لدكتور زاهر حماني انه قدر يحط هيدا الكونفرنس توجذر. هيدا الشغله كثير مهمه لزاهر ولنا كلنا وللبلد. انا بفتخر انه انا هون مع دكتور عمار غزالي, my friend, who will be assisting me, and Ali Bayoumi, who will be assisting me with this case. So we have a linear Fujifilm echo endoscope. فرجيكم أول شيء على EOS. So here, we see the mass in the head. It's a large mass, and this is the bile duct. فهون one option we have is a colodocoduodenostomy. One challenge here is that you see the cystic duct just coming anterior to the bile duct. So we have a window, but it's very, very small window, and I don't think it is feasible. The bile duct is very dilated, so a colodocoduodenostomy otherwise will be very simple. And here we're tracing the duct towards the hilum. So I think it's a large mass compressing the distal and mid CBD, and not leaving us an option for a colodocoduodenostomy. So the other options in this case are a hepatogastrostomy or a drainage of the biliary system through the goblet. So since colodocoduodenostomy is not an option, we're going to come back to the stomach and look at the left lobe of the liver. Can you see the EOS image?
Yes. Yes.
Okay. So, so here we are just below the GE junction, and we're going to show you the Doppler. Hide the cursor.
وين في arrow cursor?
Here. So this is here, the bile duct that we like. Let me turn this Doppler off. And we see that this is a branch of the left main. Let's freeze here. And can you guys help me measure this duct here? Can you help me measure the duct?
Sure. Let's go ahead.
So this is going to be about 5 millimeters, which is adequate. Maybe 3. Make it larger, Ammar.
Yeah, okay, I'm working on it. All right. So
okay, that's
maybe
good.
if we angle off of it.
Okay.
Okay.
Freeze, okay.
Going to unfreeze it. Okay.
So if we follow this duct, this goes towards the left main, which is extremely dilated. But we don't want to puncture the left main. First, it's further away from us, and then it doesn't leave us just space for the hepatogastrostom. And here we see one of the hepatic veins, and above it is segment 2, which I'm going to target. So it's important to stay within segment 2 or 3. I prefer, my own preference is segment 2, which is right below the GE junction and gives me a great position that is stable. There is always going to be a vessel close to the bile duct because it's portal triads that run together. So as long as the vessel is not large, it is acceptable to target. Let's get the needle, please. So can we get the fluoro image, please, and show the audience the fluoroscopy? Let me know when you have the fluoro image, please.
فلورا ايه بس بدي انا بعملها من هون بس بدي
مين عم بيغير لنا
يعني
نو قصدي للاودينس مين بيغير بدنا بدنا نغير للاكس راي اوكي بس خبريني انه غيرنا
ايه Is there a distance between the probe and the duct that you prefer, at least to decrease the risk of complications and allow for proper stent placement?
Yeah, so less than 3 centimeters. It makes the target easier, and then you have enough stent to bridge. Because like we spoke before, it's really important to leave about 3 centimeters of stent in the stomach. So if the target is 5 centimeters away from you, you're not going to be left with enough stent in the stomach. Guys, can you see the X-ray?
Yes, apparently we can.
So I'm depending on the moderators to let me know if you guys can see the X-ray. How do we mag without zooming in?
I think he just. When
Okay, how do we mag without zooming in?
بدنا نعمل mag.
We don't see the X-ray here.
ها؟ فرجينا الإكس-راي هلا.
هلا بدنا نعمل mag بلا ما مش increase depth بدنا نعمل magnification بس.
Okay, it's good.
لا هيدي عم نفوتها لجوا. لك هلا اختفى البروب يعني.
اوكي ممتاز.
ممتاز.
اوكي هيدي كيف فينا اوكي ممتاز. طيب هيدي البوزيشن للسكوب كثير مهمه لانه it's facing towards the hilum. اوكي فنحن هلا فينا نحط كونتراست هون بليز. ونعمل له برايمينج وذ كونتراست بس كفايه شوي كونتراست لجوا. اوكي كثير منيح. طيب هلا نحط النيدل. قيمه بليز لهيدا.
You want to zoom it back ولا ماشي حالك؟
So as you can see, Dr. Khashab here is targeting one dilated bile duct. He'll get the needle into it, confirm his location, and then complete the drainage through that axis.
بس ما بدي اخسر البروب.
He should be puncturing the liver now.
Okay.
We can see the needle coming out of the scope under the EUS. This is probably the most critical step of this procedure.
الضغط المظبوط.
So the needle is almost there.
اعطينا اكس راي بليز. لايف اكس راي.
لا وقف. ليه وقف الاكس راي؟
اعطينا لايف بليز.
لحظه بس بدنا وين الاكس راي؟ اوكي بس ليه ما عم يمشي هون هيدا؟ بدنا اياه لايف ضل ماشي. ليه عم يوقف؟ داعس منه ماشي.
So the needle is in a dilated duct. He is injecting some contrast.
No.
شو؟
يلا لحظة. ليه ما عم يضل ماشي؟
اوكي حتنقله على غرفه ثانيه نظبط الاكس راي وبنرجع. ما حنعمل شيء بلاكم.
Okay, Mu'in, since we have you there for a minute, what is your plan? Is to drain through the stomach or to do a rendezvous?
So the second case, it's a case of a 64-year-old female patient presented with rectorrhea on aspirin. Colonoscopy showed a rectal tumor starting at 10 centimeter to 15 centimeter with 5 centimeter in diameter, Paris type 2A plus 3. And we have 3 sessile polyps in the right colon ranging from 10 to 15 millimeter. Rectal US showed tumor invading the perirectal fat, UT3 and 0. PET scan showed no distant metastasis. So it's a colonic polyp assessment plus or minus resection with Dr. Mahmoud Halal and Dr. Yasser Shaib. Sorry. Dr. Muhammad Sharbini and Dr. Mahmoud Halal.
Yeah. So this is a case of a patient with rectal cancer being considered for neoadjuvant.
اوكي صباح الخير. محمد شربيني، القاهرة القصر عيني. طبعا احنا يعني سعداء. دكتور زاهر اكتشفنا فيه مواهب كتير جدا النهارده، مواهب الشعر، حاجات جميلة جدا. ساعدنا بالكلمة الافتتاحية. توكات شورت يعني عشان الوقت بتاعنا. انا بيشتغل معايا دكتور محمود حلال هيساعدني خضر، ومعانا بقيه الجروب. بنشكر كل الناس، سعيد جدا. الحلقه بتاعتنا زي ما سمعنا التقديم بتاعنا، احنا وصلنا للسيكم تو سيف تايم. This is appendicular orifice. بصراحه دكتور زاهر يعني تسلم ايديه. احنا اول ما دخلنا ما كناش شايفين البوليب. احنا لما بندخل كده ممكن ما نبقاش شايفين اي حاجه خالص. withdrawal وبجود بريباريشن، العينه متحضره كويس قوي، نقدر نشوف الليجن اللي احنا هنشوفه هنا كده عند الساعه 5. تمام. this lesion دكتور محمود بقى هيساعدنا كده ويقول لنا الليجن اللي احنا شايفينه ده. اهم حاجه قبل ما ناخد decision of resection عايزين نقدر نعرف الكلاسيفيكيشن whatever Paris classification and Kodo classification to assess the resection. احنا شايفين هنا عند الساعه 1 بالظبط 1 o'clock او 2 o'clock with the ileocecal valve. The one fold pre to the ileocecal valve we can see this lesion.
This lesion, this lesion, as you see, the subpedunculated large villus polyp. فينا نشوف بالام بي اي we are using the Olympus 03. الام بي اي اذا بتشوفوا البيت باترن documented that it is Kudo 3. It goes with villus adenoma. If we want to see the Paris classification, we see here that it's a subpedunculated polyp. To remove this polyp needs injection.
Okay.
We will inject methylene blue. As you know, we start injection of methylene blue from distal to proximal to prevent dropping the polyp inside. Dr. Sharbini will inject with other start injection from distal area, and we'll see the injection. We are using methylene blue, diluted methylene blue.
So we'll start first by injection of the lesion. So our decision now to assess if the lesion can be resected with endoscopic mucosal resection or not. We put the lesion on easy position. We are using gastroscope from Olympus, colonoscope from Olympus 190 with the NPI mode and near focus mode. So now we will start by injection. Khodr will assist me. I'm using Microtech injector needle with 22 gauge. As Dr. Mahmoud said, we'll inject diluted methylene blue. Needle out, please. So we'll start distal here. Would you assist me? Yes? Yeah?
So would you have biopsied this lesion during the index colonoscopy?
Yeah.
Can you hear
Yes.
us?
Inject. Yes.
Ideally, when we want to remove the polyp, we avoid to take biopsy because the
Okay,
biopsy
continue.
will make it difficult
Continue.
and will lead to fibrosis. So the elevation, if we decided to remove the polyp, we prefer not
No,
to take
stop.
biopsy.
Wait. Again. So we'll stop. We'll stop now and we'll reassess. Does this help us or not? Okay, needle in, please.
Do you use another injection like sigma disc for this lesion,
needle again.
or it's not recommended for this
No.
type?
Wait. Needle in. Yeah.
We'll get up.
So what criteria do you use to decide on resectability?
I think it starts to be lifted.
We are not hearing you very well.
I'm asking about Dr. Sharbini. What criteria does he use in such a polyp? So does he depend on the pattern, on the lifting?
No, wait. Sorry, we couldn't hear you, please. Would you repeat your question again?
I'm asking about the criteria you use to decide on resectability of such a polyp.
فين نعلي الصوت شوي؟ ما عم نسمع. فيكم تعلوا لنا الصوت شوي؟ We are not hearing you very well. He's asking about the criteria of lifting, I think. Here, okay.
Yeah, you can inject. No, we are transfixing. Again, we can inject from here. Okay. Inject.
Okay, that's it.
You can continue.
Here you see
stop.
We do elevate the polyp.
Dr. Mahmoud and Dr. Muhammad, you hear us?
Yeah, you can inject.
Yes, now we are hearing.
Okay.
Continue. Okay, stop. Continue.
I want to ask you if you use another
As you
injection
can
like
see now,
Sigma-Visc
I
for
think
these
it's got
types of
lifted.
lesion.
Okay. Okay. Stop. Needle out. So I think it's lifted now.
It's lifted.
So now we'll go with the snare. 23 or 25. Okay. So you will see now the snare.
We are using
now it got lifted. We'll go inside and see the lifting from the inside. Okay, 24. So I'll use the snare with 24.
So as you see, they have tried to inject mucosal injection to see if there is invasion in
this microtech snare, 24, this oval snare
Here
from
we have
microtech.
cervation of the
So I'll
lesion
use the
by the
snare for
injection of methylene blue.
MR now.
It's well solvated, so no deep invasion is suspected. And I think Dr. Yasser Shaib was asking about the criteria that we admit for mucosal resection of those types of lesion. And here we...
Now we'll shift to other room.
We have salvation of the lesion, so we have to continue with the resection via the snare. And they intend to have a complete resection of the lesion to have good pathologic exams concerning the margins and the depth of the invasion. So as you see, it looks that all the lesion is taken by the snare, and the essential on this lesion is to take all the
مرحبا بدي فرجيكم على الاكس راي خبروني بس تشوفوا الاكس راي.
So here we move for the other live session. So with the
so we don't see the X-ray. We can't see the X-ray.
يعني هلا بصير في ليكج بدي احط الواير وامشي ما فيني ضلني. ها؟
بس انا احط البالون.
اوكي بدنا نشوف الاكس راي بليز قولوا لي اذا عم تشوفوا الاكس راي.
نو ما هلا شفنا الاكس راي.
اوكي فخل عمر خليك خلي هلا نحن عملنا كولانجيوجرام فيري دايليتد داكت وهلا الداكت كثير صغير و بعتقد النيدل طلعت من الداكت لأن كنا ناطرين.
So again, he achieved the first step, which is cannulating the duct, access to the duct. Then apparently the needle is out, so he has. I don't see a wire through yet. So the next step will definitely be passing a wire. And Mu'in, if you can hear us, what is your plan right now? Is it to drain directly or to transpapillary or a rendezvous? How do you decide? Is it something you decide intra-procedural?
Yeah, so the hepatogastrostomy, it's a one-stage procedure. And it doesn't require exchange of scopes and stuff like that. So here, unfortunately, something that we don't like to happen happened. The needle came out of the duct. It took about 15 minutes for us to. So I'm gonna get the needle back here and repuncture. So we got a cholangiogram, as you saw.
Yeah.
But then I believe the needle is outside. So we have to be very careful when we are pushing the wire in and out. Okay, so we see the duct still there. It feels like we are in.
So again, this is the needle going through the liver. He's trying to puncture the duct again so he can pass the wire. He needs to establish good access before he...
So we're trying to manipulate the needle. We do have a cholangiogram, but you know, the duct is small. And I think we got out of it just with the waiting and the breathing live.
Yeah.
So here, we just have to be patient and try not to re-inject, because if we inject outside the duct, it becomes really hard to get back in.
And you can see how the first puncture is probably your best puncture, because that's when you see the duct, you know you are in the duct. Now, if you inject, if it's outside, it will mess up your views. And if you're inside, you're not to be sure because you already have contrast inside the duct.
Yeah. So I think we just have to take another look and try to re-inject.
We'll take some questions from the audience.
The duct started by being 3-4 millimeter.
Moin, why did you choose to puncture the small duct, a smaller duct? Why don't you go further down and a very dilated duct?
Yeah. I mean, it was 5 millimeter on my measurement, and that's fine. The thing is that when you wait 15 minutes, then that duct is leaking and it becomes very small. And you know, with any breathing, the needle can come out. So that's the issue, but 5 millimeter is okay. I didn't want to go to a 10 millimeter duct that is very deep. It becomes really, really hard to control anything. We may have to do it if this doesn't work, but
it's not a matter of
I think
vessels.
we have to just start from scratch here, guys.
It's a matter of vessels, a matter of distance. And as Moin is explaining, he had a decent sized duct to gain access. The problem is he lost that access, and now he's trying to reestablish it.
So we got lucky here, to be honest. Okay, so we got lucky. We got back to this little duct there. So now, really important is we're gonna exchange, and very important is to keep that wire in view. So Ali and I are gonna exchange. So Ali, you're gonna get into a comfortable position, and you're gonna hold. بدك تمسك النيدل من هون والواير من هون وتعمل exchange. حدا خلي حدا يحمل لك الواير من هون. نعم. ايه اوكي. بس بدي اشوف انا هيدي. تيجي بعد لي شوي هيك. عمر خان ساعتها.
So Moin, now you will only consider a hepatogastrostomy. You will not consider a transpapillary drainage, for example. Like after establishing access.
Now it seems that we moved for the other room. We see that with Dr. Mahmoud Halal and Dr. Muhammad, they have resected the lesion. So could you tell us some details, Dr. Muhammad?
Yeah, hello.
Yes, we are hearing you.
We did the elevation for we elevated the lesion, okay. With the methylene blue. Well lifted, good lifted. We catch it in a good catch. We think that it's a good catch. Actually, we catch more than 90% of the lesion, After cutting, we saw a small lesion on the back, or distal or from cecal side, and we catch it again. So we remove the lesion in piecemeal MR. After first resection part, we encountered active arterial bleeding that controlled easily with the hot biopsy. Now we can see the bed of the lesion. It's clearly, it's not infiltrating the muscle now, just to coagulate the edges with the hot biopsies. Then we will close this lesion with the hemoclips or endoclips because we are in the right side or in the ascending colon. Now we can see a small lesion here. We'll catch it with the hot biopsy. Open, please. Hot. Open.
So you can coagulate the merge of the lesion just if there is any residual lesion.
So he's completely resected the polyp, as you can see, with some remnant tissue on the edges.
Now it's completely resected.
He's using a hot biopsy to complete the removal of whatever tissue is left behind. Remember, you can do that with cold biopsy.
Now we will close the close. Now we will shift to room 3, okay, with a new case.
And this is a successful.
The third case is a 67-year-old male patient known to have coronary artery disease on aspirin and Plavix, presented with rectorrhea. Plavix was stopped 5 days before the procedure. On April 2021, colonoscopy showed 2.5 centimeter pedunculated polyp in the right colon, NICE 2 Paris 1S, lifted by normal saline and indigo carmine, partially removed by snare polypectomy, complicated by bleeding, controlled by clips insertion. Procedure was stopped secondary to hemodynamic instability.
So this case had a incomplete polypectomy that was complicated by a bleed, controlled intraprocedural, and the patient is being presented for
pathology
follow-up.
showed villous adenoma with focal high-grade dysplasia. Colonoscopy with remaining polyp resection by Dr. Shayma Al-Kholi and Dr. Muhammad Al-Nadi.
Dr. Zahir.
Okay, welcome Dr. Shayma and Dr. Muhammad.
Dr. Zahir.
Yeah, we are hearing you. We hear you, Dr. Shayma. Go ahead.
معايا دكتور محمد النادي. صباح الخير يا دكتور زاهر. انا شيماء الخولي ودكتور محمد النادي من القصر العيني من جامعه القاهره. طبعا احنا عندنا ميكس فيلينجز. وي ار فيري هابي ان احنا موجودين في لبنان حتى لو الاوضاع يعني مش قد كده، بس احنا مبسوطين جدا وبنشكر دكتور زاهر على الدعوه الكريمه. احنا we will start with this patient. Our patient is a 70-year-old patient زي ما الدكتور شرح. هو عنده residual polyp ويمكن management of the residual polyps is one of the difficult يعني situations. احنا هنا بنستخدم منظار الفوجي اللي هو ال 7 series وبنستخدم CO2 insufflation، ومعانا الاربي الفايو 3 اللي هو احدث حاجه، ومعانا الكومبليت تاور اللي هو الفري كات والكواجيليشن، ومعانا الاربي جات. احنا هنا بصينا على البوليب. البوليب موجود عند 55 سنتيمتر. احنا هنا completely under water. This is the polyp as you can see here. طبعا شكلها اكبر بكتير من اخر كولونوسكوبي هي عملته، وده دليل على ان هي فيها اكتيفيتي قويه. We are completely underwater. We inspected the base of the polyp. هنا في we can see here the scar. It's very evident the scar of the previous polypectomy. لكن هنا ده التشيكن اونيون appearance، وده اللي احنا يعني يمكن ده الفيرجن part of the polyp اللي هو it's the non-touched part. فاحنا ما قدمناش يمكن choices كتيره في in this patient غير ان احنا نحاول نلفت this part والجزء الثاني نشيله حتى لو حصل muscle injury او perforation we have to close it.
This patient is an old patient, comorbid patient. هيخش جراحة على lesion still حتى لو في high grade dysplasia it's still benign lesion. فاحنا شفنا هنا and احنا راهنا على الهايبريد نايف لان هي بتحقن بجت عالي جدا. لو هنا احنا ممكن نبص على السيتنجز بتاعت الهايبريد نايف. ممكن نوريه السيتنجز بعد اذنك. السيتنجز هنا زي ما احنا شايفين الجيت بتاعنا احنا usually بنستخدمه على 35. This is a specialized device only for injection. It's a very expensive device but it's worth it لان احنا بنستخدمه usually in the POEM and ESD وممكن نستخدمه دلوقتي في ان احنا save this situation ان احنا inject this polyp and we injected actually واحنا off air and it was lifting this virgin part of the polyp. It was lifting. And we intend to do EMR even لو حتى حصل muscle injury you will put some clips at the end. هنوريه بس حاجة هنا ظريفة. احنا بنستخدم ال 2G7 series اللي فيه الكات series as you can see here. هو طبعا it detected the lesion.
The benefit of this system that it has 3 systems of lights. The white light and the LCI are used for detection of the lesion, and the BLI is used to characterize the lesion. So, as you can see, the image detects automatically the polyp, and it detects that it's an aplastic polyp. So you have 2 modes: a detection mode while you are doing the colonoscopy to show that there is a lesion. Then you apply the BLI with artificial intelligence, the CAD button, and it will detect that the lesion is neoplastic. So, Dr. Shaimaa now is using the ERB knife to inject and to create a space under the polyp so that it can facilitate later the resection. So we will move to Dr.
We have a question from the audience.
Come back to the resection of the polyp.
Why did you not use envelope for this pelliculated polyp before?
نحن هلا خبرهم بس.
اوكي هلا.
So we're back with Dr. Khashab for the hepatogastrostomy.
طيب خلينا نشوف اول شيء الاكس راي بليز. اوكي عندك الاكس راي فيو؟
We could not directly. No, we need the X-ray, please. We can see your screen, but not on our screen. We see the endoscopic view. Switch to fluoro, please.
اوكي طيب هيدا الاكس راي حاطين الستنت. عملنا دايليشن with the balloon. We didn't use any cautery. هلا بس بدنا نحط الستنت بدنا نشوف الاندوسكوبي فيو. هلا هيدا
So you established the axis again with the wire.
Live.
Dilated with the balloon.
Yeah.
And now you're passing the stent. And what stent are you using?
Fluoro. هنستعمل partially covered wall flex from Boston Scientific 8 centimeter. اوكي خلينا نبلش نعمل deployment. هلا الديبلويمنت عم بعمل انا شوي عليه بلش اعمله. الديبلويمنت بده يكون كثير سلو. البلان لازم يكون عندنا 3 سنتيمتر بالستمك.
Right now, are you pulled back to the esophagus? Where are you right now?
Yeah, I'm pulling towards the esophagus. آخر شيء بنرجع وقف شوي عليه وقف. اوكي فرجيني الفلورو عمار. اوكي ففينا حتى نرجع بعد شوي. هيدا partially covered, so we're not worried about blocking the hilum. Go ahead. كثير مهم انه يكون عندنا 3-4 سم بالستمك.
So 3-4 cm, 3-4 centimeters in the stomach, that includes the uncovered part.
ايه اكيد الانكفرد بارت اكيد لازم يكون بالستمك والا بصير في ليك.
Definitely.
هلا لانه ال 3-4 سم كمل عليه لازم يكون بالستمك لانه في شورتنينج شوي علي شوي بدك تبطئ شوي لانه في شورتنينج حتى بعد الديبلويمنت. بعدين الستمك والليفر بيبعدوا عن بعض خلال التنفس مثل ما شفتوا. كمل. انا هلا هون عم نشوف الاكس راي وعم نشوف الاندوسكوبي. اوكي كثير منيح. خليك شوي وقف عليك. اوكي فينا شفنا بدنا نرجع بعد شوي هون. اوكي فلورو.
So as you can see, because he was working on high up in the liver, he's forced to be operating within the esophagus now, but eventually he will push the stent down into the stomach.
Flora? وين صار والله مشكلة لا الستاند هون ايه عندك ايه كثير منيح. اوكي كمل يلا شوي عمل ديبلويمنت. فعم نطلع اكس راي وعم نطلع فلوروسكوبي. اوكي هلا هون
اوكي yeah
okay Flora.
So the stent apparently is fully deployed.
بس خليني احط بس هنعمل ريتروفلكشن هنشوف اذا فينا نفرجيكم اياه. اوكي خلينا نشوف الاندوسكوبي فيو. شايفين الاندوسكوبي فيو؟
Yes. So you see that there is part of the covered, the part of the stent is out, all of the uncovered part, and it's high, close to the G junction, is pushed in. And
on the fluoroscopy, the fluoroscopy, the stent is very close to the hilum, which is excellent. So here we are done, I think.
And we can see that the duct is already draining, some contrast is out. Good job, Dr. Khashab. Thank you.
Okay.
Now we move for the other room with Dr. Shaima. So where are you now?
تمام دكتور زاهر احنا الحمد لله البوليت يعني mostly يعني 65% منها was lifting and we removed it خلاص اوكي وده مكان الباد بتاعها في شويه residual tissue صغيرين هناخدهم كمان بسنير.
So how you remove it?
سنير وده هنا لو هنا شايفين مكان السكار. يعني احنا شلنا الجزء الكبير هناخد الجزء الصغير المتبقي وبعد كده هنعمل coagulation to the edges.
Did it lift?
وهي بقى ايه سافرت جوه.
Did it lift with you?
Yes, mostly it lifted with a hybrid knife. Mostly it lifted with a hybrid knife يعني حوالي 70% منها lifted with a hybrid knife. لكن تبقى الجزء بتاع السكار طبعا حاولنا نحقن فيه يعني with the pressure with a slight pressure شويه lifting بس برضه it was not properly lifting بس we don't have enough options هنا في القصه دي بس it was يعني mostly lifted ما بقاش غير الجزء الصغير ده احنا شلنا the main bulk واحنا when we inspected the bed we found this small part so we are going to remove this small part وهنعمل coagulation. نفتح فتحه صغيره.
The tip that دكتورة شيماء took her time to inject to create a space with the jet. The jet under pressure created a space under the polyp, so it avoided perforation. So, Dr. Shaimaa, the tip that you can say that you take your time to inject properly to create the space. It will work as a cushion. So while you are doing the polypectomy, it will protect you from perforation, especially in such difficult situation when you're having a residual polyp after partial resection, prior resection. So you will have to be very meticulous in inspecting the bed right now.
طبعا هي يعني one of the most challenges اللي احنا بنقابلها ان احنا نلاقي recurrent lesion او residual lesion. So each time before any resection of any lesion, we have to be sure that we totally remove the lesion عشان the residual will cost us a lot. So the thing is here طبعا واضح ان في a sort of muscle injury على scar of fibrosis. احنا we are not sure. بس احنا our plan is that after we remove the lesion, we will do coagulation to the tips. احنا هنا بنستخدم precise sect. This is a new mode from Irby, the precise sect.
Okay.
So you're doing with the snare or the APC?
And we will come back.
What did she? Why did she use the cap?
Yeah, hello. Now we remove the lesion in the ascending colon, the first fold after the ileocecal valve. We remove it in EMR, piecemeal EMR. We encountered some arterial bleeding, 2 arterial bleeding that stopped easily with the hot biopsy as we mentioned before. After that, to avoid delayed bleeding and delayed perforation, because you are in a very thin region or a very thin segment of the colon, we close the defect here, as you see, with the hemoclips, with 3 hemoclips to avoid the delayed bleeding and delayed perforation. After that, we found small sessile polyps, one as you can see here. We remove it with cold biopsy, forceps, and we will retrieve the resected polyp.
When do you decide to close?
And this is the resected polyp, and we retrieve it. Sorry?
Question, when do you decide to close the polypectomy site, to clip? Do you use the size? Why?
Actually, we prefer to close the resected bed or the defect if we are worried about perforation, if we are see target sign. If we are seeing target sign, it's better to close. It's a must to close.
It's a must,
if we are in the right side, if the resected bed is, if the resected bed is large, it's inside in the cecum or the ascending colon, it's better to close it. Because if delayed bleeding occurred, it's very difficult to go again inside the colon and reach to the cecum or the ascending colon and to control bleeding. So it's better to avoid delayed bleeding, to avoid perforation, to close large defect, especially in difficult areas or thin wall areas like the ascending colon. But in left side of the colon, if the lesion is small, no need to close the defect or to close the resected bed after EMR. Now we will retrieve this polyp. We close the defect actually using the Microtech clips with 11 millimeter. Now we will use Rosenet, open please, to retrieve the lesion. After that, we will go outside and search for other polyps. If we'll find other polyp, we'll come back and see you the next step. So the first polyp, we remove it with EMR in the ascending colon, the small sessile polyps removed by cold biopsy forceps. We have many strategies to remove the lesion or for polypectomy, starting from cold biopsy forceps, and not now more longer recommend to remove it with hot biopsy forceps to retrieve the tissue for histopathology, especially in this patient. Open please. We also have many strategy like cold snaring, hot snaring, or cold snaring, or like EMR as we did. Close please. So
it seems that you have removed all the lesion.
More than, I think
so
it's
do you think that is sufficient to avoid surgery, or still there are some concerns about later pathologic results to go for surgery? So is it sufficient to avoid surgery for this patient?
Yeah, actually, this patient, as mentioned before, has lesion, lateral spreading tumors that become malignant tumor T3, as mentioned by the doctor, the first, with AOS, it's T3. So this patient will do left hemicolectomy, or even if chemoradiation, according to the decision, as we will see now. Okay, so we need to save the colon. If we did chemoradiation, if we did left hemicolectomy, to save the right colon for the patient, it's better than to do total colectomy.
So remember,
we'll
this patient has erectile cancer,
lesion,
a T3 at least, and she's going for neoadjuvant and will need a distal resection, a left hemi. So it's very crucial that we try to avoid a complete or a total colectomy.
Okay. Now we will shift to another room, please.
Thank you.
Thank you.
Good job.
Okay, welcome.
Yes.
Now we are live with you, Dr. Shaima.
احنا we remove the whole lesion واحنا عملنا coagulation. طبعا هنا
We need to see your screen, please.
واخد الماسل معاه كمان، وممكن يكون في بدايات muscle injury. احنا we coagulated already the edges and the bed with the precise sect mood, and now we are going to close with the clips. احنا بنستخدم clips microtech.
There was a question about using the cap. How does the cap help you?
مش سامعين السؤال، معلش ممكن تاني سؤال؟
About the use of the cap. How does the cap, why did you elect to use a cap in this case?
Actually, it's preferred طبعا with all resection techniques, especially the ESD and EMR, to use the cap. This is an ST Hood cap from Fuji. It's really a nice one. The use of the cap helps you to open the folds, so you can see this is the polyp that we removed. عمالة بتلعب اهي. It facilitates، يعني هي بتفرد الفولدز المقفولة، نقدر نشوف أي disc polyps موجودة. ومن ضمن ده بالنسبة للdiagnostic. بالنسبة للtherapeutic, the cap is really essential because it helps in maintaining the instruments steady still, not a floppy instrument. Especially during dissection, it's really important that we have the cap so that we can maintain our field stable.
So it's better for visualization and
some tips before doing such complex interventions. Try always to think about the safety. So we are using two insufflators. So even if there is minimal perforation or injury to the muscle layer, the patient is under CO2, so we can take time to proceed safely and to interact with this event. The idea of ablation is also adding more security, because we know that from previous biopsies the lesion was high grade and apparently it's growing rapidly. So we would like to ablate the edges to make sure that we are having almost a full resection of the lesion. So always think about safety. As Dr. Shaima said, the use of the cap is giving her steadiness and stability. So she's applying the clips. Yes. And she took all her time to inspect several times the polyp. She injected properly, and she was expecting and preparing all her tools before going and proceeding to this.
The use of the clips, we have different types of clips that we use now is microtech. Actually, Microtech is the Chinese clip. China طبعا ليها مكانة خاصة في قلبنا كلنا. This is the place where we have been trained يعني. Especially the cooperation between Cairo University and Shanghai, and we are using the Microtech clip. Actually, it's a perfect clip because it has the properties of it's rotatable. It's واحنا ممكن نقفل ونفتح.
Several times.
Several sizes. But actually, the Microtech clip is an excellent clip. Plus, it's a cheap one. It's a cheap one.
So, Dr. Shaima, why didn't you think about closing with, for example, an Ovesco clip?
It's no need. No need for Ovesco. We can close with the clips, with ordinary clips. لفهم ممكن. كمان. لف كمان. كمان لف افتح.
So, Dr. Shaima, first clip is to be put on the edge. Then following, it will make like a zipper, and you will have several clips after to close the bed.
I think the bed is closed.
The bed, yes,
there is
completely
concern
sealed
about
right now with 3 clips.
So it's time to get the polyp out. One of the properties of the cap is then you get your polyp out. يلا ممكن ناخد البوليب يا جماعه.
ممكن شاشة.
I think we're done with this case. Thank you very much. Excellent job.
Thank you.
Thank you. You're welcome.
So I think we're done with the live cases.
ناخد لها صورة بقى. لا ما تشيلش الكاب، شيل
I think
حطها بقى على الشاشة ده.
the live cases all are done. So I think it's time to proceed with our program.
section ممكن شاشة.
I think we had a good start for the meeting today. No technical issues, which is I expected more of under the current situation. And we're waiting on a signal from Nabati to go ahead and proceed.
يلا بس يبين عنا حيجهزوا اوكي يلا بلش قل لهم انه في محاضره هلا للشربيني.
Yeah. So next we're gonna we will listen to a talk by Dr. Muhammad Sharbini on endoscopic full thickness resection. Dr. Sharbini is assistant professor of anatomy and embryology at Al-Ma'rifa College of Medicine in Riyadh, and he's in the basic medical science department in the Faculty of Medicine. He's a member of the American Association of Anatomists, Egyptian Anatomical Association, and Egyptian Society of Stem Cell Egypt. We're ready for you, Dr. Sharbini.
صباح الخير تاني. أنا محمد الشربيني. My talk today about endoscopic full thickness resection. Usually the resection techniques that we know is designed or aligned for a lesion that are limited to the mucosa, submucosa as we see, and not the muscle. Whatever it is with polypectomy, EMR, as we see the case this morning, the lesion in the ascending colon, or with ESD, the different. The EMR, as we see, we can remove the lesion in block or in piecemeal EMR in the large lesion. ESD to remove the lesion in single or in one piece or en bloc resection. But actually, the muscle is still in the resection techniques, the old resection techniques, EMR and ESD is a barrier, is a border. This is our border. We couldn't touch the muscle in this case. So the muscle is the barrier, is our saver, is our, like in this photo, you can see here, this a lesion in the stomach on the anterior wall of the antrum. We remove this lesion using ESD. So we can see here, this is the pyloric ring, and this is the bed of the resected lesion. We can see here the muscle nicely, and this is the lesion after the resection. You can see this red arrows refer to the muscle. So here we didn't touch the muscle. The muscle is our barrier to avoid the complete resection. But if the muscle is entangling, if the lesion are related to the muscle, if it's originating of the muscle, this means that we will break the barrier. We'll break this barrier, the muscle. So our approach will be different. The technique will be much more challenging, and of course, the name of the resection technique will be changed, whatever it is. Endoscopic submucosal excavation, this means that the lesion is originating mainly from the muscle or maybe from the superficial layer and going deep to the muscle, but the serosa is not incorporated or not entangling, or the lesion respects the serosa, so we can remove this lesion by endoscopic submucosal excavation, or we can remove lesion by another technique called submucosal tunneling endoscopic resection. Submucosal tunneling endoscopic resection designed for subepithelial lesion or submucosal tumor originating mainly from the muscle layer or muscularis propria by doing tunnel, or we can remove the lesion by the endoscopic full thickness resection. Actually, the American Society of Gastroenterology designed and put classification for endoscopic full resection, whatever it is, exposed or non-exposed. Exposed means that after removing the lesion or during removing the lesion, the peritoneal cavity will be exposed. But in non-exposed, we will remove the lesion, we will resect the lesion without exposure to the peritoneal cavity. Without touching, we will touch the serosa, but we didn't expose the peritoneal cavity. So exposed also can be classified to tunnel, so it's endoscopic full thickness resection with exposed peritoneal cavity with using tunnel or without using tunnel. Our example for tunnel, as we mentioned before, is STAIR, submucosal tunneling endoscopic resection for submucosal tumor or subepithelial lesion originating mainly from the muscularis propria through a tunnel to save the mucosa intact. Or we can remove it through non-tunnel like endoscopic submucosal excision or full thickness resection. But what about non-exposed endoscopic full thickness resection is by using full thickness resection device. First example, this for endoscopic submucosal excavation. As we see here, this is a lesion, submucosal lesion with hybremic overlying mucosa. We are seeing this lesion in the fundus. We did endoscopic ultrasound. Here, the endoscopic ultrasound told us that the lesion are originating from the third layers, submucosa, and the muscle layer is intact. And unfortunately, the FNB proves that it's lipoma. But when we decide to do endoscopic submucosal excavation, as we see here, this is a lesion on retroflexion. We use here the hybrid knife from RB to do circular incision. This like endoscopic submucosal dissection. We started by injection. We didn't do mark in the stomach. We started by injection, and then we do circular incision. Here we can see the lesion. We discovered that the lesion is attached to the muscle. So we decided to dissect through the muscle. As we can see here, this is the muscle, and we had to dissect in the muscle. So in the last here, we can see the muscle entangled. And so we decide to remove in the lesion and at the end by snare, and we retrieve the lesion. After that, we did hemostasis. So what about this bed? And we injured the muscle. So we'll close this lesion using technique called burst string technique, like putting the snare on the tip of the scope, and we'll put the snare all over around the resected bed, and then we will close and fire the snare. After that, we can see that the defect is closed completely total. After that, the pathology showed this lesion, which plexiform fibromyxoma. It's a rare tumor. It's a potentially benign tumor. In the follow-up of this case, we, after 2 months, this nicely, we can see the burst string with the clip inside, and the defect was closed. We removed this clips with the end loop, entangled with it, and go outside. After that, we went again inside, and no defect and no residual lesion. So what about the tunnel exposed endoscopic full-stack resection, which is STAIR? STAIR, like POEM, this application of the third space endoscopy in removing submucosal tumor originating mainly from the muscularis propria. As we can see in the graph, the first one on your left hand is the A, by doing submucosal entry and doing submucosal tunneling, and we go inside to the submucosal lesion. Then we resect or dissect around from the mucosal and from the muscle layer, and after that we grasp the lesion. After grasping the lesion, we can close the defect. This is another example for in the STAIR submucosal tunneling endoscopic resection. This case is one of our cases. This young boy with 25 years has dysphagia. We found this submucosal tumor just before the cardiac, 35 centimeters from the incisor. We did mucosal entry, and we go inside the tunnel by injecting using the same needle or the same knife. This is hybrid knife. This I type from hybrid knife. Now we can see the lesion. It's very important to do orientation. We can see here the mucosa up and the muscle layers down. We resect and dissect around the lesion. Now, actually, we did more the resection or dissection from the mucosal side. Now we shifted to the another needle or like insulated tip to do final cut and resect the lesion from the muscle side. After that, we hold and retrieve the lesion inside the distal attachment or the cap. We can see this lesion now, this lesion, and this is the size of the lesion. After retrieve the lesion, we go again inside and go through the tunnel. We did it before. We can see here there's the muscle resected, and this is the serosa with clean bed. We did hemostasis. After that, we have to close the mucosal entry or the tunnel. We did it before. And this is the pathology, it's leiomyoma. So what about full thickness resection device? This is non-exposed. The peritoneal cavity will be non-exposed. This is the lesion, as you can see. This is the lesion with deeper infiltration to the deeper layer. We do marking by ABC probe around the lesion. Then we applied the device full thickness resection device. We can here put the mark. After that, we grasp the lesion using the forceps inside the cap or the distal attachment. we have to make sure that all marks are inside the cap and never do suction or aspiration. After that, we can release the overscope clips and we'll close the tunnel, and we can here see the scar, and we can see the peritoneal inside the lumen after application of the clips. So what about free-handed full thickness resection? This exposed free-handed full thickness resection. Now I'll introduce a case. This is one of our cases that we did full thickness section for that. This is a guest with umbilicated guest located at the fundus. The first part we did here marking using the hybrid knife around the lesion on forward view and on retroflexion view. After that, we use the same knife by injection and do mucosal entry, then completing the mucosal entry until doing circular incision, as you can see here. After that, we do trimming for the edges and to go inside, to go in the submucosa until exposure of the lesion. As you can see here, we inject, then dissect, inject and dissect all around the lesion, and we are searching for the tumor. As you see, we can see here that this guest originating from the muscle layer. We did the trimming. We are now using O type from hybrid knife with nearly insulated tip to bit it around the lesion, to trying to expose the lesion more from side to side. We use it by cutting from side to, as you can see, we can put it inside, and then after that we can dissect by its shaft. Now we can see the lesion and it's still attached to the muscle layer. We use again the O-type hybrid knife. You can see here that this is the peritoneal fat. We dissect around the lesion. Our concern now that this lesion after dissection can fall inside the peritoneal cavity. This is the lesion. So we will do traction technique, this clip in line. We'll go outside with the clip inside the scope and put dental floss and go with the scope and the inside dental floss outside the biopsy channel and the clip inside. We catch the mucosal cap of the lesion, and my assistant will retrieve on the dental floss from outside, okay, to do traction and to make sure that the lesion will be related to the clip with the dental floss. This final cut, now we can see the defect, and this clearly noise the fat. We will close it with the same technique. As you can see here, we put the envelope over the scope, we put the Phyllis clip, and will encircle the defect with the clips around the defect. Now we will put the last clip. After that, we can face some challenging, like the envelope can go outside the scope. We can catch it again, and then we will tighten the envelope. We will tighten it now, and the clips will close the defect. We will release the envelope. Now we can see the defect is closed. It's on retroflexion. This is very nice to close the defect. To some extent, it's challenging. This is the lesion, and this is the back of the lesion. After that, this is the guest. How to close the defect? You can use another techniques like overscope clips. We can use endoscopic suturing technique. You have to push the limits. But you have to know that don't do it unless you are experienced enough, you are fully equipped, and you are backed up with the surgeon. This publication for our team with the Chinese Professor Zhou and Professor Tsai for our team about the endoscopic resection of submucosal lesion, full thickness resection, and submucosal tunneling endoscopic resection. This picture or photos for the lesion, our team in Cairo University resected it, and this is our team, and thank you for your attention.
Thank you, Dr. Sharbini, for a great presentation. Now we will move next for Dr. Yasser Shaib for his presentation about malignant biliary obstruction, when and how to drain. Dr. Yasser Shuaib is a well-known professor of medicine and director of the gastroenterology training program at AUB. Is American board certified in gastrology and fellow of the American Society of Gastrointestinal Endoscopy, and he specialized in advanced endoscopic intervention, and his research interests include gastrointestinal oncology, interventional endoscopy, and pancreatic disease. Welcome, Dr. Yasser, and you could start, please.
Good morning, everyone. Welcome. I'm gonna rush through this talk because we're a little late on time. In this talk, I'll try to go over the indications for drainage in patients with malignant biliary obstruction, to explain the options available for us, and to give a kind of a critical appraisal. I'll be focusing a little bit more on the data, not showing videos. So as you know, most of the biliary strictures are malignant at the time of diagnosis, and they are associated with a poor quality of life, and only a few, or at maximum a third of them, will be resectable at the time of diagnosis. So usually our goal is to cure or palliate these patients, and we're very involved in the management of these patients, whether it comes to diagnosis, drainage, and follow-up. The malignant strictures can occur anywhere in the bile duct. This can be as high in intrahepatic, biliary, the bifurcation, distal bile duct, gallbladder, and reaching the ampulla and the head of the pancreas, of course, or duodenal metastatic disease. So what are the indications to drain? That drainage could happen in two settings that are really usually we talk about. We talk sometimes about pre-op drainage, a very controversial topic that will be going into some details here, and the palliation of unresectable cancer. Patients who are deemed unresectable, but we need to improve their quality of life and hopefully get them to get other forms of treatment, and we need to drain their biliary obstruction. The drainage options are mainly endoscopic, as we know, that's what we do, percutaneous, something we'll touch on, and surgical. Not much, I won't be touching much on this surgical because it's usually our last resort. So starting with pre-op biliary drainage, this is a discussion that's been going on for years and decades maybe, that whether we should actually be draining patients pre-operatively, patients who are deemed resectable and should be going for surgery, whether should we drain them and send them to surgery, or we just go straight to surgery. The possible advantages of drainage is to improve hyperbilirubinemia, which is usually associated with increased mortality and morbidity. Disadvantages is you might have increased rate of complications, usually related to the procedure, and you might be delaying the surgery if such a thing happens. Much debate, there were several reports and then some studies. The first RCT, which was published in the mid-90s, did not show any difference in morbidity or mortality. However, this was a small study that was not enough for us to make any conclusion. Again, the question here is whether a patient who's a surgical candidate should be drained or not. Then there was this landmark study by Vander Gag from the Netherlands, which was a randomized study which included almost 200 patients. Some were allocated to go to pre-op drainage and some were not drained pre-op. There was no difference in mortality. However, there was a higher rate of complications post-op in the group that went for pre-op biliary drainage. So the patients that went actually for pre-op biliary drainage had more complications, almost double, 74 versus 39. And the rate was, this included all complications, and the surgery-related complications were 47 versus 37% in the drainage group versus the non-drainage group. However, note in this study, there was a high incidence of ERCP complications, which was quite unusual for what we see. The complications were around 50%, including quite a few cholangitis, ERCP, pancreatitis, and even perforations. And of course, this is a study that was done in a very controlled setting that probably, we always argue, cannot be applied to what happens in the general population or in the general practice. There was a systematic review that looked at this issue, and that between draining and not draining, there was no mortality benefit. So if you drain or you don't drain, you're really not making a difference in mortality, in the outcomes of patients after surgery. And so far, we've seen that there is probably a significant increase in complications. So what about real life? This is our study, actually. We looked at the NASCIP data. This is a quality data from the US, and our institution is part of that looks at complications related to surgery. We identified almost 2,400 patients who with malignant biliary obstruction who underwent Whipple, so mostly distal malignant biliary obstruction. And these between the years 2014 and 2015, almost 80% had pre-op biliary drainage, and the rest did not. The post-op mortality was 3.0 and 2.2 among the direct surgery group and the PBD group, so that was not different. However, as seen in previous studies, we confirmed the data that there was a higher rate of post-op complications in the patient who went for pre-op biliary drainage. So this is the nice thing about this study is it confirms that what we suspected is actually confirmed in a large data set that covers a large population in diverse clinical and practice settings. These mostly included wound-related complications, sepsis, and pancreatic fistulas. The conclusion that pre-op biliary drainage is associated with a higher rate of complications post-op, but there was no difference in mortality. So to conclude this section, we can say that the pre-op biliary drainage seems to be associated with increased morbidity, but it should not be routinely recommended. However, it should be considered in patients who have significant debilitating symptoms, or if you expect a delay in surgery or intervention. And this should be individualized. So it depends on your setting. Some patients, some institutions, they might wait for 2 weeks, 2 months to have a Whipple scheduled. These patients should be taken as a case by case. Severe jaundice, I don't think personally severe jaundice is an indication, but I rarely see a patient with severe jaundice who's not debilitated and sick and malnourished. So it is usually the sick patient rather than the number itself. And of course, the patients who are scheduled to undergo neoadjuvant chemotherapy. These patients, this is an evolving concept, especially in pancreatic cancer. As you know, most of the malignant biliary obstructions are actually pancreatic cancer, because these patients, even though they would be considered resectable or borderline resectable, they would need to be drained because, of course, our oncology colleagues will not give them chemotherapy if they obstructed and have high bilirubin. The toxicity of the drugs would be higher in the setting of obstruction. And they will be at a high risk of cholangitis and other infections when they receive immunosuppression and chemotherapy. So the rationale here is to increase the probability of an R0 resection, complete resection, and target micrometastases, and as some would say, allow the bad diseases to show themselves. So you give them this few months of therapy, and those bad patients will show up, will show themselves. They'll come with metastases, and then you know, okay, good, we did not resect these patients. This is the bad biology tumor, and we shouldn't do a resection. In these patients, durable biliary drainage is essential, as I mentioned, to prevent complications and facilitate treatment and prepare them for surgery. To conclude here, for resectable malignant biliary obstruction, pre-op drainage is not recommended for surgically fit patients with asymptomatic jaundice. When performed, endoscopic drainage is preferred, and patients should have at least 4 to 6 weeks between biliary drainage and surgical resection to allow normalization of hepatic function. And it's, of course, mandatory in patients receiving neoadjuvant therapy. The second part of the talk here will be about patients who have unresectable cancer. These are the majority, and our aim is to alleviate symptoms. The interventions we have at hand here include ERCP, stent placement, what we all know as probably the first approach. EUS guided drainage. We had a nice demonstration of that this morning. Of course, endobiliary frequency ablation and other tools that we can help in the management of these patients. Endoscopic stent for biliary drainage itself, endoscopic stent placement is a preferred first line. It's been shown to improve morbidity and mortality compared to surgical bypass, which is quite a morbid surgery. And there is several meta-analyses looking at this issue, and that showed that there is an increased surgical mortality in the patients undergoing surgical bypass compared to those who have endoscopic resection. And the question we always ask with endoscopic is whether to use the metal or plastic stents. That's a discussion we always have. Sometimes we, especially nowadays, we have to incorporate cost, but in terms of the science, self-expandable metal stents are the primary choice for malignant biliary obstruction. There have been multiple reviews, and we know now, we can say with confidence that self-expandable metal stents have significantly less stent dysfunction, they have lower re-intervention rates, and they have better survival rates with a prolonged duration of patency. It's almost double, 250 versus 124 days when compared to plastic stents. So I think this issue is settled. When you need to, if you have the option, you should use a self-expandable metal stent. I understand that sometimes we still resort to plastic in certain situations, but when we have the option, it should be a metal stent. So what about plastic stents? It should be considered in patients with unresectable disease where you have a low life expectancy. You think the patient is not going to live more than 3-4 months. So a plastic stent, cheaper, you can use it and then not worry about it. However, when the plastic stent is placed for then 3 months, it is comparable to a metal stent and might be a better choice in this setting. The other question we ask is whether in terms of the metal stents, whether the covered or the uncovered stents are better. As a principle, uncovered metal stents are less prone to migration, but are difficult to remove due to tissue ingrowth. So fully covered metal stents, on the other hand, have a non-porous membranes coating, decreases the rate of occlusion, but at an expense of increased risk of migration. So this is always the issue we're trying to deal with and to decide on. Two meta-analyses have shown no benefit to survival of morbidity when using covered versus uncovered. So it really doesn't impact the long-term outcomes. However, retrospective study evaluated these two, the covered versus uncovered, showed that tumor growth with recurrent obstruction is more common in the uncovered stent, much more common, almost like 6-7 times. And stent migration, again, is higher in the covered metal stent. The partially covered metal stent represents a reasonable option where it is associated with less incidence of stent migration than the fully covered, and less incidence of tumor ingrowth than the partially covered. A few words about the hilar biliary stricture. I'm going to skip quickly. This is probably where we still have more difficulty deciding what to do. We know that in these strictures, we don't like to use covered metal stents because you might be occluding side branches or the other side. And we use plastic or uncovered metal stents. Sometimes when I'm not sure about the adequacy of drainage, I might elect to use a plastic stent and see how this is going. And then if the patient lives long enough, I will change it for an uncovered stent. This is a very, again, it's its own topic that needs a separate talk probably. And we prefer to drain both sides when we can, but sometimes we cannot. And the studies don't show like a really significant benefit of drain. It is better, but you can always get away with draining one side. A question that always comes before we go to our other fancy toys. What about percutaneous, PTC, percutaneous biliary drainage? As gastroenterologists, we now make it look like this is the bad guy. We always say there's more bleeding, infection, and repeated procedures. However, there is no clear data to support that. PTC, if you look at the literature, is not as bad as it sounds. Actually, there was the two studies I came across, both were retrospective. And remember, these studies that are retrospective are usually biased against PTC because you don't go to PTC unless you fail ERCP. So by definition, these are difficult cases. And one of them is actually by Dr. Khashab, which evaluated EUS-guided biliary drainage and percutaneous drainage and showed that the two are equivalent in terms of success and immediate complications. There was a high rate of interventions and delayed complications with the PTC, which you can expect. There is a drain that gets dislodged and there is a high rate of infection. Similarly, another study with a compared initial PTC versus ERCP and showed that the two approaches are equivalent. And this was done in patients with cholangiocarcinoma, higher cholangiocarcinoma. So PTC is still an option. If you have a good intervention radiologist, don't dismiss them. They can still offer you some help. Then we come back now to probably the most evolving concept in the field, which is the EUS-guided biliary drainage. Looking at the anatomy, this can be achieved through different three principal ways, like the direct intrahepatic, what we saw today by Dr. Khashab, where you go in, puncture the liver into a dilated duct and drain transgastric most of the times. The extrahepatic, a choledochoduodenostomy, or an EUS-guided rendezvous, where you actually pass a wire transpapillary and then you go capture it and finish your work from that side, from the normal orifice transpapillary. The rendezvous technique, it seems probably it's the simplest, but it is not technically. So what you do is you go into you go identify a dilated duct. Instead of doing all the work, you just pass a wire, transpapillary, leave it in place. You go down with an ERCP scope, capture that wire, and go inside and finish your work, place the stent, basically. That's what you're there to do. The intrahepatic, I'm not gonna, I think we had a nice demonstration of that today. Puncture the liver, the left lobe usually get into a dilated duct. The pictures I have here are probably easier than what Mu'in was dealing with today. And then you dilate that tract and put in a stent, usually a partially covered metal stent to establish drainage. And the third type of what is the choledochoduodenostomy, where you create that tract in the duodenum next to a dilated duct. That's what he was hoping to do, but then he had the cystic duct in his way, so he couldn't go that route. That probably would be simpler than going up. So this EUS guide drainage brought in a new player to the game, that lumen opposing metal stents, and they are being used more and more with to establish biliary drainage. Traditionally, we used metal stents, our regular metal stents, like what Mu'in used today. However, more and more, we're using more of these lamps, especially in the choledochoduodenostomy. So far, we don't have enough data to make a judgment to which one is better. However, there was one study I found which compared the self-expandable metal stents for choledochoduodenostomies with the lumen opposing metal stent, the Axis. It was not all Axis, but we're mostly, probably all of us are familiar with the Axis. So there was no difference between the groups in unplanned procedural events, clinical success, short-term adverse events, and overall survival. So we cannot say today that the lumen opposing metal stent or that our regular stents are better or worse. So EUS, to conclude here, EUS-guided choledochoduodenostomy after failed ERCP has equally high technical and clinical success with either LAMS or SEMS. However, you have to keep in mind that there might be issues related to technique and expertise and cost. The hot access it provides us with an attractive solution. It's a one step, one puncture. You go in, you put a stent, and you're done. But the cost is very high, and we always have to incorporate this into our decisions. So as we move toward more and more towards that US guided drainage, we still, what happened? I mean, we spend our lives training in ERCP and dealing with ERCPs. Are we gonna just drop it? Actually, so far, there are few studies that looked as ERCP versus EUS as a primary intervention. So not using EUS as a salvage, but using it as a primary. And among these studies, there were only 3 RCTs. And these showed actually that the technical success rate was high in both, over 90, close to 95%. The clinical success rate, meaning achieving what you're after, establishing biliary drainage, was also quite high in both approaches. So, and the adverse events were similar in the 2 groups. So if you go direct to US drainage or direct to ERCP, you probably will achieve the same results. However, here, and this word of caution, EUS guided drainage should not be a compensation for poor ERCP technique. It is not like, oh, I failed the ERCP, let me jump. We have to still follow our protocols. If you fail an ERCP, probably try it again. Look at what kind of expertise you have before you jump into that route. Maybe Maureen makes it look easy, but it's not as easy as it looks. So now, there are a couple of studies that one of them in the US and the other in Japan that are looking at LAMS as, so these people are saying, okay, we're not gonna do anything, we just go. We have a pancreatic head tumor, dilated duct, we're gonna go in straight, do put in a lumen opposing stent and get done, not even try an ERCP. And whether this will be the future or not, we'll wait for these studies to come out. To summarize all this, the drainage of malignant biliary obstruction is best achieved endoscopically. PTC is still an option. Haram, yani your good interventional radiologist should be given credit. Frankly, in our institution, we use them occasionally, but they usually achieve what we are after, and they have good results. So I'm not hesitant at all to go to my interventional radiology for a PTC. Unless clinically indicated, biliary drainage should be avoided in resectable disease. So really, if you don't have a strong reason and the patient is surgical candidate, go to surgery. Don't waste time. You get a pancreatitis in a patient with potential resectable cancer, and you regret it for the rest of your life. You delayed surgery maybe by 2-3 months. For unresectable disease, endoscopic options are many and continue to evolve. The best approach should account for patient factors as well as cost and local expertise. And thank you everyone for being here today. Thank you, Zahir, for putting this together. I know we're all suffering with all kinds of stuff, but when there is a will, we will continue and keep going, and we want to keep Lebanon alive. And this is Lebanon Alive is part of keeping Lebanon alive. Welcome, everyone.
Thank you, Dr. Yasser, for this great presentation. You have a question, Dr. Hassan?
Yes.
To drain or not. So the bilirubin level should take on consideration to drain or not before surgery.
Yeah, yeah. This is a good question. If you talk to the surgeons, they always give you numbers. They say 10, 15, 12. And what I trying to say is, when you have a patient who's high bilirubin, they're usually also sick otherwise. As a number itself, it doesn't mean much, but it's usually also associated with other more liver dysfunction, lower albumin and low albumin, more coagulopathy. So as a number, but you rarely see someone who's at bilirubin 15 and goes direct to surgery. But to use it as like just a set number, I think this is falling out as a criteria for resection or no resection.
Okay. Okay,
thank you.
Another question? Yeah.
If you decide to put a stent before surgery, metal stent did affect the feasibility of the surgery due to fibrosis, to inflammation. So I think the surgeon prefer plastic stent. What is your opinion?
So definitely, and this again, so if patient is going to surgery, then my first preference is no stent at all.
Let's say he will have neoadjuvant therapy, chemotherapy. Let's say that he will have neoadjuvant chemotherapy.
Okay, if he's going for neoadjuvant, then I try to use a metal or a covered metal stent that's as short as possible. So this would be my choice. Sometimes plastic is fine. Maybe 2 plastics also will get the job done. But with the option of covered stents, I think we have a few.
No fistula after surgery or
no
fibrosis.
If you talk to the surgeons, they say it doesn't bother me. Actually, it's the stent. These are all concepts that I've not really proven in practice, but we always worry about them. You're right.
Thank you, Dr. Yasser. Thank you all. We'll move to a break for 10 minutes and fast. You still have, okay. 11 and a half, we must turn back, go back for continuing the Congress. Thank you.
The FDA did post-marketing studies indicating a 5% rate of culture-positive scopes despite reprocessing. That's a huge failure rate. 1 in 20 patients is at risk. That's something that should really wake us all up and have us look at what we can do better and how we can redesign scopes. Disposable types of scopes will help, but it's not the long-term answer. Either the reusable scopes have to come out of something better, where complete sterilization is actually possible, or I think the future is going to lie with disposable scopes.
Clearly, where the field is going is towards use of single-use device. And the more we try and the more we get familiar with it, because it's going to be a game change for the field of interventional endoscopy.
Once I began the procedure, I completely could not tell I was using a disposable instrument. I forget I'm using a disposable scope when I'm working on this.
I think what we're living through right now is the beginning of a transformation in healthcare where we're going to look back 10 years from now and say, I can't believe we were using, scopes that we reused over and over again. So it gives us a nimbleness to address clinician needs. It gives us the ability to iterate on a pace that has never been seen before. And it manages some really serious problems in endoscopy in a way that no one's ever been able to do before.
So the fourth case, it's a case of 77-year-old male patient presented with bad breath dysphonia and recurrent choking since 1 year ago. Gastroscopy showed Zenker diverticulum at 17 centimeter from the dental arc with mild hiatal hernia. Barium swallow showed esophageal diverticulum, and MRI neck show esophageal diverticulum measured at 5 centimeter of transverse diameter by 2.8 centimeter anteroposterior diameter and extending over 5.4 centimeter of length. So poem will be done with Dr. Mu'in Khashab and Dr. Shaima Al-Kholi.
اوكي مرحبا. بشرفني انه اعمل هيدا البروسيجر مع دكتوره شيماء وطارق هون معي عم بيساعدني. عم نستعمل Olympus 190 scope with an Olympus 4 millimeter clear cap, and we see here a 5 centimeter large diverticulum, and this is the upper esophageal sphincter here, and then the esophagus. So the plan is to tunnel to the esophageal side and the diverticular side to expose the entire septum. So we're doing a Z-poem technique with the intention of exposing the entire septum. So the beauty of Z-poem is that it allows us to see the entire septum, and which results in a complete septotomy. So instead of tunneling like we did in the past here proximal to the septum and tunnel towards the septum, now we tunnel over the septum. The reason for that is when we did the hypopharyngeal approach, you can see this is a narrow area, so closure is difficult. This is a larger area here, so closure is much simpler. So Tariq, give me a little bit of needle here, and we're going to inject. Go ahead. Slowly. Inject. Good. Give me about 5 cc's. A little more, a little more. A little more. More. Okay, stop, kneel back, and give me the knife now. So we're gonna make an incision, and after the incision, we get into the tunnel. So here we're using the Olympus triangular tip knife. No, this the TT knife. Is this a TT knife? Knife, okay.
This is the TT.
Okay, so let's take the TT knife, please.
So
with the initial, we're going to do an incision.
Yes.
And that's going to be with endocut Q current. So the settings are 311. We're using the new Vio 3 as the microprocessor. So knife out, please. And we're going to keep it out, okay? No need to put the knife back and forth. We're just going to keep it out. خليها برا. Okay.
So speaking about Z-Poem, Dr. Ma'in, it's an honor to be with you today. We have published a multi-center study about Z-Poem with Dr. Ma'in Khashab in the Esophagus Journal, which is the official journal of Japanese Esophageal Society, regarding the conventional methods that we use to treat Zenker's diverticulum. We usually either it's a surgery, major surgery with correction of the diverticulum, or the conventional septotomy. So for each kind or for each modality, there is a drawback. Surgery is usually a very invasive procedure with in these old comorbid patients, and the conventional septotomy, there is a high recurrence rate. So we believe that the Z-Poem is a genius solution because you can expose the septum fully, cut the septum fully with a very minimal recurrence. Besides, it's a much less invasive technique than surgery. So now Dr. Moin, he has created the tunnel opening. As you can see here, there is a lot of vessels. And we entered the tunnel, and the septum is the white part inside the tunnel.
So here, so that we don't get lost. So this is the septum here, and we are on the diverticular side.
Yes.
It's a little bit asymmetric.
It's a bit challenging case because the diverticulum is large and vascular.
So this, I believe, is the diverticulum here. So let's see if we can just expose it.
Yes, so the view that we have seen from outside, the septum with the esophagus, which is the narrow part on the right, and the diverticulum, which is the wide part on the left. So we are going to see the same picture from the tunnel. So we are going to get inside the tunnel, dissect the submucosa on the diverticular side, then the esophageal side. Now we are on the diverticular side.
So here I'm using a spray coagulation.
Yes.
To make it a little more efficient. I'm injecting through the scope.
Yes.
I'm not using a jet knife or anything like that. Let's treat these vessels because I think they are affecting us a little bit.
Yes.
Bleeding is not a major part of this procedure, but of course, if we see anything like this, we have to treat it right away. We do have a coag grasper that we can use if needed, but we'll try to just use the knife.
So Dr. Moin, you prefer the TT knife for dissection?
You know, to be honest, you can use any knife. This knife is just faster. You know, but what I always say, you have to get used to a knife and just use it all the time. And here we're starting to see the septum.
Yes, excellent.
Do you guys kind of see it here?
Yes.
Okay, so what we're gonna do, expose the septum. so that the audience can see.
Yeah.
And then we tell them the plan. They can change into another room and come back, but I would like to show them the septum first.
Yes, okay.
So here is the septum. And to the bottom of it here is the diverticular side.
ممكن نجيب صورة ونفريز عشان نوريهم.
And on this side here is the esophageal side.
عشان النايف هنا مختلف. سبراي ما بتنفعش مع الهايبريد نايف.
Yeah, so what Shaima is saying, if you use the hybrid knife, you can use spray, but it messes up your injection port. It kind of closes it, so it's not made for that. So here, I'm just using so now we're on the esophageal side, right?
Yes.
So this is like regular phone. Always when we do myotomy or tunneling, we work on the surface of the muscle because we need to protect the mucosal layer.
Yes.
Because injury of the mucosal layer is a perforation.
Yes.
So for the sake of anatomy, so this is here is a septum. And to this side is the tunnel on the diverticular side, and on this side is the tunnel along the esophageal lumen. So you want to lengthen the tunnel to expose the entire septum, and then we start then closing cutting the septum, and then at the end mucosal closure. But here you see it's just tunneling along the wall, along the septum, and I'm using the spray coagulation, which can make it very fast.
Yes.
Not much vasculature here, so you can move relatively fast. So with the just spraying through the scope, you see Shaima, you can expand the layer, you can dye it blue. You really don't need
the injection.
Yeah, so I've done all my poems this way.
Yes.
Never used anything else, and it works well. You know, we described this technique like 7 years ago of using the channel of the scope.
Yes. It's really nice.
So now we're gonna come back. Can we take this knife out? Clean it, please, because it has a lot of coagulum on it. And now, so this is the incision. And here,
Bleeding.
Minor bleeding, it's fine. We'll control it in a minute.
Yes.
And this is the septum. So we expose the entire septum on this side here. We can either now start the myotomy or the septotomy, or just expose it a little bit on this side and then do the septotomy. So we're gonna expose it just a little bit. If you guys wanna show another case in the meantime and come back for the septotomy, we can do that. Okay, then they want us to continue. Shaima, will you start your septotomy now or do the tunnel on this side?
Actually, maybe we do like the old technique. So we expose the tunnel. Maybe we need to do some more dissection on the diverticular side. And the diverticular side needs to be complete because we have to dissect the same length from the esophageal side. I just have a question for you, Dr. Moin.
Yeah.
What do you think about doing an extended myotomy into the esophageal muscles after cutting the whole septum to ensure that there is no recurrence for the Z-point? What do you think about this?
Yeah, that's definitely what we're going to do.
Yes.
You know, there is really no limit to the extent of myotomy. And here,
Yes.
so one thing is, it's really harder to know the extent of how much you're gonna go on the diverticular side in terms of landmarks. So instead of continuing, I'm gonna show you that you actually do not need to form both tunnels at the, you just need some space. We can get the other knife now, and then you can continue. And so even if your tunnel is not done, you push the mucosa away, and then you can start.
Yes.
So now,
You're almost done on the diverticular side.
yeah, we're done. So now we're gonna do the septotomy.
نفريز عشان نوريهم الصورة دي حلوة قوي. نرجع ورا كده ونفريز نوريهم الصورة.
So now the next knife I'm going to show you is the SB knife from Olympus. Also, it is what we call it is the scissor type knife. So Tariq has now an important job of helping me orient this knife correctly. And so Tariq, let's open. Okay, keep it open, please. And so we're gonna grasp the muscle here. It's okay. سكر. Okay. فنحن هلا ما we're not gonna treat until we see what's going on. I think we're good. Okay.
Yes. So, Dr. Main, we usually use two types of knives in the poem. You usually do this?
I can do the entire thing with one knife.
Yes.
But I think it's good to just demonstrate this since we are in a teaching conference. But if you're in your practice, for the sake of cost, I think it's good to close. So here we're separate from the mucosa. We're using endocut Q.
Yes, this is very nice to show.
And while we're doing that, we're pulling.
Yes.
So this is important now. I'm gonna say is here. This is where I'm going to freeze a little bit. So here you see like a submucosal layer in the middle of the muscle. So this is where the esophageal muscularis propria proper and the diverticular muscle will separate soon. So the last thing you want is to not pay attention to that. You see muscle here and muscle here. And it's going to separate, open. So you want to make sure you're going to cover all this muscle.
Yes.
And this is something to pay attention to. And I'll show you in a minute what I mean by that. Close, please. So now you see both muscles here.
Yes.
Open. So I want to cover both. Close.
Yes, excellent.
And here, just some injection. So even, this is what I was going to say. You see here, even if the tunnel is not complete, it's not a big deal. Open. Close. Okay. So you see here how.
So you start coagulation, then cut.
No, that was just why.
Endocut Q?
No, just cut. Close.
So any questions from the floor?
So we see here how really a lot of separation, especially in these large diverticular.
Yes. Yes.
Yeah, I think we're almost done here. So just come back. We'll show you the end of the myotomy. Yeah.
So you're shifting to another room?
Yeah, we're shifting to another room. We're just going to complete the myotomy, and we'll get you back to show the completion. Close.
Go on.
Yeah, okay. Close.
No.
Okay, هلا هون شفت حتى لو even if the tunnel is not complete.
So there's a question here, Doctor, from Sherbini.
Yeah.
He's asking on cutting the myotomy from the esophageal side.
Okay. Yeah.
How we know that we come to the end of the septum?
Yeah. So there is a good estimation with that.
Yes.
And that's why you just do it a little longer. So we're still having some muscle here.
Yes.
Which means you're not done. Which means there's still some.
Yes.
Which means when you go to that kind of muscle, there's still more to cut. Open. But I'll show you how I figured it out in a minute. Close. But here we're not done yet.
Actually, the muscle itself changes when it comes to the esophageal muscles. You can feel that.
It can be very, very subtle.
Yes.
Open. Close.
So I prefer to use the scissor knife or IT knife. You can use it also. Or?
IT is great, yeah. Yes. So IT is pretty safe here because you can protect the mucosa nicely. Open. Close. See how I'm pulling so that we protect the esophageal mucosa. And we can just put some glue.
So This is very nice.
And once we finish this muscle here, I believe this is almost done here with this.
Just the final one.
Open, close. Open, close.
Dr. Ma'in?
Yeah, so here the muscle is done, and all what we're seeing here is the fascia. And this is the fascia that actually you don't want to go through. So, so here's some minor bleeding. We can sometimes just leave it alone, or like, why don't we get the coagulation grasper to show how we use it, and then we complete the myotomy on the other side. So here we're going to use the coag grasper to. So now in between, while I'm getting the coag grasper, I'm tamponating the bleeder with the cap. It's a minor bleed, but so that it doesn't affect our vision, it's good to do that. So we're gonna change, can I see the Irby, please?
Yes.
We're gonna change to soft coagulation.
Dr. Khashab?
خلاص تمام. We are done. Yes?
Yes, open. Close.
Yes, we can hear you. If there is any question from the floor.
دكتور خشاب إذا أمكن تشرح الأناتومي الأشياء اللي عم نشوفها عم تكون شوي غريبة لأنه البروسيجر ما بنعملها يوجوالي عادة مش كل الزملاء بيعملوها. يا ريت الأناتومي بتشرحوا لنا إياها أكثر والستبس اللي بدكم تعملوهم لنكون نحن متوقعين شو الستب الثاني اللي بدك تعمله.
اوكي هلا تعطيني دقيقة بس. Close. I'm gonna get the scope out of the tunnel وبشرح الاناتومي. Open. Close.
ممكن نكت كمان الوضع.
اوكي طيب حينقلوا بترجعوا بتجوا لعنا. هيدي هون.
Okay, the next case is a 44-year-old woman known to have congenital cardiac disease. She presented with acute necrotizing pancreatitis of unknown origin on January 2020. On February, infection of the necrosis, they did the open cystogastrostomy. On December 2020, abdominal CT showed complete resolution of the infected necrosis and a cystic lesion at the level of the uncinate process just below the papilla of 1.84 centimeter. So EUS FNA was done. It showed 3 centimeter pancreatic head cystic lesion, and the FNA showed a string sign negative. The CEA level was 420 from the aspirated fluid, and the amylase was 1000. So the differential diagnosis was mucinous cyst adenoma versus IPMN. The patient had portal hypertension with portal cavernoma and collaterals secondary to the acute pancreatitis episode. So Whipple procedure in this case was considered risky. So the decision was to perform EUS guided RFA for the pancreatic cystic lesion. As you can see here is the cystic lesion. And here is the EUS RFA probe. The RFA started here. So on May 2021, MRI abdomen was repeated. It showed decrease in the size of the cyst, now measuring 0.3 times 0.5 centimeter. On August 2021, MRI and MRCP were repeated. It showed increase in the size of the cyst, abutting the medial edge of the pancreatic head, measuring today 0.9 times 0.9 centimeter. The cyst shows high T2 fluid component with intrinsic low T2 intensity, possible debris, and there was a new cyst more anteriorly located, abutting the pancreatic head, measuring 0.8 times 0.7 centimeter, showing high T2 signal intensity. So now the planned procedure is EUS for assessment of the cystic lesion, the new one that was shown in the last MRI, and the one that we did RFA for it, and possible RFA for discussion by Dr. Zahar Humani and Dr. Muhammad Al-Nadi.
Assalamu alaikum. Assalamu alaikum. Good morning, everyone. I'm really honored to be with my friend and colleague, Dr. Zahir, again here in Lebanon. We are always glad to come back and see how things progress in a very positive way on a medical field, not on other fields. But I'm really happy to be with Zahir today. So this patient illustrates how EOS is beneficial for follow-up of pancreatic cysts and how we can intervene when the patient is inoperable. This patient has portal vein cavernoma. Her cystic lesion was previously ablated. As we can see, this is the scars in the pancreatic parenchyma induced by previous or prior radio frequency ablation. As you can see, these white spots, it's not calcification, it's scarring of the parenchyma induced by the previous radio frequency. Here is the track of the previous radio frequency ablation. It was very successful. So as you can see, the previous cyst is totally ablated. As you can see, this is the
You don't see your screen,
that
please.
was ablated
Show us your
prior.
screen.
And here, do you see with me the image, please? Do you have the endoscopic view?
Okay.
Okay.
خد صورة اليو اس. انا هلا شوف هلا ما عم يسمعوا وعم بيحكي معه حدا عم بيرد عليه. بس بليز هذا بس علمني كيف بيطفوا لانه انا اذا بدي اضرب بيطفوا ما يطلع صوت.
We are just trying to get the image of the US. Okay. So as you can see, the patient has a cavernoma in the portal vein. That's why she's inoperable. If I can show you the importance of the collaterals seen around the head of the pancreas and the cavernoma that is formed, as you can see, that's why the patient was recused on the level of surgery. Her best management, her best chance is to offer her Whipple surgery, but she was deemed risky, very highly risky, as you can see the collaterals and the cavernoma formation. We will just switch to Dr. Ma'in and we come back.
اوكي فخلينا نفرجيكم فهيدا الهايبوفارينكس، هيدا الزنكرز سبتم، هون الزنكرز دايفرتيكولم، وهيدا الاسophagus. فهون الايديا if you cut the muscle إذا شقينا المصل بين الدايفرتيكولم والاسophagus ساعتها ما بيصير في obstruction والfood fluid everything will empty readily into the esophagus. We use the tunneling technique to expose the muscle. هيدي هون fascia هلا. We don't want to cut this. And this is the muscle. And you see we went pretty deep and we cut a lot of muscle. So here now we're on the esophagus side. وهون submucosa muscle adventitia. One thing I was discussing with my colleagues here is that when you leave this much of mucosa behind, it may cause dysphagia. So what we've been doing is cutting this mucosa as well so that it doesn't cause obstruction. So although the muscle is gone, there's a lot of mucosa here. This is a 6 centimeter septum on my measurement.
Yes, yeah.
So I prefer to cut the mucosa. So we're going to do a mucosal incision here and then close at the end. It does complicate the closure a little bit, but I'm a believer that this needs to be done. Yes.
Dr. Ma'in, one question.
So you're going to go to another room. I
One
just
question,
wanted to show
please.
you completion of the ma'armi, and then you'll come back to see the end of the incision. Open.
One question, Dr. Ma'in, possible? When or how to decide the end of septum?
Okay, the next case is a 73-year-old male, states post-cholecystectomy. He presented with jaundice and abdominal pain with elevated cholestatic pattern. On May 2021, MRCP showed multiple stones in the extrahepatic biliary tree, reaching the proximal aspect of the left intrahepatic biliary duct, measuring between 0.7 centimeter and 2.5 centimeter. So the procedure will be spyglass guided lithotripsy by Dr. Ammar Ghazali and Dr. Mahmoud Halal.
Hello, everyone. How are you? So we started this case. So as she said, this was a case with a large stone in the left duct and multiple other stones. We started this case by taking out the stent, the existing stent with a snare. And now we introduced the spy scope. I'm going to show you, hopefully you can see the spy image up there. So the image to your right is the spy image, and you can see the large stone right in front of us, and this is in the left duct. So we're at the left main. Now our EHL probe is in there. So this is a Boston Scientific spyglass with an autolith from Boston and for electrohydraulic lithotripsy. And so the plan will be to zap this stone with electrohydraulic lithotripsy. And then once we get all the fragments out, we'll use an extractor balloon and remove the fragments. And if we need to, as part of Spyglass, Boston has various devices that will go through the Spyglass, including a Spyglass basket, a small basket that you can use for smaller stones. For other cases where we use Spyglass for strictures, there's also something called a Spy Bite, which is basically a small biopsy forceps that goes through the spy port, and we can biopsy directly in the bile duct. But this particular case, we're doing a stone. I'll show you the stone again. So you can see on the image how it's moving. Now you're going to see our catheter on the stone. You can see it right at the bottom of the screen. And then we're going to start giving some, and then you're going to see that everything will cloud up as we give our electricity here, okay? And then let's go ahead. Can we? It's not.
We can move. We can see the thing here.
Can we bring it closer?
Can you put the camera here?
بس ما لحظة ما عم بيعمل السباي. هلا ماشي الحال. Okay. So now you can see how it becomes cloudy. Spy? لا ولا. Okay, so we're waiting for the spy image. And we're breaking through the Let me know when we can see the spy. Are we still live or no? So if you can see the SPY image, we started breaking into the stone, which is a very tough stone. اوكي يلا ونحن لايف بعدنا؟
Yes.
اوكي يلا يطول عمرك.
بدنا لان ما عم تبين السباي هونيك
عندهم هن إذا بدك كبر السباي. اوكي لحظة. ايه هاي هي تمام.
هلا بينت عندكم؟
بين شيء.
ملاك بينت السباي؟
No.
والله صعب عليك.
كفي نحن لايف.
اوكي نحن لايف.
نحن بس ما عندنا الصورة تبع سباي جلاس.
If you can see the image here, the spyglass image, you can see that we started the green part in the middle as we were. Now we're going to do
we
some
had
more.
the image of the duodenoscope.
It's going to cloud, so you're going to see the image cloud.
Okay.
We have both images.
Okay, and then now we're going to continue. We're burrowing through it. It's a very hard stone. The catheter is going all the way through it, and we have to be careful not to go through the other side into the bile duct wall. So we have to be a little bit careful with that. So we're going to angle ourselves. Okay, perfect. I'm just going to change my angle slightly, and then change my angle. And then we're continuing to burrow through. Let me just move my scope slightly. Clear our image. We'll try a different. Sometimes it goes all the way through, and you still don't break the stone. But hopefully, as we get more angles off of it, and we continue to irrigate while we're doing this. So it looks like it's cracking in the middle. Okay, we've got pieces flying off. And we're just going to clean up so we can see better. So you can see now there's a shell. And we'll try to move up on it. Without losing our view here. Because we have some debris sitting next to the scope. That's why we're seeing that there. And we'll keep cleaning and keep monitoring it and observing it. We're still inside of it. and burrowing a hole through. I'm going to try to angle up again without getting, or down. Either way, just something to break through. Okay, let's continue to clean. And sometimes these take a significant amount of time working on them. And so, ايه يلا بناخد شوية وقت نحن وبنقول لكم الريزلت بعدين.
باينين واضح؟ احنا سامعيننا تحت؟
Okay. Yes.
Okay, this is the scarring, the scarring in the pancreatic parenchyma of the previous ablation. And here is the new cyst. Here is the new cyst. If we apply color, the big vessels on the left are the aorta and the IVC. So we'll be ablating the patient, and the only way to access that lesion was through the deep part of the second part of the duodenum, because she's having the color, just to make sure that yes, that there is no vessel in between, and try to avoid the major ducts if we can. So we'll try to take our time and get the best way . Here, there is no intervening vessel. Okay, so we'll apply the radiofrequency needle. Yes. We'll try to get the best view. Here we are avoiding the ducts, and we are avoiding the vessel. As you can see, it takes some time to get the good pain. It's already short. Yes, we are already. We are already shortened. We are already short. So here is the direct view to the cyst with nothing in between. With nothing between us. No vessel and no duct. We'll try to get this axis. Someone يثبت المنظار؟ حد يثبت المنظار؟ Yes.
small wheel big wheel.
Yes, we are almost inside. Yes.
Okay.
We are inside. We'll just try to get the view proper.
Okay. Yes. You can see the needle here. This is a needle. This is the same as an FMA needle. An active part in its tip, 5 millimeter active part. And as you can see here, the current and a cooling system.
So we are making sure that the active part is inside the cyst before applying, as you can see, inside the cyst before applying the radio frequency ablation. Here is the needle and here is the cyst. We can see it clearly that the needle is in.
We have to mention that this patient had received propionate NSAIDs as prophylactic treatment for post RFA pancreatitis and antibiotic to avoid superinfection after the procedure.
So we can start.
So now we can start the ablation. And
the benefit of this system is that it is automatic. So it will start. The what?
Okay.
Yes.
Okay. So now
the what is here. You have to. Okay.
Yes.
Okay. So the system is
now
automatic.
You can see the system run, and we stop when we see the bubble raise, or when the impedance, increase suddenly.
Yes. So the bubble, as you can see, the cyst is disappearing and there is a whitish material is formed due to coagulation and liquefaction. So we are ablating the cyst, and the benefit of the system is that there is auto cooling with 2 lines inside the needle, avoiding rise of temperature inside the tissue. So the needle is being cooled, the tissue is being ablated, and the needle is being cooled. As you can see, the microbubbles are formed, and the cyst is disappearing. عشان size. Size is not. There are several sizes, but the lesion is not very large. That's why we took the 5 millimeter needle. So it may take some time, but it's safer because the patient has collaterals and wouldn't like to injure any duct or vessel surround. So the cyst is almost disappearing.
Yes.
Is almost disappearing, as you can see.
One question, please. What is the immediate complication and how to prevent it?
We would like to avoid penetration of any ducts or vessel. There is, if you are approximate to the main pancreatic duct, you may apply prophylactic pancreatic stent. The rate of pancreatitis is not very high, less than 20%.
There is, for this kind of lesion, it's better to suck the cyst before doing RFA. But in this case, there is a small cyst, and I think if we suck the fluid, we can miss it after that.
As you can see here,
the ablation,
complete ablation of the cyst.
The only risk is the burning of the surrounding tissue. So to avoid that, this needle has a cooling system. You can see the cooling system here.
And if you can see, we are not far from the aorta, but we are pretty much confident because of the cooling does not transmit the energy to the surrounding vessels. So it's a safe procedure, especially in this patient. I will show you how the patient has a huge cavernoma and collaterals around the head. So that was her only chance to prevent further progression of the IPMN into malignancy. That's why we choose to do radiofrequency ablation. As you can see now, the white material is coagulated because of liquefaction of the walls of the cyst. So you are ablating the cyst in a safe way.
بس أنا بدي أشرح شغلة بعد هون. بالستدي اللي عملها مارك بارتيه على الاي بي ام ان we have two worrisome features. The first one, the increase of the diameter of the cyst أكثر من 5 millimeter last 2 years on هيدي الكيس and mural nodule. So the RFA permit to decrease the worrisome feature in 100% of the cases and to disappear the worrisome feature in 2/3 of the cases. هذا المسج. وهذه البيشنت inoperable. صحيح ان صبيه عمرها صغير سنها صغير بس there is no other solution.
So instead of letting her go to a highly mortal surgery, you can prevent the progression of IPMN just by doing ablation of the recurrences. So as you can see, the system has stopped automatically. So we will retrieve the needle. We'll retrieve the needle from inside.
Any question? Okay, we'll move to other room. Thank you.
Okay, thank you very much.
المفروض يكون واحد خايفين يعمل مظبوط عرفت كيف؟
ايوه جاتش الفكره ان احنا نعمل الاثنين في نفس احنا راجعين.
Okay, close. Okay.
Now we are back.
Okay, guys. So we did an incision of the mucosa. So the thought was that it's a very, very 6 centimeter diverticulum. So if we leave the mucosa, it's going to cause obstruction. So here we are using microtech clips. And we used first the Lucado clip, the 20 millimeter clip. It's the largest clip on the market, 20 millimeter diameter. So that allowed us to approximate the widest edges together. يعني مطرح ما الفتحة أوسع شيء كانت حطينا كليب ل 20 ملم قربت الميكوزا على بعضها ومن بعدها عم نستعمل 16 و 11 ملم مايكروتك كليبس. بهيدا المنطقة مهم إنه نستعمل مايكروتك لأنه شفتوا الستوك أو الستم قصيرة. هيدي في عندها 2 advantages. واحد إنه المريض ما حيحس فيها. واثنين it's a very crowded space. فإذا عم تحط كتير كليبس وطوال ما بقى فيك تشوف وما بقى فيك تجي تقرب على الانسجن. Open. فنحن هون هلا صرنا in the last part of the incision and we're using, is that a 60 millimeter clip? Okay, 60 millimeter here. And close, please. Okay, take it. So one more or 2 more. Yep. So 2 more clips. I like the clips to be very close to each other to cause ischemic injury or necrosis of the mucosa so that the rest of the mucosa retracts, scars down and retracts. Really, we only do this, mucosal incision and just aggressive clip closure with large diverticula. Most diverticula are between 1 and 3 centimeter. I don't believe you have to incise the mucosa. Once you get to 4 and more, then you probably have to. So this here now is the last few clips. Tariq is having your neck is hurting, Tariq, from rotating. No, don't, hold on. طب هون حناخد هون كثير مهم انه تكون مسكره كلها. ثقيله شوي هون لانه صار نزل لتحت الانسجن، فاللي فينا نعمله كلوز هون. اوكي. No, I don't like it. So مع انه هون مسكره بس في فتحه بتخبط.
ايوه
فما بدنا نعملها اوبن.
عامله ودنا.
ايه. فشيماء فيها تفسرها اكثر مني.
هي الادجز بقت انفيرتد شويه جوه فعامله ودنا.
ايه.
This is not classic for closing يعني. يعني احنا عندنا التو edges كده زي ما احنا شايفين في الاخر بقوا inverted to each other. ف this is not classic for closing. احنا we need to have the raw edges together. So it's a bit difficult here.
Okay. هيك عم بتفش هلا.
هنا حلو.
Okay, close. Okay, take it. And one more in between. الكبيرة. Okay, and we everted them.
Yes.
And we do that sometimes with regular poem where we'll have tenting, like a tent, مثل صار في خيمة هيك من تحت. فمن نعمل proximal clip to evert the edges and then complete the closure.
Yes.
هلا هون الكلوجر أصعب شوي من البوم العادي، بس يتعود الواحد على البوم closure. I think this is okay. Open. So this is hopefully the last clip. We'll take a look. Closed. Take it. Okay. Let's see.
Yes.
Excuse me, a question.
Okay, give me just 111.
واحد صغير. أزرق.
Dr. Mouin, do you hear us?
It's really nice.
So
really
what
nice.
we do in these cases, we admit the patients, we get an esophagram the following day, make sure there's no leakage, and then they can start on a soft diet. And we give them soft diet for 10 days or 7 days, not to dislodge the clips. Okay. If they eat solid food, they can dislodge the clips. And then the efficacy, which means patients really get better 95% of times. هون شفنا ما بقى في كثير وسع. Close please, close. Okay. Open. Okay. Close. Okay. Close. Yep. And we're done.
تمام.
That's it, guys. A lot of clips, but needed. ما وقفنا عد والله. يمكن شي 10 12. ليك هلا فينا ناخذ المريض لعمليه ويقعد جمعه بالمستشفى، بتكلف اكثر بكثير.
ايوه.
اوكي. 12. Okay.
ماشي. Thank you, Dr. Mouin.
Any questions or they move to another room?
I think they moved us.
Any question? Can you repeat, please, the dietary recommendation after the procedure?
لايف نحن لايف؟ اوكي يلا خلينا بس فرجينا السباي بيكتشر. سو فينا نشوف انه هلا بتشوفوا انه كسرنا الستون. رح كفي شوي تكسير. We were able to fragment the stone into pieces. It's a very large stone. And you can see إنه هلا صارت pieces. بعد في one piece شوي أكبر. We will try to get it كمان. Okay. هنعمل angling عليها. هيدي هالبيس اللي هون. Okay, and then we irrigate. There's an irrigation port to the spyglass that allows us to irrigate the, and then, okay, نحن live هلا? Oh, okay, yalla, perfect. All right, so now what we'll do after we have all these fragments, we'll try to remove them with a balloon. If we need to, we can also do a balloon dilation with a dilating balloon of the papilla and then remove the remaining pieces of the stone. But most of them are small enough where they should be removable fairly easily with a regular extraction balloon. Just going to continue fragmenting some of the rest of the pieces of the stone. But you can see that there are smaller pieces now, all broken. And shortly we'll just continue this a little bit, and then shortly we will use the, there we go. And then shortly we will use the balloon extractor to extract the fragments. I'm just going to continue cleaning here a little bit. And if anyone has any questions, I'm happy to take them as well. Okay. Okay, so we'll get the rest of this on DVD, and then we'll show it tomorrow in the wrap up, and you can see the final result after we're done with this, because I think they need to move off of the live now. Is that correct, Zahir?
Yes, yes.
Okay.
Yes.
لا بحكيها بكره.
Okay. Good afternoon. We move now to Janssen Symposium. I have the pleasure to introduce Dr. Philippe Sanyour, doctor in medicine from St. Joseph University, American Board in Internal Medicine, and American Board in Gastroenterology, fellow in gastroenterology from Robert Wood Johnson Medical School, Camden, teacher professor in gastroenterology at Faculté de Médecine, Université Saint-Joseph, head of gastroenterology at St. Joseph Hospital. He has multiple publications in the field of H. pylori, eminent speaker in many international and national congress, and Dr. Sanyour will present today a lecture titled Moving Forward with...
Well, before going serious, Misho اشتقت لك.
With confidence in IBD. Welcome, Dr. Sanyour.
ميشيل، قبل ما نفوت really seriously أنا اشتقت لكم كلكم أنت وريمو وحسن بهني لزاهر على هذا الكونغري. So it's really a pleasure to be with you guys. And now going back to serious, راح نروح completely from endoscopy to IBD. Do you hear me? ما عم تسمعوا؟
ما عم نسمع فيليب.
نحن عاملينها unmute. عم تسمعني ميشو؟
Dr. Sanyour, just a second, please.
Yeah. ميشيل.
دكتور سنيور بس في عنا just one thing عم نظبطه هون بالصال وبتصير معنا لايف just one minute.
شو البروبلم؟
اوكي دكتور تفضل.
ميشيل عم تسمعني؟
ايه هلا عم بسمع.
اوكي ميشيل، قبل ما ابلش سيريسلي بدي اقول لكم انتم كلكم اول شيء بهني زاهر مثل العاده على ان اكسلنت بروجرام، وكلكم انت ريمو حسن كل الموجودين انا اشتقت لكم كثير، بتامل نشوفكم قريبا. So having said this, we're gonna move to something completely different من يلي عم تعملوه. Let's share screen and نحكي عن شوية IBD rather than endoscopy. اليوم رح نحكي today we're gonna talk mainly about the place of one of the medication يلي unfortunately we're not able to find currently on the market يلي هي Stelara. But still, I hope that in the near future we're gonna be able to redo our medicine the way we used to do it before. 1 second before we share screen. في مشكلة بالشيرنج يا دموزيل.
ما عم نقدر نشوف السلايدات.
Okay. Are you able to see the screen now? Yes. Okay. So, اللي رح نعمله اليوم, we're going to talk quickly about our goals and treatment in CDUC. Just one word about Stelara and presenting to you the data on the long-term results of this medication in UC and CD, and a few slides about real world. That's going to take about 20 minutes. So hopefully you're going to enjoy that. So just to remind you that nowadays we're evolving in our treatment goals in IBD towards more and more aggressive goals. We used to accept remission, response as a good thing. Then we moved to something called steroid-free remission, mainly also endoscopic remission or improvement, but أكتر وأكتر هلا نيجي عم نروح على ultimate goals اللي هي reducing hospitalization, reducing surgery, restoring good GI physiology, avoiding any complication. And that's what we have, and if we follow the STRIDE recommendation, now we have STRIDE 2 recommendation, we see that we need to really be very targeting very tightly, I would say, our goals, and we need to use set goals in a set time to achieve that goal that we are putting for us. We need to have full remission, endoscopic and clinical. We need to have biologic remission, if possibly, with normal fecal calprotectin and normal CRP. We're moving towards also histological remission, which is very difficult to achieve, but still it might be the aim for the future. All this is done in order to get really the patients back to, if possible, to a normal life. Now, the STRIDE 2 fortunately gave us also a set time, because we cannot really do all this in a very rapid way. So we have weeks or months to achieve one and maybe years to achieve the others. But ultimately, if we could put the patient back to normal with a good quality of life, that's our aim. Now, fortunately, we know that 50–60% of our UC patients and about a third of our Crohn's patients will do fine with what we call conventional treatment. Now, the others will need what we call biologics or immunosuppressors. And we have first-line biologics that we are all good and aware of how to use the anti-TNF that has been for us present for the last 20 years. We know that we have good results with this, but we know that at least a quarter will have a lack of primary response. يعني من الأول they will have no response. And unfortunately, another third will have a lack of or loss of response after a year, and thereafter maybe 5 to 10% per year. So على المدى الطويل we're having barely 20–25% of response or remission with the anti-TNF. And that's mainly due to the immunogenicity. We know that at least 2/3 of infliximab and at least 1/3 of adalimumab will develop antibodies against that medication, and that will lead to the loss of response. So not only we have something called a change in the dynamic of the disease, meaning the disease could progress towards, but also we have a pharmacokinetic problem with the medication. Fortunately, within the last few years, we had medication that have less immunogenicity, being vedolizumab or ustekinumab or the new small molecules. Now, we all know that ustekinumab or Stelara is a medication that is directed against some interleukins that are important into the cascade of the downstream inflammation, blocking interleukin 12, interleukin 23. Although they are humanized or human immune globulin, fortunately, they have very few immunogenicity. We're all aware about the data in UC and in Crohn, the immunity and the Unify, and we know that it gives good results. Within the last year or two, last year and this year, we finally had the results on the long-term extension study, meaning after getting the results at the end of the typical trial, patients were followed for years in order to see how many of them retained the remission. And I remind you that this is the main problem with anti-TNF, the loss or the secondary loss of response over the years going down to 20–25% of response. So those studies are important for us. Now that we were able to put our patients into remission after a year of medication, how many of them will eventually give us headache and will need to move on to another medication after losing a secondary response? In the Crohn's disease, they were followed for 5 years, and the aim was evidently to see how efficacious was the medication, how many of the patients remained in remission, in mainly corticosteroid-free remission, and also to study the safety and if there is a development of antibodies throughout the years with this medication. And fortunately, as we see here, out of the people who at the end of the first year were into remission, and I'm talking clinical remission, and that was about 50% or more of the patient, almost half of them, or even more of half of them, were still on a medication and in remission. And that's if we use the intention to treat, meaning assuming that everyone that was lost to follow-up was a failure. So if we take all the patients who started and at the end we looked at them, we see that more than 50% on Stelara, be it Q8 weeks or Q12 weeks, and Q8 is obviously better than Q12, more than 50% of them were still in remission, and that assuming all the people who entered. Now, if we assume that the patients who were still followed up and we have registry on them, and we see how many of them were in remission, more than 75% were still in remission. So those are big numbers. 50–75% of people who at the end of the first year were in clinical remission remained in clinical remission after 5 years, meaning we're really much better than the anti-TNF in regard of maintaining the response and capturing the patient on the same medication. Definitely better in people who were on anti-TNF naive, were anti-TNF naive before the treatment, and that's common in all the medication, but also still 45% who had a TNF failure after they were put in Stelara, more than 45% of them remained in remission after 5 years of treatment. So that's good numbers and good news for our patients. And which is also even better, that the vast majority were steroid-free, meaning just on the medication. And you know that we don't need to give combination treatment with Stelara. We don't need immunosuppressors with it. So 88% of those 50% were on steroid-free, immunosuppressor-free, just one medication, maintaining the remission. That's mainly due not only to the efficacy of the medication, but also to the lack of the immunogenicity against this medication. Very few people develop antibodies against Stelara, less than 5 or 6% of people. And meaning that the patients who really fail the treatment are the patients who have a dynamic change in the disease, a change in the inflammatory cascade, rather than a pharmacokinetic problem with the medication. So we could rest in peace that we have really a medication that will not give us a problem unless the disease is changing its status. No safety problems after 5 years, so it's a very safe medication. Nothing appeared during those 5 years different than what was, let's say, discussed or was present during the first year. This year we have another 1 year, meaning the 2 years result in UC after the Unify. So after the first year of the Unify, those who were in remission or those who were not in remission but entered during the trial, the arm, the open label Stelara, were entered into this 1 year follow-up. And again, like Crohn, it was studied to see how efficacious it was. Just to remind you that really in UC, we have, after just one shot, a huge amount of responders. About 2/3 of people were responders after just the induction dose. And that allowed them to get into the trial, into the maintenance trial. And the vast majority of those people were in corticosteroid-free response or remission. And importantly, also at the end of the trial of Unify, half of the patients had really histopathological mucosal healing. Just a quick reminder of how important was Stelara in UC in the Unify trial. Now, those patients who were in remission at the end of the Unified trial, also they were studied to see how many of them remained in remission throughout the follow-up of this year, be it on Q8 or Q12. And also the safety and the immunogenicity was studied. And the results showed really impressive data, meaning the people who were at the end of that year in remission, as we see, the 50% were in remission, almost all of them remained in remission, meaning unlike Crohn, which is really an aggressive disease that could change really the dynamic of the disease, in ulcerative colitis, once we reach really remission, especially with Stelara as seen here, the vast majority of people, 80% of them remained in remission, and 90% of those 80% or more were in steroid-free remission. So once you put them on the right track after 1 year, those who were in remission, also you could really be in peace knowing that they will remain in remission and steroid-free remission throughout, as seen here, be it in the frequency of the stool or the subscore of Mayo School, throughout that year, really remaining flat. We have a flat line, no loss of response, no secondary loss of response. And that also mainly due to the lack of immunogenicity against this medication. Safety, same thing, no new signals, very safe medication. So over the 5 years follow-up in Crohn's disease and the 2 years in UC, that data showed that really the efficacy is lasting and the majority remain into steroid-free remission. The immunogenicity was very low and no new safety signals were observed. Now, if we move to the real world data, and that is important because the trials are not really your daily treatment, your daily patient that you see. There are a lot of data out there who studied Stelara in real world, meaning you enter patients according as you see them in your clinic, not as in the trial. And that will give you really a better sense of how efficacious the treatment and what to expect out of the treatment during the course of the disease. One of the largest study is a Spanish study called SUSTAIN. They entered more than 450 patients who were almost all of them anti-TNF experienced and failed. And they tried to see how efficacious was Stelara in this subgroup and how fastly efficacious it was. And as seen here, you can see that probably 40% 50% of them were really in response and remission after just 2 shots. So really a rapid onset of efficacy, and 50 to 60% between remission and response, or even more, in people who are really refractory or resistant to anti-TNF. An excellent choice even after TNF failure, be it using the Q8 or the Q12. In the sustain also, they showed that the safety is excellent and really very low rate of side effects, less than 8%. Only 4 of them out of the 460 had serious adverse event, and 70% of patients remained on the medication during the year or 2 of follow-up. So this is a medication that is efficacious even in very refractory treated patients. And again, those who were on the Q12, as it's done in Spain and Europe, also a lot of them remained on Q12 in this difficult to treat group of anti-TNF failure. We know that, at least myself in Lebanon, I treat every age, especially those who were anti-TNF failure, but even Q12 could give us at least 2/3 of response and remission. Another study is also from Spain in a very high refractory group of patients, as the NAIDA group, or the NAIDA study, showing almost again the same numbers of 50% response or 50% remission and 45% steroid-free remission. Big numbers, 50% all the time or more. And in this NAIDA study, more than 50 or 60% had also endoscopic improvement or endoscopic response. And that is important because we know the better we have endoscopic results, the better long-term outcome we'll have, and the remission will remain. Same in a different population, in a Finnish population. So that will prove that really it's not a genetical problem. It's across the board. It has the same efficacy with 70% of patients remaining on the medication after a year or so, meaning having at least a remission or a response. Now, comparing Stelara in real life or ustekinumab with vedolizumab, we have a couple of studies in Crohn's disease, one of them in the Netherlands, showing at least 15% better efficacy compared to vedolizumab. We have more than 60% efficacy response or remission after 1 year with ustekinumab compared to less than 50%, 45% of vedolizumab. And the same also in a French study showing at least a 15% difference between ustekinumab and vedolizumab, with again 50% or more remission and response up to 70% response. In UC, we have the Unify study that showed we have a lot of response after 1 shot. In real life, in the NAIDA study, after 1 shot, we had less than the Unify, but still a high response rate and a high remission rate. And in another Jadate study, it showed almost similar to Unify, about 50% response. But you could see on the right side graphs that in patients who are anti-TNF naive, the numbers are impressive. After just 1 shot or 2, you have 80% of patients who are responding and about 30–40% who are in remission. So highly efficacious in difficult to treat UC patients who are really resistant to all the conventional treatment. And we know that difficult UC patients are more difficult to treat, at least in my practice, than Crohn's patients. Once you reach biologic UC, it's really difficult to treat. And yet we have 80% of response with the shot or 2 of Stelara in that real world study published by the French. Now, comparing really monotherapy or combined therapy with immunosuppressors, this consortium, this multinational trial showed that Stelara, unlike anti-TNF and unlike mainly infliximab, does not need to be given in combination with immunosuppressor. And the efficacy is the same with or without. And that's mainly due to the lack of immunogenicity. So that would give us a medication that is really safe, that could be given alone without immunosuppressors. And when it gives results, it gives results without the need of steroids. The vast majority, once they're in remission, they are in steroid-free remission. So finally, I would just wrap up everything and tell you that now that we have for many years this medication, we have a new class of medication that has more safety, less immunogenicity, high efficacy. That efficacy was proven in the induction and maintenance trials of Unity and Unify in Crohn's disease and ulcerative colitis. And now I showed you that over the years, that efficacy and that remission is remaining, and there is really a little secondary loss of response compared to the anti-TNF, be it due to the efficacy of the medication per se or to the lack of immunogenicity of that medication with a consistent safety profile. And we know that it's really conveniently dosed. And that's the end of my talk, and I will be glad to answer any question if there is any. And again, اشتقت لكم and hope to see you soon.
Thank you, Philippe, for the nice and clear presentation. Any question from the audience? Philippe, do you hear us?
Yes, I'm hearing you.
Hi, Philip.
Hi,
It's
Habibi.
nice to see you.
Thanks.
Habib, thank you very much. It was an excellent presentation.
Thank you, Habibi.
I have some questions to ask. First, Stellara and extraintestinal manifestations. What do you comment about efficacy?
Well, till now, you know that we don't have the indication unless if you have a psoriatic arthritis or psoriatic skin lesion, mainly induced sometimes by anti-TNF. But we don't have really data regarding the what we call not mixed or not in relation to the inflammation extraintestinal manifestation, meaning the axial extraintestinal manifestation. But any manifestation that is in relation to the inflammation, peripheral arthropathy or arthritis, would respond once you treat your inflammation, your intestinal manifestation. So the axial indication, we don't have it in Stellara. We still have to rely on anti-TNF. And you know that we've talked a lot about personalized medicine, and each profile of the patient would need a medication. The extraintestinal manifestation, mainly the axial, is mainly anti-TNF for the moment. I can't hear you, Nadim.
Do you hear me?
Now I hear you.
Okay. Another question is Stellara and anoperennial disease in Crohn's disease. Sure.
Well, again, you know that the only evidence-based trial was in infliximab. Even adalimumab, which is the same class of medication, is a post-hoc analysis of the people in the trials of CHARM and the others. We have also post-hoc analysis or subgroup analysis of Stellara in the trials, and we have real-life or real-world efficacy, mainly the JATAID group and other groups that showed the same numbers of Stellara of, let's say, response or improvement or closure of the fistulas with Stellara, almost like the anti-TNF. And you know that numbers hover around 1/3 or 40%. So the real-life numbers and the subgroup analysis showed almost similar efficacy with Stellara, knowing that we don't have a trial designed to study this effect or this efficacy or this indication in Stellara. But personally, I just move someone who is failing with an anti-TNF for perianal disease to Stellara after reviewing those studies.
Okay. And finally, a question about head-to-head study with adalimumab. There is a study called CView. What do you comment about this?
Well, you know that CView just came out, and it was those who attended ECHO or those who attended EDW saw the results, and it showed head-to-head people who were naive to any biologic they were entered in the study. Really, let's say, not so difficult patients to treat, meaning they had their Crohn's disease only for a couple of years, never had biologics before, and they were randomized to take either ustekinumab or adalimumab. And it showed impressive results for both, meaning about 60 to 65% of the patients had, at the end of the study, were in remission, if I remember. So impressive results. The aim of the study did not show superiority unless if we go to subgroup of patients. And I think there will be a lecture regarding this with the Jensen people. Probably Professor Sands will give a lecture about this in a month or so, explaining everything about CView, showing that although it did not show difference at the end, there were subgroup people who had a better response or remission with ustekinumab compared to adalimumab. But what I take from this is, again, what I always thought about, that probably ustekinumab and adalimumab are excellent medications for Crohn's disease. And if I see the safety and the immunogenicity of both medication, and if I see the long-term results, I would probably tip over to ustekinumab, because I would remain on that medication after I attain that 60% remission or response with both medications. And also the message is, the earlier you treat, the better the results you're going to get. When you get 60%, that's excellent. And that's similar to the subgroup of people in the Unity trial who were anti-TNF naive and were placed on Stelara. So excellent results. Both medications are excellent. Early treatment, but we'll have to see on the long run, because one medication could give you immunogenicity and will need immunosuppressors, and the safety profile is not the same. You will have to choose between the medication. Personalized medicine again.
One last question.
Okay, hello, Philippe, monsieur. About the pregnancy, we know there is no study for the pregnant woman on Stelara. But what you do in practice when your patient gets pregnant and she is in Stelara?
Listen, you're right, and all the medications, anti-TNF, Stelara, all the medications, supposedly we have to stop them. You know that those are immune globulin that can cross the placenta, especially during the third trimester. There was a tendency at one point to give your last shot, I would say week 24, week 28, max week 30, and let the patient without a medication, and then after delivery, you could restart the medication, be it with anti-TNF, be it with ustekinumab, be it with vedolizumab, or all those monoclonal human or non-human antibodies. But we know that we have major registries, I would say, that showed that patients or female who remained on the medication throughout their pregnancy really did not have any problem for their newborns, or the newborns did not have any problem after the delivery. Just you have to really, let's say that the vaccines that are live, put them later on during the childhood rather than giving them immediately. But really the safety profile throughout the pregnancy of all those immune globulin medication did not show any problem regarding stillbirth or malformations or anything. So if your patient is stable and she could tolerate stopping the medication, and you could even adjust it, give your last shot, let's say at week 28, 30, meaning after delivery, that's 8 weeks, you will give it just after delivery. And if she needs it, you could continue it and know that probably it's going to be safe. All those immune globulin could be continued. You adjust your treatment according to how sick is your patient, because the sickness of your patient is worse as outcome for the newborn and the delivery rather than the medication. Michelle?
Thank you.
Thanks, Michelle.
Okay. Thank you, Philippe, for the nice presentation. Hope to see you soon.
Hopefully.
Bye.
Bye-bye. Take care, all of you.
Bye, حبيبي. Please 50 minutes break وبنرجع على اللايف. 50 minutes.
The FDA did post-marketing studies indicating a 5% rate of culture-positive scopes despite reprocessing. That's a huge failure rate. 1 in 20 patients is at risk. That's something that should really wake us all up and have us look at what we can do better and how we can redesign scopes. Disposable types of scopes will help, but it's not the long-term answer. Either the reusable scopes have to come out of something better, where complete sterilization is actually possible, or I think the future is going to lie with disposable scopes.
Clearly, where the field is going is towards use of single-use device. And the more we try and the more we get familiar with it, because it's going to be a game change for the field of interventional endoscopy.
Once I began the procedure, I completely could not tell I was using a disposable instrument. I forget I'm using a disposable scope when I'm working on this.
I think what we're living through right now is the beginning of a transformation in healthcare where we're going to look back 10 years from now and say, I can't believe we were using, scopes that we reused over and over again. So it gives us a nimbleness to address clinician needs. It gives us the ability to iterate on a pace that has never been seen before. And it manages some really serious problems in endoscopy in a way that no one's ever been able to do before.
The Acquire Endoscopic Ultrasound Fine Needle Biopsy device is a new biopsy device designed for the targeted sampling of submucosal and extramural lesions in the gastrointestinal tract. It's able to do this through the accessory channel of a curvilinear echo endoscope. The system comes with a handle and customized sheath similar to our Slimline family of needles. and it provides the same great performance you've come to expect from our products. What differentiates the Acquire FNB needle tip from FNA aspiration needle tips is its cutting surfaces. While other needles may only aspirate cells and perform minimal tissue cutting, the design of the Acquire FNB needle provides an increased number of cutting surfaces, thus increasing the chances of getting a visibly larger tissue sample for histology. This tip design is similar to percutaneous biopsy needles used in interventional radiology. The Acquire needle also has custom sheath sizes, designed to improve passability and help advance the needle out of the sheath. The 3 needle points are designed to afford greater control at the puncture site. They also provide stability to the tip at all times, allowing for easy penetration. To facilitate puncture and potentially minimize tissue tearing, the tip of the needle is electropolished, a manufacturing process that removes all imperfections. Aided by aspiration, as tissue moves through the needle tip, it's pushed into 3 symmetrical cutting heels. These are fully formed to maximize sharpness and cutting capabilities. In addition, these heels cut tissue from 3 different angles, making a more circular cut before it's pushed into the needle. Compared to the FNA needle tip designs, the Acquire needle is designed to capture a larger volume of tissue with minimal fragmentation. Along with the Acquire's optimized tip design, the system is also made of cobalt chromium, which delivers superior penetration and leads to less needle deformation than stainless steel alloys. The Acquire fine needle system features control zone and lubricomp on the handle for actuation, making it one of the most versatile biopsy devices on the market.
Janssen Immunology has been contributing to science and medicine for the past 23 years, providing innovation in molecules, formulations, devices, and even clinical trials designs. On the occasion of the World IBD Day, this year, 8 renowned IBD experts from Lebanon came together to share their experience with Janssen Immunology portfolio and showcase how the available treatments improved their patients' lives.
During the last 2 decades, Janssen has been playing a crucial role in the advancement of IBD therapies. We, as Lebanese Society of Gastroenterology, expect to maintain a fruitful partnership with you to offer our patients, through your innovative therapies, a better quality of life.
Let us travel back in time to 1998.
I remember the IBD patients that I used to see in my clinic when I was still a resident. As physicians, we really struggled to find the appropriate treatment for each patient. That's why we often opted for surgery, given the limited options that were available back then.
Fortunately, Janssen launched Remicade, which was a real breakthrough at that time. Honestly, I couldn't wait to initiate my patient on it and witness the great results seen in clinical trials in my own patients' lives.
Also, it was great to see that Janssen didn't stop there, but rather introduced Symphony, which is another innovative molecule offering UC patients the convenience of a once-monthly pain-free injection.
However, our patients were still asking, searching for treatment that better suit their needs. This is where Stelara came along, providing a complete solution for our IBD patients. I still remember how it changed the life of one of them who had Crohn's disease. He is a medical student who had almost lost hope, but had durable control of this disease till graduation. His family is still grateful and thankful till date.
As an IBD specialist, having in my disposition a large arsenal of therapies allowed me to provide a personalized treatment tailored to every specific patient. Now, with Stelara approved also in ulcerative colitis, we are moving our patients' experience to a higher level, especially if we provide them with a medication early on in their disease course.
Nowadays, looking at the current situation in the country and the massive challenges we are facing in the healthcare sector, it is not enough to have a variety of patients. However, we need to ensure patients have access to those medications.
Global guidelines highlight more and more the importance of considering the patient's status and preference while prescribing a medication. Therefore, it's our responsibility as physicians to take those into account in every decision we make along the patient journey.
And this journey continues.
Our patients rely on us
to provide them with the best possible solution.
We are all looking forward to what the future will hold with Janssen promising pipelines.
With this exceptional heritage, we are committed to standing by you, to break the silence around inflammatory bowel disease, and to support you and your patients in every step of the way.
Break the silence. Join our mission and give your patients their best chance to live free from IBD.
Peroral endoscopic myotomy, or POEM, is a new minimally invasive technique to treat achalasia of the esophagus. In patients suffering from achalasia, peristaltic function in the lower esophagus is impaired, and reflexive relaxation of the lower esophageal sphincter during swallowing is limited or not present at all. In order for food to once again pass unhindered from the esophagus into the stomach, the annular muscles are myotomized. ERBA provides the hybrid knife for POEM, a flexible, multifunctional probe whose distal end consists of an electrosurgical electrode with water jet nozzle. For all gastrointestinal applications, ERBA offers the gastroenterology workstation, which also includes the APC2 module for argon plasma coagulation. The POEM working steps: mucosal elevation, mucosal incision, creation of the submucosal tunnel, and myotomy are simplified with the hybrid knife. The mucosa is elevated above the initial esophageal stenosis. The raised mucosa is then incised to a length of approximately 2 centimeters above the stenosis using the hybrid knife's electrosurgical function. While alternating between the water jet and electric current, a submucosal tunnel can now gently be created with the hybrid knife. The surgeon can replenish the cushion during the course of tunnel preparation so that the protective function of the water cushion is ensured throughout the working step. Minor hemorrhages that may occur can be coagulated with the hybrid knife at any time. The required length of the tunnel is confirmed with an endoscopic inspection. Dissection starts around 3 centimeters below the incision point and is performed in a distal direction. The muscle fibers are cut to approximately 2 centimeters below the gastroesophageal junction. The opening of the incision in the mucosa is then closed with clips. The combination of the high-pressure water jet and the instrument's electrical functions reduces the number of instrument changes and hence the duration of the procedure.
شيء لك السكايب بس افتحها عندك.
واحد اثنين واحد اثنين واحد اثنين ثلاثة أربعة واحد اثنين ثلاثة أربعة خمسة ستة سبعة ثمانية. كيفهم؟ لا ما في شيء. كيفهم شيء؟ ألو 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 بس مش طالع. ألو 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 أوكي. ألو عم يطلع. خليك معي لحظة أحمد لحظة ثواني. أكدت عندك إنه محطوط شو اسمه؟ إنه محطوط هذا. شيل الفيشة أحمد. شيل الفيشة تبع جورج. إيه. ألو 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 ألو. One two one two test. 10 في تقطيش. واحد اثنين ثلاثة أربعة خمسة ستة 17 18 19 20 21 22. جرب يطفي. خلي يطفي ياخذ الاس ان جي. واحد اثنين واحد اثنين ثلاثة. ما في عم نعمل تيست. واحد اثنين تيست 1 2. الو 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 واحد اثنين 1 2 1 2. اوكي هلا هو لا اوكي خلص رح اطفي انا. هلا هو شيء الو ايه الو تشيك 1. شو عم تسمعني؟ الو ساتلايت هايبر.
يلا لحظة خليك معي. لك عندك كابل.
في الهايبر.
ايه
شو عم يصير عندك؟ Hello. Check. Check one. Hello. Hello. واحد اثنين. الو.
Good afternoon, everybody, for this first session of Libano Live in the afternoon. And we have the pleasure to welcome our colleague, Dr. Ammar Ghazali, for a conference on pulmonary adenoma diagnosis and therapy. Just to remind every one of us, we know that Dr. Ghazali is a gastroenterologist and interventional endoscopist and director of endoscopy at Clemenceau Medical Center. He has a special interest in interventional advanced endoscopic procedures and pancreatobiliary diseases. He is also an assistant professor of medicine at the Johns Hopkins University School of Medicine. Welcome to Dr. Ghazali.
يا نحن نقدمها نحن
عم بسمعنا هو قالت مش هنحكي معه هون.
دكتور غزالي
دكتور غزالي
دكتور غزالي عمار
من عنده ما بعرف ريتا هون، ريتا هون دايركتلي ما بعرف. عمار فوق بنبطية هون، ريتا هون ما شفتها أنا.
ما نسأل بس يا صوت ريتا.
إذا ريتا هون، ريتا هون كمان مش هون. ريتا لا، ريتا من بيتها من بيروت.
Okay, I want to welcome everybody back from lunch. And my name is Ammar Ghazali. I'm the director of endoscopy at Clemenceau Medical Center. And I was asked today by Zahir to give you a talk on the endoscopic management of ampullary adenomas. And so we'll go over some of the diagnostic aspects of it and certainly the management or the therapeutic aspects of ampullary adenomas. And I want to thank Zahir for the conference, which is always amazing every year. It's always a joy to be here. ويعطيه العافية إنه he was able to do it this year. So thank you للجميع for coming. All right, so when it comes to ampullary adenomas, they're not very common. The prevalence of ampullary adenomas lifetime is 0.04 to 0.12%. They usually occur later on in the 6th to 8th decade of life. And in the majority of patients, they're typically found incidentally. And this has been, we've seen an increase in incidence of these adenomas because of the increase in use of upper endoscopy, routine upper endoscopy done for other reasons. And visualizing the papilla and realizing that it appears abnormal, and then doing some further studies, whether with a side viewing scope or other, and we'll talk about how best to diagnose that. Occasionally, patients present with symptoms of jaundice, biliary obstruction, pancreatitis, and then even more occasionally, patients will present with a CT scan done for another reason where the bile duct and the pancreatic duct are enlarged with no obvious mass in the pancreas, and we do an endoscopy to take a look and we find a polyp or an adenoma present. They can be sporadic, and this is the majority of cases. And occasionally we see them in patients with familial adenomatous polyposis. They're very common in FAP patients. So what is FAP? As you all know, familial adenomatous polyposis is an autosomal dominant mutation in the APC gene, which is a tumor suppressor gene, and a mutation in this allows for growth of polyps in the colon and elsewhere. Colonic polyposis obviously leads to a very high risk of colon cancer in a lifetime, which you're well aware of, approaching 100%. And so really a lot of the focus of primary physicians and even oncologists is on the colon, but they fail to realize that really the duodenum is the second most common site of polyp formation. And so the likelihood in some studies is approaching 100% of developing a duodenal adenoma, not an adenocarcinoma, but at least an adenoma. There's about a 100% chance of developing that over a lifetime. So certainly it's something where screening and surveillance needs to be done for these types of situations. The typical onset of duodenal adenomas in patients with FAP is typically about 15 years after colonic polyposis. And the risk is about 100 to 300-fold in increase in the risk of duodenal adenocarcinoma when you compare it to the general population, which it's already quite rare in the general population. So the ESGE guidelines recommend that patients with FAP have an EGD at age 25, and then the follow-up of that is based on the polyp characteristics. There's something called the Spiegelman score, which looks at the number of duodenal polyps, the histology of the polyps, whether villous or tubular, and the size of the polyps. And then based on these, there's a score, and that score will determine when the follow-up is. So when we're talking about diagnosis of these types of polyps, how often do we see the papilla with a normal standard upper endoscopy. There was a big Korean study that looked at this where there was about 49% photo documentation of the papilla. But this again was photo documentation in a large group of patients, about 100,000 patients. And it was not done specifically to look at the papilla. We think that the rates are probably higher than that, approaching 70, 75%. And this visualizing the papilla has been proposed by some people as a quality measure, as part of a quality measure of upper endoscopy. So if you visualize an abnormality, then where do you go from there? Obviously a duodenoscope is a good option, but what about cap-assisted endoscopy, adding a cap to a standard upper scope? There have been studies looking, non-inferiority studies looking at cap endoscopy. Some of these studies have shown that it's equivalent to duodenoscopy, and then other studies have shown some inferiority compared to duodenoscopy. But what we would recommend is basically if you are not comfortable with placing a duodenoscope, you should consider a cap endoscopy as an initial measure to get a better look at the papilla. So what about with the diagnosis? Biopsies are considered mandatory in this setting. So we don't undergo any intervention on the papilla without having biopsies that prove that what we're dealing with is an adenoma. We'll talk a little bit more about that because this could represent other possible etiologies of a polypoid-looking ampulla, including gastric heterotopia or even pancreatic acinar heterotopia as well. So the accuracies of biopsies are not perfect when we take them of the ampulla. They're anywhere from, in some studies, for 38, 40%, up to 90% in other studies. And we have two problems. You can either underestimate pathology or you can overestimate pathology. When you underestimate pathology, that means that you have an adenoma present and your histology came back negative, or you have an adenocarcinoma present and your histology came back as an adenoma. So you're underestimating what is there. In situations where you get a negative histology, it's certainly important to have close follow-up of these patients, repeat sampling of the papilla with repeat biopsies, and you could even, in some cases, consider a small sphincterotomy to unroof or uncover an intraduodenal portion of the bile duct that might have adenoma in that portion of the bile duct. Even EUS with an FNA of the ampulla might be reasonable in some cases. And in a recent study done just in 2020, 11% of patients undergoing an endoscopic ampulectomy for an adenoma had foci of carcinoma present. So certainly something we need to be aware of in terms of overestimation of pathology. And I think we've all seen these where you get a diagnosis of an adenoma, you do an ampulectomy, and then you get the tissue back and there's no adenoma, it's just ampullary tissue. And so this is something that is thought to occur in about 15% of cases, and it can lead to risky therapy. An ampulectomy is not a simple procedure. And so it's very important in these situations to communicate closely with your pathologist, to get a second opinion when you feel it's indicated, and to repeat sampling if you get any discordant results from your initial biopsies. What about staging and finding out whether this is something that can be removable? We'll start off with what is the role of endoscopic ultrasound in this setting. There's a meta-analysis that was published in 2014. This was 14 studies, 422 patients, where they looked at the role of EUS in T-staging initially. When it came to T1 lesions, it was the pooled sensitivity was about 77%, and the specificity was 78%. When it came to T2, it was very similar to that. In more advanced tumors, also noted to be somewhere in that same range, 78, up to 77%, and then in T4 lesions, similar numbers that we're looking at. So reasonable numbers in terms of staging for T-staging with EUS. What about nodal staging with EUS? Also reasonable numbers, somewhere in the range of 70% sensitivity, 74% specificity. But again, this is without the use of FNA. This is just the characteristics on EUS of a lymph node or the presence or absence of lymph nodes. So if you add FNA to that, certainly the specificity would increase in that setting with a good area under the curve. So what about alternate strategies to stage these patients? MRI, CT. There was a study in 2009 that compared, a small study, but this is really the only one out there, with EUS, MRI, and CT in terms of accuracy in T staging and N staging. If we look first at T staging, you can see that EUS was superior to both MRI and CT in T staging of these patients. What about N staging? Really, MRI was the superior one here, though this wasn't statistically significant. But again, this is a small percentage of patients. So certainly MRI, MRCP can be helpful in this setting as well. So when we look at the ESGE guidelines, which I highly encourage you all to take a look at, these were published this year, 2021. They recommend endoscopic ultrasound and abdominal MRCP for staging of ampullary tumors. And that's a strong recommendation, but really based on low quality evidence. And as you can see, I showed you, these are all meta-analyses of retrospective studies. Unfortunately, we don't have anything more than that at this point. I didn't talk about intraductal ultrasound, but intraductal ultrasound can be helpful in select patients with ampullary tumors. It requires expertise. There are some risks with it, including a high risk of pancreatitis in these patients. And so the routine use of this should be really balanced against training, the cost of the procedure, and the risk of developing pancreatitis afterwards, which could delay your entire procedure. And so, you know, it's only if you have the expertise for it, and not a strong recommendation there. So endoscopic ampulectomy is a minimally invasive technique, and it's essentially endoscopic resection of the ampulla by snare cautery. And it was initially described in 1993 by Binmoller's group in California, and it evolved into the gold standard for resection of superficial lesions of the ampulla of Vater, and this really has replaced surgery in many of the patients that we see. And this is an example. You can see here the snare resection of the ampulla before and after. So what are the indications? The lesion is preferably less than 4 centimeters, because if it becomes larger than 4 centimeters, it becomes difficult to resect completely, and the risk of complications increases exponentially. Intraductal extension, most people would say more than 1 centimeter, you should consider going to surgery, but 1 to 2 centimeters is a gray area. Certainly if there's 2 centimeters of intraductal extension, it's preferable to consider surgery, even in the presence of current things like radiofrequency ablation of the bile duct, or the intra-duodenal portion of the bile duct with the Habib probe. Obviously, we need a lack of adenopathy. If there's adenopathy present, then that could be concerning for the development of an adenocarcinoma, and there should be a lack of invasive adenocarcinoma, though there are some small case series of T1A lesions being removed with close follow-up with no recurrence, but that's not currently recommended. One relative contraindication would be the presence of a large diverticulum. As you can see in this image, if you have a large diverticulum with the papilla present within the diverticulum, it would be extremely difficult to remove this, and be sure that it's been removed completely without a higher risk of complications as well. So what about the technique? The preference is en bloc and not piecemeal, but this is not always possible, especially with laterally spreading adenomas that spread off of the papilla. It might be more difficult to remove these with an en bloc resection, although we always recommend that we try to do this, because there is an increased risk of recurrence in polyps that are removed piecemeal, just like you would see, for example, in the colon. Submucosal injection. When we first started doing these, we were doing submucosal injection, but with time we discovered that it sometimes made polyp removal more difficult off of the ampulla, because the area around the bile duct and the pancreatic duct will not lift well because of the presence of the muscle layer there. It will not lift well with submucosal injection, and it'll cause a sort of a crevice or a divot, and that makes it more difficult to remove with a snare afterwards. So currently it's not recommended because of the lower chances of having an en bloc resection or a complete resection in that setting. What about the type of snare? There's really no consensus on the type of snare in this setting, and it's really what you're comfortable with. We prefer not using the braided snares, but using a regular snare. And in terms of the cautery, you know, everybody uses something different. I typically will use EndoCut Q with Irby and Effect 3, but that might vary based on. But we usually use a blended current and not a pure cut current, because of the increased risk of bleeding with a cut current. And then adjunctive techniques for incomplete resection. So if we have an incomplete or a piecemeal resection, then we should consider APC if it's externally within the duodenal wall, and we can also consider RFA of the ducts if there's intraductal extension, and that can be done at the time of the initial procedure or at the time of follow-up procedures as well. So what about the results of studies looking into this? There have been multiple retrospective studies looking at ampulectomy. The results of these studies were reviewed in a meta-analysis that was published just last year. And this was a meta-analysis of 1,450 patients, 29 studies. And they looked at a lot of different, it's complicated in terms of what they defined each thing as, so I won't go over all of these. But mainly they had a complete resection in about 94% of patients, complete resection meaning it was whether piecemeal or unblocked, an unblocked resection rate of 76%. A curative resection means that it did not recur within the time of follow-up, and that was at 86%, and that could have been one or more sessions that were required, and recurrences of 11% in that setting. These other aspects of endoscopic retreatment and endoscopic were not well defined in the paper in the meta-analysis. What about adverse events? Bleeding occurred in about 11% of patients and was usually controlled endoscopically. Cholangitis in 2% of patients. Perforation occurred in about 3%, 2.8%, and papillary stenosis. Pancreatitis occurred in 11.4% total, but if you look at the difference in pancreatitis rates with stenting, it was 6%. Without stenting, it was 18%. So certainly the recommendation in this setting is to place a prophylactic, at least a prophylactic pancreatic stent after doing an ampulectomy, and that's a strong recommendation. The overall adverse events were somewhere in the range of 24% in these studies. I'm going to show you a video now just to sum up. This is a case I did recently, and I'll sort of walk you through it. Hopefully you can see my cursor here. So this is the lesion kind of starting from here, extending up, and it's about 2.7 centimeters, the lesion. This was a fairly large one. And then we did the EUS aspect to look at the pancreatic duct and the biliary duct here, and to determine basically that there was no extension into the pancreatic or biliary orifices. You can see this is the lesion here. We're getting a little bit of a lag. Okay, so there is the lesion. Now we're going to try to cannulate. We like to cannulate the ducts first to figure out where our ampulla is exactly, and to make sure that we have no significant intraductal extension in the pancreatic and biliary orifices. And you'll see a cholangiogram now for that. And there's a cholangiogram showing no extension. The snare, I usually like to put the snare proximally and then sort of ride it down and let it spread open, as you can see here. So, and then we try to fit it around the entire polyp to try to remove it in en bloc. The blue discoloration down there is off video. I had injected down farther on the portion that was not on the papilla, just to lift it towards us a little bit, and that was a duodenal portion. And I injected that just to bring it closer and allow for a better removal. And then once we got beyond the polyp, which is about right here, then we will tighten the snare here. And then we use our cautery. We make sure to sort of shake it and make sure that it's separate from the duodenal wall. And here you can see that I'm cauterizing the lesion, shaking it to get it off the muscle layer. And then I leave it there and immediately place a Rothnet, because the last thing you want is to lose your specimen down into the duodenum. So you can give glucagon before for that, which might help a little bit. But most importantly is to have your Rothnet ready to immediately remove the specimen. And then you can come back and inspect. And obviously here's the inspection area. There's a small area there that was subsequently treated and removed as well. This is a pancreatic stent being placed. And so this is a single pigtail pancreatic stent with no internal flanges. So just a pancreatic, prophylactic pancreatic stent that was placed. Some people place biliary stents. I typically don't, but I will cut a biliary sphincterotomy to allow for drainage and to avoid the risk of cholangitis and papillary stenosis. And here you can see the 3-centimeter lesion removed en bloc and sent to the pathologist. And this came back as a tubulovillous adenoma, and the patient on follow-up had no further recurrence. This is from the ESGE guidelines, and I'll just go over this. This will be the last slide. So if you have a suspected ampullary tumor, you start with a side viewing endoscope with biopsies of this, and you could do immediately an EUS and an abdominal MRCP at the time. And then let's say you do the biopsies. We'll go first. Let's say your histology is negative and it just comes back with ampullary tissue. You don't want to leave it at that. You want to consider if the papilla is enlarged, follow up at 3 months, further biopsies, and then consider even an EUS at the time. If you have an obstructive tumor, then you need to be a little more aggressive. So if the liver enzymes are elevated, you're not going to leave them 3 months. You should consider further intervention with either an EUS FNA as a start, which is usually what I start with. If I don't get anywhere with that, I'll consider an ERCP with a sphincterotomy to open up the sphincter and then take biopsies from the inside of the sphincter. Now, let's say we do have an ampullary adenoma on biopsy and intraductal extension is less than 2 centimeters, then this would be something that can be removed endoscopically. If it's an adenoma with just low-grade dysplasia, here they say further biopsies. What they mean is basically be sure of what you're dealing with, because sometimes you'll get adenoma back, but it's not truly adenomatous tissue. So have another pathologist look at it and make sure that that's what you're dealing with before you send the patient for an ampulectomy. If you have high-grade dysplasia, then it's fairly clear that that's what you're dealing with, and you should consider going ahead with a papillectomy. And then if you resect it all in one piece with an R0 resection, then you follow up at 3 months with a side viewing scope and more biopsies. If it's not an R0 resection, then you might consider complementary techniques like APC, EMR, RFA, things of that nature. If you have TIS, meaning you have carcinoma that's mucosal, then you need to think about what you're going to do next for this patient. Are you going to consider a transduodenal ampulectomy or just follow up if you have no residual disease? There's no clear guideline on this. It's really your level of comfort that's important, your level of comfort with a full resection in that setting, and also the patient's status. If it's a very young patient and you want to be sure, then you should consider sending them to a surgeon at least to be evaluated. And then if you have carcinoma in it or intraductal extension that is more than 2 centimeters, then you should consider alternate therapy, or if there's a diverticulum that's present. And then you consider if it's an early lesion on EUS, you could consider a transduodenal ampulectomy. If it's a more advanced lesion on EUS, then you should send the patient for a Whipple. As I said, this is present in the guidelines from the ESGE, so you should consider looking at this. It's a very good paper that reviews all of this. And if we have time for questions, I'm happy to take them. And that's the end of my slides. Thank you.
Thank you. Thank you, Dr. Ghazali, for this very clear presentation on this topic. Any questions from the floor? Dr. Akush?
Thank you for nice presentation. I have a question about the estimation of extension of the disease. How can I estimate the extension intraductal? So echoendoscopy is enough to estimate the intraductal cells or intraductal ampuloma?
Yeah. تعيد السؤال, please.
My question is about the extension intraductally. So how can I estimate intraductal ampuloma?
By EUS.
How can you estimate the intraductal ampuloma extension?
It's a combination of using EUS and using ERCP for this. So usually we it's a combination of both of those that will tell you. When you're doing the ERCP aspect of things, then you can measure it based on your measurement of your scope size, which is going to be 10, 11 millimeters, and then you measure based on that. And on EUS, you can measure it fairly easily, the intraductal extension.
Thank you, Ammar, for this nice presentation. I have an anonymous question here. Did we need to clip the stent to prevent migration?
No.
Do you hear me?
Can you repeat the question, please?
Okay. Anonymous question. Did we need to clip the stent to prevent migration in case you put a stent? It's a question
the pancreatic
on the web.
stent?
The pancreatic stent, I guess. Do you clip the pancreatic stent in order to avoid migration?
No, and I typically will put a prophylactic pancreatic stent with no internal flanges with the realization that it's going to migrate within 48 hours. Now, there are others that advocate for putting a stent with internal flanges for a few weeks because of the theoretical risk of stenosis of the pancreatic orifice. Although I haven't seen this in practice, and so I typically will use a prophylactic stent that falls out spontaneously in 48 hours, and then I do definitely an X-ray 5 days later to make sure that the stent has migrated. And I'm being told we need to move to the live now, so we're gonna transfer over to the live room.
Okay, I have a question, Dr. Ghazali. If in case of non-conclusive histology and we need to repeat the sampling, does this cause harm to the further resection after that, as in the case of polyps, for example, of the colon? Do we have more fibrosis and more difficulty to resect the ampuloma and more complications? Dr. Ghazali?
رضوان زاهر معك. Sorry, we need to move هلا للثيرد لايف.
Okay, we will move. So we have the first case about a pancreatic cyst. This is Zahir, pancreatic cyst with EUS evaluation and assessment.
عمار بعده معنا يا زاهر؟
رضوان شباب، نحن هلا بدنا نطلع على اللايف الثالث.
Okay.
يلا سامعينك. Okay.
We are ready. We hear you.
Hi again. This case is a 40-year-old female patient that post sleeve on 2014. She complained of recurrent chest pain and dysphagia for liquid. Barium swallow showed distal narrowing associated with dilatation of the rest of the lumen and stagnation compatible with achalasia. Esophageal manometry showed type 2 achalasia, and gastroscopy showed dilated esophagus with stenosis at the lower esophageal sphincter. So POEM for achalasia will be done by Dr. Mu'in Khashab and Dr. Muhammad Al-Sharbini.
أنا هون مع الدكتور شربيني وعلي خلينا نعمل انجكشن. هيدا الاسافجس نشوف إنه dilated وبنشوف هون بس يكون dilated بتصير تشوف السباين impression على الاسافجس. مطرح ما بيعمل بولينج الفلويد هو البوستيريور، المريضة نايمة على ظهرها. هون شوي tortuous منه straight. Typical changes of achalasia. نرجع نشوف هون ال LES وفي pop sensation here where we because of LES resistance. هلا surgical teaching is that you should do 6 centimeter myotomy on the esophageal side and 2 to 3 centimeter on the stomach side. It's very important to make sure you have adequate myotomy on the stomach side. So here I'm going to go anterior. We did a randomized trial comparing anterior and posterior. There's no difference in terms of outcomes. So I just gonna choose posterior here. Needle out and inject slowly. Go ahead. Inject now fast. Inject fast. Good. So this is submucosal injection, just saline and a blue dye. Gonna inject 10 cc. gonna inject كلها عليه. Methylene blue and saline. اعطينا ال TT knife please. TT knife. اوكي وهلا دغري حنجيب ال TT knife ونعمل longitudinal incision.
The TT knife is your
هيدي مهمة نعملها دغري.
Dr. Khashab.
Anterior, Yep, anterior. Yeah, it's my go-to knife here with esophageal poem. It's made for poem, and I think it makes it very fast and.
No connection.
So here we're using endocapsule current, making a longitudinal incision. And here we're just gonna inject. So as you saw, I went into exactly the same spot where the bleeding was. Out, keep it out, please. Don't put it in the back end. So here, just some spray coagulation to create more space.
So Dr. Moeen opened the tunnel using endocut Q, using new device RB-Vice 3 with setting effect 3, duration 1, and interval 1.
Yeah, and I think if you don't want to use endocut Q, the other current that really works well, and you guys do a lot of ESD, so you know, is a dry cut.
Yes, with mucosal entry.
With mucosal entry, yeah. So it may also cause, I think, even less bleeding.
Yeah.
In patients with long-standing achalasia, we see hypervascularity, and we see.
And also the submucosal space may be.
Yeah, here, you know, we're down to the muscle level here.
Yeah.
So we're just gonna do a little bit of cutting here. Now this is just really, we call it trimming, this step.
Yeah.
It's basically just creating some space. And here I'm gonna use the cap to go right, left, and get into the tunnel. So we are not fully inside the tunnel, but kind of. So we work from a little bit from outside, creating more space before we get into the tunnel. I'm not going to worry too much about bleeding inside. The scope and the cap will tamponade these little bleeders here. So now, importantly, is the most important step of submucosal tunnel is to do the tunneling on the surface of the muscle. So here in a minute, once I'm stable, I'm going to show you the anatomy.
So orientation is very important.
Yes.
You know, the muscle side and the mucosal side.
So do you want to tell them where the muscle is? And so here clearly we see the whitish structure there at 12 o'clock. That's the muscle. And I'm going to stain these fibers blue so that we can differentiate muscle from submucosal fibers. And here we're using spray coag, which is a method of a non-touch cautery, non-contact cautery, which means you can really do it efficiently. So I'm tunneling on top of the muscle. So the idea is to expose the muscle, and after that, cut the muscle. So if you see little bleeders like that, you can just spray them. These are very minor vessels. Same as you do with ESD, you just use your knife to cut small vessels or to coagulate small vessels. If you have larger vessels, then you use the coagulation forceps. So here the idea is to tunnel towards the LES. Is there a way, guys, to dim the room a little bit? It's too bright.
So it's different, Dr. Moeen, the length of the tunnel and the myotomy for different types of achalasia.
Yeah. Yeah, very, very important question. So the first thing you guys asked, what's up? So for 1 and 2, I think 6 centimeter myotomy on the side, good. The stomach side is always good no matter what. For the tail side, when the short myotomy is okay. When it is type 3, that's the case. This is where you want to include the bottom of the esophagus with
Dr. Khashab.
In these instances, I'm going to defer this question to you, Dr. Is how do you determine where to stop to start your myotomy in type 3? What do you do in your practice?
I think the longer myotomy is better, but we will depend on the endoscopic view. See the most constricting ring, and we'll start just before it. It is at
Dr.
maybe
Khashab,
25, maybe 26.
do you hear us?
The compression of left main bronchus. We open the tunnel and then we do the myotomy just after opening the tunnel.
Yeah, so Dr. Shaima is saying manometry, we also look at that. Knowing that the manometry, the measurement is from the nostrils. So what we care about is what's the proximal extent of the contractions of the LEF, 15 centimeters, 15 centimeter, and we take that into consideration. But
the high pressure.
The endoscopic view.
Hello, Dr. Khashab.
Yes, go ahead.
Hello, thank you very much. I wanted to ask you about the TT knife. It's your preferable knife. And second, what are, if you can summarize the steps to do for this procedure? Third question about achalasia. The length of the incision is proportional to the type of achalasia?
Can I have the water, please, here, and some gauze? Just cleaning the lens here. Come to the questions. So the steps is we've already showed you step 1, which is the mucosal incision, and step 2, which is the tunneling, which we are actively doing. So step 3 will be the mucosal incision.
Closure.
So sorry, mucosal closure.
I think a second question is what is the teeth? You prefer triangular tip type, other types of knives?
There is no data that one knife is better than the other. You just have to. I think she's a little awakened to the spasm against us. So you just have to get used to one type of knife or not, but there is no data that one type of knife is better than the other. I've done all my poem knife. I became efficient with it, and that's I think some people like the hybrid knife to inject through the knife, but as you can see here, I inject the scope, so I don't need the knife to inject through. And in terms of length, it doesn't matter. The incision, mucosal incision, just to get this scope into the tunnel. What matters is the length of my out, and that, as my colleague explained, that it depends on the type of achalasia.
What do you do in case of bleeding? Do you use coagrasper?
Yeah, so for minor bleeds, we just use the same knife, and for larger bleeds, we use the coagrasper. Same thing with prophylactic treatment of vessels. Smaller vessel, we just treat it with the same knife like I'm using here, and for larger vessels, you coagrasper. continuing the same thing, the tunnel. Here's the LES. We stay on top of the muscle. And you see my orientation to the muscle stays the same. I'm going perpendicular to the muscle because that even esophagus, that is not going our path. So if the muscle turns, you turn with it. Your approach to the muscle stay the same. Here, the blue color demarcates the submucosal tunnel from the muscle.
So what are you doing is to do a tunnel in the submucosa from 6 centimeter proximal and then 3 centimeter distal to the EG junction, and then to proceed to the muscle cuttings?
Yeah. So exactly. We expose the muscle and then cut it at the end. Initially, you need to make sure that you expose enough muscle. And this is what we're going to...
And in order to know that we have not go further than 3 centimeters, we should check in the stomach every time,
If you go further, it's okay, but then you just have to limit your ma'arami. And I think you're going to move to another room. When you come back, we're going to show you the land. Here, we're going through the LES. It's a little tight here, and suddenly you see a couple meters and then finish. I think you guys are going to move to another room. We're going to do a little bit of tunneling here, and then we'll start the ma'arami and we'll get back. But now we'll start the ma'arami and we'll get you back. Yes, but now we're in the stomach. Yes, go ahead.
The next case of a 61-year-old female known to have ulcerative colitis on Pentasa since on April 2021. A colonoscopy showed multiple polyps on a normal-looking mucosa. So it's a case of polyp detection.
We are not hearing very well. Hello, Dr. Halal.
نحن عم نشتغل هلا كولونوسكوبي، عم نستعمل الفيوجي PL 700 7000. عندنا مالتيبل كولونيك بوليب 7000 مالتيبل كولونيك بوليب. هدول البوليبس عادة سلسلة الفيوجي ميز انه هو عنده اكثر من كاركترستيك ويكونتنت. دكتوره ملاك عم تساعدني هون، المفروض التكنيشن كمان عم بيساعدني. هنشوف هلا بهدول دكتوره ملاك هتشرح لنا شوي عن السبيسيفيكيشن والديتكشن تاع البوليب.
هون بدنا نحكي عن artificial intelligence. هيدا اول شيء في عنا تو methods بيساعدوا بالاندوسكوبيك characterization للبوليب. First of all, detection by three issues: sound, the box, and the circle. The sound, the box, and the circle. لا قبل بدك تعمل الديتكشن المفروض تعطي صوت.
تعطيني الارتفيشال انتليجنس.
مصطفى الارتفيشال انتليجنس عشان يعطي
يلا هون مثل ما شايفين مالتيبل بوليب. شيء بيكون هايبربلاستيك بوليب، شيء ممكن يكون malignant بوليب. Now we can, by using this element of the scope, we can detect if this is a malignant or hyperplastic polyp. We will see in a minute how we can see the artificial intelligence, which help us a lot in differentiation of what kind of polyp. How we will collect or how we will remove the polyp. Some of the polyp we will remove it using different size polypectomy snare. If it is less than 10 millimeter, we remove it by cold snare from Boston, or if it is by hot snare from Boston or from Microtech. Now we will assess the size of the polyp and the degree of hyperplastic or malignant polyp. Just waiting the artificial intelligence to be okay. You can see this look like as a malignant polyp. This one at 6 o'clock. It look like as a malignant polyp. And then we will see it.
Okay, so here previously they said that they may be dull in cases of IBD, but in the new Senate consensus, they said that this misnomer, the dull, we must abandon and we must just use.
Let me see the setting of VO3. We will see the setting of VO3 when we use it. Can we take a setting?
Dr. Halal, do we hear us?
We will use the VO3 and we will put it on cut Q. The specification will be the colon. There is difference between right and left colon in the specification, and you can use focus coag with cut Q, and you can see which kind we use it. Well, artificial intelligence شباب. خلينا نبلش لك بالبكتومي. أعطينا الصغير. 15 واحد صح؟
كبير.
خلينا نشيل الكبير هون. I will start by using 15 hot snare to remove this polyp. بدنا artificial intelligence يا شباب. وين راح مصطفى؟
Why, Dr. Halal, do you hear us?
حط لي artificial intelligence.
Okay, so as we said, by the sound and the box and the circle, here is the detection to decrease the eye movement and concentrate the optic polyp. And the second way is the characterization, which is the eye. Okay, and you can see here, this polyp is neoplastic.
Neoplastic polyp.
It's designed neoplastic or hyperplastic or ulcerated polyp. The neoplastic may be or something. In this case, this as the AI is plastic.
Color, the right side, the green color. This is also a malignant component. If we go to this one, only.
Dr. Halal, do you hear us? Do you hear us?
Yes,
we are hearing you.
Yes. Who went to decide to dissect this polyp or this one, depending on BLI or MBI, and you use the term of artificial intelligence. Where is the artificial intelligence here? We didn't see it.
We are using both of artificial intelligence and BLI, and we can detect here.
Yes, in BLI we use it for characterization for both AI and the routine characterization. The RCI it's for detection.
Dr. Halal,
the sound.
Yes.
Is learning curve necessary or only a simple training for gastroenterologist is needed?
No, it's for sure learning curve, but no need to. If a good endoscopist can tell when we use it. But this is the artificial intelligence, just to fix your hand on the scope and to use the knob of the scope regularly, and it will be fine. It has here a new plastic component because it looks yellow, while in this one it has hyperplastic component because it looked in the small screen, it looked green. If you notice, when I am away from it, cannot detect it, you have to fix your hand over it and you will wait to see what happened. Now we will go to remove all these polyps. As you know, there are different kinds of polypectomy. It's based on Paris classification. If it is soft, it has sessile, semi-pedunculated or pedunculated. I will start by removing the small polyps. Okay. We will use here the 15 millimeter polypectomy snare from Microtech. Okay. For this small polyp, we put a polyp trap, so we will not lose the polyp. We can take it by suctioning the polyp, and the polyp will be collected in the polypectomy or in the polyp trap. Usually, if we have polyp on the right side, we start by removing polyp from that side, then from the left side. You can. Okay. خلي شيء هذا الكبير الأول. Open. Okay. This longitudinal polyp, we have to remove it. We will use the. Okay, close. We are using the air machine, air machine. Okay. This was removed, the first one. The biggest one we removed first.
Can you comment the cutting setting here?
Yes, and the cutting setting we are using the end-to-cut plus from the VO3. We put in the end-to-cut Q2, and for calculation 4, we're using the VO3 from air machine. If the polyp is so small, we can remove it by using cold snare. We will continue removing this by hot snare. And the smaller one, we will remove it using the cold snare. We are using here the snare from Microtech. When we're using the end-to-cut, it by itself, it gives us an circulation current on the same time. Now, the remaining polyp, these two remaining polyp, I will go remove it by using the cold snare from Boston Scientific. So I will change the polypectomy snare, and later on, we will collect the polyp either by using basket or by suctioning through the endotrap. Okay, this one remove it by the endotrap, and I will try to take the other one by suction. I hope it can take it.
Dr. Mahmoud.
Yes, yes.
For polyps more than 2 centimeters located on the right colon, do you put a clip, a preventive clip?
What? I don't.
Clip.
Yes, on the right side, we prefer to put the clip before to prevent delay bleeding, especially if you, as you mentioned, a polyp more than 1.5 centimeters. Okay. We are using the thin wire called the snare, 10 millimeter. Now, we will remove this by cold snare. Can you hold the scope?
Yeah.
Cold snare from Boston. We are using cold snare from Boston. We will take in the cold snare technique. We have to elevate it up to take you further with it. Then we direct it. Okay, cut. Okay, we'll cut it and we'll take it. Okay, you will move to another room and you'll come back to me later on.
Okay.
Okay, thank you, Dr. Halal.
It's a 48-year-old male patient presented with recurrent gastric pain. May 2021, as the abdomen showed normal breast size with spherical cyst like 2.7 times 1 centimeter of pancreatic normal pancreatic duct. On June 2021, cyst was re-evaluated. Antibiotics were given briefly to the procedure. The US showed large molecular pancreatic head cyst with wall thickening with no evidence of smooth branch duct connection. There was mucus inside it. FNB showed normal pancreatic tissue with no dysplasia. CA was 20 and amyloid 58,000. Post as patient fever, acute epigastric pain, CRP was high. He received ertapenem milligram for 10 days with marked laboratory improvement. So I would show you the pancreatic cyst. Okay, this is in June 2021. FNB was done. Yes. So the needle is in the cyst.
So what is the preliminary diagnosis before EUS?
So it's a case of EUS pancreatic assessment by Dr. Muhammad Al-Nadi and Dr. Yasser Shaib.
Okay, thank you.
Assalamu alaikum. Assalamu alaikum.
We are hearing you.
Okay. Good morning again. I'm pleased to work with Dr. We have a Melham, and this case illustrates the challenges of having to diagnose pancreatitis in a setting of pancreatitis. So the problems that we are facing usually is that we are finding a cyst and in the middle of pancreatitis, we don't know whether the cyst is primary or secondary. It's the origin of the pancreatitis or does it develop secondary to the pancreatitis? So the best way is to follow the patient, is to follow the progression and the evolution of the cyst. So here we will start the examination in the second part of the drill, and we are trying now to get the head of the pancreas by applying echoendosonography. As you can see here, gently we are seeing the head of the pancreas, and it's showing marked nodularity. No focal mass, but there is passive trabeculation. The septation of the pancreatic head is markedly exaggerated. There is no encroachment on the posterior vessels, the superior mesenteric artery and vein. Here, superior mesenteric vein and superior mesenteric artery, there is no encroachment, no focal masses, and we can see clearly that the head showing excessive trabeculation. We even have some site of calcification, and if we can illustrate the pancreatic duct, we will see that the pancreatic duct is hyperechoic wall, has hyperechoic wall. Try to show the hyperechoic wall of, yes, here it is. The pancreatic duct is having hyperechoic wall in the middle of the image.
We don't see the EUS image. Can we see the EUS image? Okay, thank you. Now we see it.
Okay, do you see right now the image?
Yes, yes.
So I was describing the head of the pancreas. There is excessive nodularity and trabeculation. Excessive nodularity and trabeculation, no focal masses. And as we can see here, the superior mesenteric artery and superior mesenteric vein, no encroachment, no focal masses around the vessel. The excessive trabeculation and the fibrosis in the station is a sign of chronic inflammation. And as we can trace the pancreatic duct, we can see that the pancreatic duct is having hyperechoic walls, as you can see in the middle of the image. Yes, the hyperechoic walls of the pancreatic. We will then, so we examine the head properly, and we will try to find the common bile duct to ensure if there is a stone which may be at the origin of this pancreatitis. So here is the ampullary complex. Here is the ampullary complex. And we can see the uptake of the pancreatic duct and the CBD. No stones at the level of the distal part of the CBD. Here is the CBD, not dilated, and we can change the direction to trace it to the hilum. So we can apply color flow to ensure that it's a duct. Yes, it is a common bile duct in front of the portal vein, and we are approaching the hilum. So no stones, and if we do a clockwise rotation, we can see the confluence of the portal vein with the splenic vein going down and the superior mesenteric vein going behind the head of the pancreas. So here we can see the superior mesenteric vein with its tributaries, and here is a confluence with the portal vein and the splenic vein getting from down. And above, this is the common bile duct. So if I do clockwise rotation, I will be tracing the common bile duct, and I can see it going inside the pancreas, join the main pancreatic duct up to the ampullary area. Exactly. So no stones at the level of the distal part of the CBD. The main pancreatic duct, as you can see, in the middle is having hyperechoic wall. Exactly. This is the main pancreas. It's not dilated. It's not a fixed finding in chronic pancreatitis. Okay. So
are you comfortable calling this chronic pancreatitis?
Yes, yes. It's having many features, not fulfilling all the features of Rosman, but it's having the main features of pancreatitis. So we'll be tracing now the gallbladder, and the problem is that we may miss some stones at the level of the neck of the gallbladder. So we have to trace the neck of the gallbladder, not only the body, not only to get stones in the body, but also to trace the neck. Here is the neck, and as we can see, even we can trace sometimes the junction of the cystic duct with the common hepatic duct to form the CBD. So this is the CBD, and there are two ducts that will bifurcate. One is the common hepatic duct, and one is the cystic duct. So we are not inside the gallbladder or even the cystic duct, no biliary origin of this patient. So we'll go up and examine the body and tail of the pancreas. So we decrease a little bit the depth. We are having some lymph nodes which are having an inflammatory pattern, meaning that they are preserving the hilum. Here's the aorta, and the first uptake, first vessel that goes from the aorta is the celiac. Yes? Okay. Yeah. So we'll be moving, but we can say that the patient is having chronic pancreatitis, and it should be followed by imaging later on. Thank you.
Okay, thank you.
هنقول للجمهور انت بدك توقف هلر خلص ما فيك ما حدا بيعمل هلر بقى.
Coming back to poem.
اوكي نحن على الكاميرا هلا
على السمع.
طيب يلا خلينا بس نوطي شوي الصوت بالاوضه بليز. هون بس لفرجيكم الاناتومي قبل ما نبلش المعرمي. هيدا الميوكوزال انسجن، هيدا الاسوفاجس، الميوكوزال سايد، وهون بنشوف البلوish discoloration down towards the cardiac. Without even retroflecting, we can see it clearly. And coming back into the tunnel, so we're gonna gently go back into the tunnel. So this is the muscle at 12 o'clock. And here clearly this is the lower esophageal sphincter. And then if you just peek through, you can see that we have a tunnel to the stomach that's 2 to 3 centimeter in length. So that's key. You need to have 2 to 3 centimeter in length. You don't want it to be 4 or 5. Because then that predisposes to reflux. Here below the incision, you're going to give 2 centimeters without any ma'arami, and then start the ma'arami below that. And so this is muscle. My intention will be to do a selective inner circular ma'arami in the upper esophagus, because that protects patient against perforation and during mid-spinal structures. Here, what I want to first do is find the layer between the inner circular and outer longitudinal, and then just with that layer. So this is like skinning an onion layer by layer.
Also, you start, might use the break oil.
Yeah, you can use spray coag, you can use end cut, you can use dry cut. And here, just layer by layer until we get to the, and here we go.
Yeah, it's
just freeze here.
Very clear.
So we see the outer longitudinal and we see the circular. So we're going to take that layer in between there and start cutting. Can we change the Irby settings to 50 and 2 instead of 40 and 2? So the Irby 3.0 is a little different from the 300. If you go in spray coag, right? Okay. Wait to go to increase the power a little bit. Okay. Yep, that's good. Let's see that. Yep. I want 40. That's the issue, huh? 40 watts now? Okay. So it's a little different. Because I was seeing a lot of coagulation. So now I think it's better.
Now less smoke and less carbonization.
Yeah. So I like this more than endocapsule in this instance. Just I see less bleeding. I think if there's submucosal fibrosis, then I think the endocapsule is better. Because then you have less coagulation and better delineation of layers. But this works. Minimal coagulation, you don't see much bleeding, and it is fast. So this current is not appropriate for ESD because it's straight. So it goes straight, right, left. Not as accurate as you want it for ESD. Let's clean the knife, please. We're gonna just clean the knife from the coagulum. And once I get close to the LES, which is here, so I think now when I get the knife back, I'm gonna change this to a full thickness because we wanna do a full thickness ma'arami of the lower esophageal sphincter. But in essence, any ma'arami will be thickness because just passing the scope, some pressure, some insufflation, that's good, Ali. Doesn't have to مش ضروري تكون شركي. كيف بنترجمها هيدا بالانجليزي؟
دكتور خشاب.
طيب هلا نحن بنشوف اللاير اللي هونيك الادفنتشا فينا نعمل له ستينينج هون teaching point بس بتعمل EMR you inject know that the rosal layer and adventitial layer also takes blue color and causes some lifting because it takes bit of fluid and lifts the polyp. So that's one reason where you think you've lifted the polyp, but it's not the right kind of lifting, and you snare and you see peritoneum, because the rosa can take fluid. So here we're gonna go, this is now full thickness. We just have to keep the advential layer intact. If you hit it, then all the CO2 is going to go to the mediastinum.
Dr.
So here, when our LES, just one point, when we're at the, yeah, just one point.
Okay.
When we're cutting here at the LES, the mucosa is very close to us. So we're cutting down, you may hit the mucosa. So what you do partial myotomy downward, come down and meet it kind of in the middle. Then that way you protect the mucosa. Yeah, go ahead, please ask your question.
What's the risk of perforation here?
Yeah, so the perforation, the definition of perforation in submucosal endoscopy is different. We're cutting the muscle. So for luminal endoscopy, that's the definition of perforation. If you want to follow that definition, is 100%. So definition is mucosal injury. That's the definition. And that has to do with the complexity of cases you do, how much sigmoesophagus you see, and also the learning curve. You know, with time, you just basically eliminate that risk. You just don't see it. But initially, you'll see it, and you have to pay attention to it. And when you have a mucosal injury, you have to close it right away. So here, you see how we're going with the myotomy step by step, staying in the middle. And here, we're making sure we're not going to injure any mucosa. And here, we're going to continue doing the same thing.
What time takes the incision itself, the myotomy itself?
So the entire procedure should take about an hour or less. You know, once everything, and we've done a bunch of these, it's very, very quick. And also, just to let you know, we do it as an outpatient. So we just published our experience in EIO with outpatient poem. We learned this during COVID, where patients did not want to stay in the hospital. So there is some criteria for it to discharging patients, but we do this in outpatient. But these cases should take an hour or less once you have some experience with it. And now we are on the stomach side, guys, here. So we just have to extend it to the end of the tunnel, and then we will be done. And then we'll have the opportunity. You see here there's a vessel. So we just have to avoid it. So everything is done.
I can see now that you sometimes you make the over the scope or the tab distal attachment to make some dissection of the muscle.
Rarely. So not on purpose, because I think that just creates some bleeding.
Yeah.
It's better to have cautery assisted dissection. Here it's just like really widening rather than pushing down. I'm widening it. I'm not trying to push forward. But this is almost at the end. So that's the third step. So to repeat, first step is mucosal incision. Second step is the tunneling. Third step is the myotomy, which we're doing right now. And the last step is to close the incision. And we close the incision using regular clips. Some people use suturing, but that's not really needed.
Dr. Khashab?
Here we are at the bottom.
Dr.
Yes.
Khashab.
So this is the end of the myotomy. Yes, you can take it out. Yes.
In case of small perforation, do you proceed to putting hemoclips and you continue the procedure, or you use another Ovesco clips or something like that?
Great question. So we learned this the hard way. So once you have a perforation, which again is a mucosal injury, then you have to close it right away. Mind you, now we're gonna take clips. Yeah. So mind you that if you put an Ovesco, it's gonna be very hard to go through the tunnel. So just put regular clips. Otherwise, you'll narrow the tunnel, and then you can't push your scope into the gastric cardia, because most perforations are at the level of the LES. So this is here the end of the procedure.
Okay.
Extac can play a role. Extac can play a
So
role
the
here.
next step is mucosal closure. Is there a question? Sorry, I didn't hear it well. This is what size?
The question, Dr. Moeen, about identification.
Sorry. Yeah, go ahead.
Identification of the cardia. You depend on the lens, insertion of the scope only, or you can depend on other items for identification.
Can you please figure out the how big? Yeah, 5 minutes. So in terms of cardia, it is not scope length. We exactly identified the LES, and then we looked at the tunnel below the LES muscle. Okay, good. So we're using the Boston Scientific 360 resolution 360. The nice thing about these clips is that it's completely under your control. So you control the clip rotation. Open, please. Good. So I'm rotating it here at the biopsy forceps, at the biopsy hub. And we're gonna take it maybe a little lower, close, to see if we can invert it. Hold on. Yep, take it. Okay, open. So this one you have to open once. Open. Yes.
After closure, push it again.
So just like that, huh? Open it like that. Different from, so the Microtech clip, you just clip, and then it releases. This one, you have to release it yourself. So usually 5 clips is the average. So guys, you can open a few more clips. Don't worry, we're gonna need them.
So you start to close the entry from distal to proximal.
Yes.
Yeah. And you prefer it to make the tunnel opening at the same, or just as you made like now?
Like position?
Yeah.
Okay. You know, it changes. A lot of times we have to rotate like this.
Yeah.
To the left side to get like a better angle. Here you see like the mucosa is a little redundant. And close here. Take it. Open. Good. Okay.
Yes,
but yes, that's a good point. A lot of times we rotate the scope to get a nice exposure to the. Okay.
After the procedure, do you continue antibiotherapy for 48 hours or more? And what about the nutrition? When you resume the nutrition?
Yeah, so we, if you are confident of the mucosal closure, then we allow water the same day. Open. If it's at the beginning of your experience, it's good to keep patients MPO and get an esophagram the next day. Once you're comfortable with the procedure and the closure, I think you can. You don't have to do that. Close.
For a later risk of gastroesophageal reflux disease, what to do? When do you perform a fundoplication, an endoscopic fundoplication?
Yeah. Oops, sorry. That's the most important question, is the reflux. We tell the patients, which I told this patient, 50%, 1 and 2, they're gonna need a PPI. Most of these patients are actually asymptomatic. So we discovered it by pH. There's some data that it's better to do, prelim data, that it's better to do a pH study at 1 year rather than like 3 months. Open, because there is some remodeling of the sphincter. And the remodeling, which results in less reflux rates at 1 year. Close. Take it. Next. Take it. Next. Open. So here, this is 4 clips. We're probably gonna need 2 more. So for fundoplication, so these days we offer patients endoscopic fundoplication if they are not fully responsive to PPI, or for young patients who want to get off PPI, we offer transoral incisionless fundoplication. And you know, I've had to send a couple of patients for a surgical fundoplication for bad reflux, but that's rare. Open. Open, please. Open. Good. Close.
You see one
last one.
New endoscopic procedure for reflux like anti-reflux mucosal ablation may help these patients if they are experienced reflux after doing POEM?
Yeah, you know, ARMA is a new thing, you know, but ARMS and ARMA have been described. There's just a worry of stricturing and causing dysphagia in these patients. So ARMS is contraindicated in these patients, but ARMA may be okay with ablation rather than resection. That's your question, right? Open. So here, hopefully last clip so that we can get out. Because close. Okay, take it. All right. So I think we are done here. Do you guys agree?
Yes.
Okay. So this is how many clips here? 1, 2, 3, 5 clips, which six. Yeah. So that's the average. Okay, Zahir, thank you. We're done. Yeah. Yep.
Beautiful, Dr. Khashab. Thank you very much.
Thank you very much. And now we have the pleasure to invite Dr. Rita Slim to talk to us about IBD treatment in the era of biosimilars. Dr. Slim is a gastroenterologist and hepatologist at Hôtel Dieu de France University Hospital and associate professor at St. Joseph University, Lebanon. Welcome, Dr. Rita.
هاي كنت حابة أكون معكم بس سافا ماشي الحال.
Always a pleasure.
First of all, I would like to thank Dr. Humani for his perseverance in spite of these circumstances we are going through. And thank you for Sandoz for this symposium. I will talk about IBD treatment in the era of biosimilars. One second, what's happening? We are all aware that the incidence of inflammatory bowel diseases continues to increase globally. Costs are significant. Use of biologic therapy for the treatment of IBD has continuously increased during past decades, and biosimilars have found their way into the market since patents of biologic agents have expired. It's a global disease. We have a high prevalence in Western countries, but also in Eastern countries.
Excuse me, Dr.
The prevalence is the result of
can you put the slideshow, please?
mortality.
Can you put the slideshow because we don't have the whole image.
Okay. Like this?
Okay, thank you.
Okay.
Yes, thank you.
So the prevalence is the result of incidence and mortality, and the incidence is the sum of the two rising in incidence in Western world and in newly industrialized countries, and the emergence of incidence or unmasking of incidence in developing countries. The mortality will depend on aging of the population, but also on other factors, as lately we had the occurrence of COVID pandemic. So if each country has an idea of its prevalence and its position on the curve, this will help countries have their own health policies in order to overcome the burden of the disease. So to make it in a simple way, IBD will result from the interaction between immune response, microbiome, and environment in genetically predisposed patients. And until recently, the therapeutic strategies still aim at the secondary response, which is the inflammatory response, to the luminal commensals that invade slowly the mucosa and the submucosa. So we will target the inflammatory response, not the responsible of this inflammatory response. So in anti-TNF will be are indicated, have the indication in the moderate to severe inflammatory bowel disease, and in patients that did not respond to conventional therapy or they were intolerant to conventional therapy. Why I'm focusing on anti-TNF? Because the patents of infliximab and adalimumab has expired. So we will talk about biosimilars in this particular indication. So what is a biosimilar? A biosimilar is a biologic product. So it's a product that is made using living organisms that have comparable quality, efficacy, and safety to a reference product. And FDA and EMA provided an explicit definition for biosimilar, which is a biologic product that is highly similar to the reference product, with no clinically differences from the reference product in terms of safety, purity, and potency. Biosimilars are not the same as biobetters. Biobetters are improved versions of original biologic. They are not the same as biomimics or biocopies, because copies are copies, but they have not been subjected to rigorous clinical testing as biosimilars. They differ from generic drugs, which are in general chemical drugs with small size, with a simple structure, with predictable manufacturing. They are stable with lower potential of immunogenicity in contrast of biosimilars. And if we want to place biosimilars between generics and biologics in terms of scientific difficulty, time, cost, and manufacturing process, they will be closer to biologics, and they will be closer to biologics, and but more economic if we take this criteria into consideration. Now, if we want to look at the process of the regulatory process for the approval of the biosimilar, it will differ from that of the original drug. If we want to look at the regulatory process for the biologic drugs, for the original biologic drug, we will have the step of clinical studies. So if we want to approve this biologic treatment for different clinical studies, we have to test this biologic in every clinical situation. In contrast, for the in case of biosimilar development, this process can be abbreviated. We will have to focus on analytical, structural, and in vitro studies for the biosimilar. And this step is a step that will take time. And then we will have to have one clinical study that will compare the biosimilar to the originator, taking into account pharmacokinetics and immunogenicity, and then the biosimilar will have to be approved. And then this data can be extrapolated to other indications. The term switching describes the phenomenon or the process of changing from a reference product to a biosimilar, or vice versa. So what is the eco position regarding this biosimilar? If we look between 2013 and 2016, we will see that physicians are more confident in using biosimilars. And extrapolation and switching are acceptable in condition that switching from originator to a biosimilar should be performed following appropriate discussion between physicians, nurses, pharmacists, and patients. Switching, multiple switching, and cross switching are not advocated since we don't have a lot of clinical evidence. If we take the economic aspect of biosimilars, we must be aware that the tumor necrosis factor inhibitor drugs market size in 2018 was around $40 billion in US. So the main advantage of biosimilars are cost savings. So cost savings are considered to be the main advantage of biosimilars. They also, biosimilars help control drug prices. So they keep prices under control. And in 2020, biologic agents formed 28% of the global pharmaceutical market, with biosimilars offering potential savings greater than 50 billion euros across European countries and the USA. So we are talking about savings. If we take adalimumab, the biosimilars of adalimumab, and we are interested by Hyrimoz, it was put on the market in 2018 in Europe, and it will be put on the market in 2023 in US because the patents of adalimumab has not yet expired. Hyrimoz is approved for use in all reference adalimumab indications. Studies provide evidence of similarity with reference adalimumab in terms of primary sequence, in terms of TNF alpha neutralization, in terms of tertiary structure, and in terms of TNF alpha binding profiles. If you want, Hyrimoz was approved in two sensitive clinical indications, in psoriasis and in rheumatoid arthritis. So the first study, the ADAXIS. So the ADAXIS was the study done in chronic plaque psoriasis. It was so after 16 weeks of randomization between Hyrimoz or adalimumab, patients who had response at week 16 were re-randomized to either remain on the initial treatment or undergo a sequence of 3 treatment switches until 35 weeks, and then they were returned to the originally randomized treatment up to week 51. So the originality of this study was the multiple switch and the long-term follow-up of the patient. So if we take at week 16 the first primary endpoint, we will find that Hyrimoz was similar to reference adalimumab in terms of response at week 16. And if we follow the patient all over 51 weeks, we will find the same efficacy of Hyrimoz and the reference adalimumab. So this 4-time switch phase 3 study proved to be efficacious, to have Hyrimoz efficacy in this setting. If we take the severity of adverse event or the number of adverse events between Hyrimoz and the reference adalimumab, there was no difference. And if we take the immunogenicity, we will find the same percentage of antibodies or anti-adalimumab antibodies. So we have the same immunogenicity. Now we'll go to the second study, the ADMIRA, which was done in patients with moderate to severe rheumatoid arthritis. Here, so patients were randomized between Hyrimoz and adalimumab. The primary endpoint was week 12, and then at week 24, the patients who were taking adalimumab were switched to Hyrimoz and followed up to 48 weeks. Here also we find the same results. We have the same result at week 12. So we have the same response rate at week 12. And if we follow patients after switching to Hyrimoz at week 48, we will have also the same amelioration in the score of the disease. The same, we had the same, there was no differences in immunogenicity after switch from reference adalimumab to Hyrimoz. So these two studies has proven efficacy and safety of Hyrimoz comparing to adalimumab. And after these two studies, the data were extrapolated, and Hyrimoz is now advocated as a biosimilar for adalimumab in all indications for using adalimumab. And to buckle the loop, the Sandoz Sensoradi pen is by 20% of patients, nurses, and physicians, based on a survey result, is well perceived and is easy to manipulate. Thank you.
Thank you. Thank you, Dr. Rita Singh, for this excellent presentation. Just a question. In your experience with using biosimilars, which we are using more and more in this difficult economic status in Lebanon, what's your approach with your patients when you prescribe a biosimilar? How can you convince your patient that it is the same as the originator, and how to avoid the nocebo effect?
Yes, you know, before talking about patients, we were not at ease
convinced.
Prescribing. We were not.
But now we are convinced, I think.
Yes, now we are convinced, and I think in Lebanon the economical issue is avoiding this nocebo effect, and I think discussion with the patient is essential.
Okay, thank you. Any question from the audience? No more questions. So thank you, Professor Taslim. Thank you for this good presentation.
Bye.
And now we move to the last session of this afternoon, which will be moderated by Dr. Joseph Awada, Dr. Abbas Bahr, and Dr. Abdullah Musa.
It will begin
after 10 minutes of coffee break. 10 minutes only.
At 4.
The FDA did post-marketing studies indicating a 5% rate of culture-positive scopes despite reprocessing. That's a huge failure rate. 1 in 20 patients is at risk. That's something that should really wake us all up and have us look at what we can do better and how we can redesign scopes. Disposable types of scopes will help, but it's not the long-term answer. Either the reusable scopes have to come out of something better, where complete sterilization is actually possible, or I think the future is going to lie with disposable scopes.
إذا هلا بعد في إياهم.
البيوغرافي موجودين على هيدي شايفها يعني.
هون you click just here and the Q&A to check the questions.
Okay.
دكتور هلا في عنا اللايف كور then دكتور شيماء الخلي رح تكون عم تعطي البرزنتيشن من النجدة هي her biography and next the biography of Dr. Nicholas كمان رح يكون على زوم.
اي واحد لك بريزنت.
هيا انت بلش.
اوكي بلش هيك.
وين ال biography؟
بدك احط لك اياها. ايه بعرف بس نحن انا الجرس تكونوا راضي ها دكتور شيماء
بس هو حيعملها.
So حضرتك دكتور
Nicholas. Okay.
Okay, doctor, you just click, double click, you go for the zoom. You click, double click, you go for it.
Okay.
هون just Q&A to check the question.
لا ما أنا بدي تاتش سبيشال هي.
Yeah.
كله راح على البحر.
check 1 2 الو الو check 1 شو check 1 check الو check 1 check 1 2 check 1 Okay. Hello, check 1, check. Check, check, check. Okay, okay. Check 1, check. Check 1, check. Hello, check, check 1 2. Check 1, check 1. Check 1, check 1. Check 1 2. 1 2 3 4 5 6 7 8 9 10 11 12 13 14 15 16 17 18 19 20 21 بعد اوكي
بدك شيء من جورجيا؟
بعد
رح يسكر.
لا اذا بدك اوكي
Afternoon and welcome again. We are going to start the last session of the day, and we will begin with a live demonstration from Nabatiya. So let's start, and hopefully we will have a better connection. We don't know which case.
So in our last live, we have 3 more cases. The first one is 64 years old female patient presented with painless jaundice, weight loss for 1 week. MRI abdomen and MRCP, the liver shows 30 millimeter and 31 millimeter lesions of hyperintense signal on T2 and iso-intense thick capsule in S4. The intrahepatic bile ducts are diffusely dilated. A wedge-shaped mass 38 times 26 millimeter is embedded in hepatic hilum, involving the common hepatic duct with extension into the left and right biliary ducts, suggestive of Klatskin tumor. The CBD is tiny and there is enlarged retroperitoneal and hepatoportic lymphatic nodes up to 18 millimeter. So this case is for ERCP for biliary drainage, spyglass for assessment and possible biopsies, and stenting by Dr. Mu'in Khashab and Dr. Mahmoud Halal.
اوكي مرحبا جميعا. عم بشتغل هون مع دكتور حلال وعلي. عم بستعمل هون الفوجينون ERCP سكوب. عم بستعمل الترايتوم من كوك. عم نستعمل الفيزيجلايد واير من اولمبس. واذا كل شيء منيح حنعمل سباي جلاس دي اس من بوستن سنتر. يعني عم كل الكومبانيز حيكونوا مبسوطين دكتور حلال. طيب بدنا نعمل recannulation first. So we see where the papilla here is. This is the direction of the bile duct. So we're coming here and we're gonna look up. اعطينا فلورو روح علي بالواير شوي ها روح اوكي. طيب خلينا نطلع لفوق بليز. اكس راي لفوق ايه عافيك. اوكي روح بالواير هلا. طيب
We don't have the fluoro image, please.
طيب اوكي ستوب فينا نفرجيهم الاكس راي. علي رجع شوي بالواير. فلورو طيب شايفين شيء الاكس راي؟ اوكي انا ماني سمعون.
We still don't have it.
يلا
ايه يلا
So in such cases, you prefer to go on the.
لا هيدي لعنده. مور. اوكي طيب وقف الاكس راي. طيب شايفين الاكس راي هلا؟
شايفينك معين بس.
عمل
ماشيين عم بتزمل.
ايش يمكن بدك توصلها قبل ما يصير لها شيء هلا لانه عذبتنا شوي الصبح.
Yeah, we have it.
اوكي
طيب كثير منيح. فهلا بنشوف نحن انه الواير is on the right side. فنحن since the wire is on the right side it's okay to inject. بالكلاتسكين تيومرز ما بدك تحط كونتراست الا تتاكد انه خليك اكس راي بليز دكتور حلال.
الماشين
عم تعلق الماشين. اوكي لا هيدي مشكله هيك بدنا اوكي خليها ما توقف بليز.
انا ما موقف بس هي بتوقف.
طيب شو لا ما انا ناطر هي اوكي لايف دكتور حلال عم شو بدنا نعمل؟ هيدي الكونتراست منا فول سترينث. في اعطيني فول سترينث هي يعني ما تعمل دايلوشن. ايه اوكي دكتور حلال اعطينا اكس راي بليز. اوكي بعد اوكي فلورو طيب اوكي هون مش الحال. طيب بنشوف هون نحن في severe right hepatic duct stricture. so اللي حنعمله حنخلي الواير هونيك وحنرجع نعمل سفنكترارمي ونفوت سباي جلاس. سباي جلاس بدنا نعمله لشيئين لنشوف اذا فينا نستعمل left بس كمان لنجيب بايوبسيز من الستركشر لانه ما عندنا دايجنوسيس. فخلينا نعمل وانا برجع. اوكي بس نحط سباي. طب حنروح على غرفه ثانيه بس نحط السباي جلاس حترجعوا لعنا. دقيقه بعدني ما رجعت. اوكي يلا لا مش الحل. اوكي جو اوكي رجع فرجينا الهيدا منها هذا الاكس راي غريبه. اوكي رجع شوي الواير لورا فلورو شوي بس.
دكتور معين. دكتور خشب. فتنا على نقلنا على غير روم.
الو تمام. الو طب زي ما الدكتوره ملك patients complaining of dysphagia وعامل مانومتري type 2 atresia بس مش barium swamp and he said it normal actually it's widely open yeah. As you can see the cardiac widely opened no resistance it's widely open and then on as you can see here with reflection it's very widely open. So I don't think that this patient is aphasia, but having dysphagia. You see here. Yeah, what's happening?
Unfortunately, we don't hear very much. Very good.
Very well.
Very bad communication. So connection and communication.
طب سامعني كده أحسن؟ Hello?
Yes, better. It's better now.
سامعني؟ طيب تمام هو dysphagia but we found out that dysphagia is incontinent cardia. This is an incontinent cardia lying in the ايه المشكلة؟ حد سامعني؟ اوكي. طيب تمام كده هو دلوقتي this is complaining of dysphagia but what we see here is a picture of incomplete cardia. This is not achalasia. As you can see احنا هنا داخلين الاسوفك حتى من lower end of the esophagus from the retroflex and this patient is lying supine position which makes the retroflexion more difficult. So this cardia is much more open than what we see right now. This is the incomplete cardia, which is 3 precipitation, if you can see. So that it needs to be narrowed, not to be dilated. So we have to think what causes dysphagia in the patient. If we go upside, here's again this incomplete cardia with reflux. If you go upside here, you can find that he has this submucosal tumor here on the left side, and it's readily movable. Probably it's a leiomyoma. You can see here, this one. Besides, it's not that thin food or slide. Again, you'll find another bulge, it's much bigger than the lower bulge. I think this is another submucosal tumor. You have to check. We have EUS, this patient to check. So this patient, most probably not achalasia. تكملة للكلام اللي كان بيقوله دكتور معين that you're endoscopy is very important. It's not about imaging. It's not about mammography. You have to see by your own eyes this patient is not achalasia. The esophagus is not that dilated, not achalasia. No retained fluid, nor there is no barium, but the cardia is widely open. So we cannot do point for this patient. But we have to do EUS to see what's the problem, what is this submucosal bulge. هنا في رينج. هنا في رينج.
We have to respect the symptom of the patient, which is dysphagia. Dr. Zahir did gastroscope twice for this patient, and he found that the cardia is widely opened, but the patient still has the symptoms. Unfortunately, barium are not available. The barium substance now is not available, but we have to respect the symptoms. So we are searching for another thing. As we saw in the gastroscope here, we went for the upper esophagus and we see mucosal or subepithelial bulge. So you are expecting that it's something in the lumen or something from outside. So we'll shift to the endoscopic ultrasound to assess, to do examination for these two bulges, one at 30 centimeter and the other bulge just below the upper esophageal sphincter. I think that EOS will help us to assess this bulge. It is truly from the lumen or from outside the lumen, because we are thinking that these two bulges may explain the symptom of this patient for dysphagia.
So we can shift to another room till we change to the EOS picture.
Stop. Okay. هيدي الاليفيتر بهيدا الصوت شوي تعبان. نحن هلا عملنا سفنكترارومي هلا عم نحط سباي. اوكي اعطيني فلوراستومي حكيم. اوكي ما بقى تسحب. دكتور شوي.
تعطونا البيكشر تاع السباي جلاس.
طيب خلينا هلا نشوف السباي جلاس.
سباي جلاس بيكشر.
هلا علي حط لي اياه هون لهيدي. خلي الواير بعيد عني. هيا هيك. بدك تشد منيح حكيم. دكتور معين. مش الحال. طيب خلي وين السباي ايمج؟
يلا سباي ايمج.
وين البامب؟ بدي البامب للسباي. دكتور حلال.
البامب وين لك؟
اعطيني فلورو بليز. هلا اوكي. طيب انا هلا حطينا السباي فوق الواير. اعطيني فلورو رجع. اوكي. ف هيدي ما
Can you magnify the fluoro image?
خليه يوصل حكيم. خليه يوصل. هلا يلا بعد بدنا بعد ما بين السباي. هلا نحن شايفين على الاكس راي انه السباي صار فوق الستركتشر.
بتشوفوا الاكس راي؟ شايفين الاكس راي بيكتشر؟ Are you seeing the X-ray picture?
ما شايفين شيء.
هيا مش الحال. اوكي عندي البامب بليز. هيدي فينا نقيمها. اعطيني البامب. ثانك يو. اوكي. طيب خبروني يا شباب بس تشوفوا السباي.
نحن
في ديلي هن بعد عم بيسمعونا من بعد كثير.
Are you hearing us?
Have the duodenal image, the spy image.
Fluoro shot.
ايه بس بدنا نشوف. شايفين الصورة برا السباي جلاس؟ لا سباي جلاس شايفينها هونيك؟
فلورو؟ استنى جوا بالضبط. اعطيني فلورو. هيدي فلورو. اوكي. صورة السباي من هون؟ هي منا.
يا حبيبي لحظة.
اوكي. يلا. لك هذا البامب منه منيح. بدنا لا
يلا ماشي الحال. وين مصطفى؟ بدك نحط بس صورة سباي.
يلا. طب يلا خلينا خلينا نعمل
سباي على الحل.
زوم ان على السباي.
زوم ان على السباي. يلا بس نحط سباي بعدين نقلبها.
بيومي حط 20 سي سي سرنج على هيدي حتى تعمل سكشن منها عشان ننظف الدكت. ممتاز هيك. اوكي فلورو شوت. طيب
معين نحن عم نشوف.
عم بتشوفوا شيء السباي؟
لا ما عم نشوف.
لا عشان بده يصور هو هون عرفت ليه؟
عم بتشوف ولا ما عم بتشوف؟
لا we are not seeing.
ايوه فيك تقف جوا؟
بس we have the duodenoscope image only.
It's okay.
طيب ما عم بشوفوا السباي.
هلا now it's better yes.
طيب هيدي it's a beautiful image. This is the transition zone. So we see normal, abnormal. I mean, this is perfect. So here we're coming back to the common flora. Okay, good. So now what I'm going to do is I'm going to go to the normal and go to different ducts, try to delineate the anatomy. So can you give me fluoroscopy, please? Okay, good. So this is right anterior. So here, instead of injecting more contrast, which of course carries the risk of cholangitis, pleura. Okay, good. Off. So we're gonna just use SPY here, and with minimal injection of water to clean things up, and also to understand the anatomy. Pleura. Good. So here, this is all right side, Dr. Halal. So it looks like the stricture here probably involves the left. I'm going to go in a little bit here and look at this side, see if we can see anything. We can't see anything. Okay, fluoro, please. Good. So coming here. So this is very important, guys. You see here these vessels, we see some tortuous dilated vessels here. So we didn't dilate, we didn't do anything. So here it's a little bland. So here it's benign appearing stricture. And here we see it's more vascular. So when we get biopsies, we want to target the stricture well. So very, very long malignant appearing stricture with dilated tortuous vessels, and it goes all the way down. So I don't think we will be able to, so let's see here what we see here. Maybe this is the cystic duct, let's see, or fluoro again?
Yes, I think this is it.
Okay, so let's get into there and see what we see. No suction here. No suction here. Fluoro again. Okay, fluoro again. So this might be the. So this might be the left here, huh? Back actually, fluoro. Or we went back actually, fluoro. Yeah, we went back. So this was just the same tumor. The left, but we thought you went to the left, but we didn't. So our goal here is just let's look at this here. So we're trying to see if we can use fluoroscopy to go to the left side.
Usually the left side. Usually the left side, I think.
So here, ending up on the same we're ending up on the same side. So this is a tumor, and we're just like it has tunnels within the tumor rather than different ducts. So here we went through here. So here we went through here. Let's go through here again.
معين.
Yes. Yes.
Okay, بس we are trying to communicate يعني لأنه كان في عندنا difficulty.
Same, huh?
Okay,
Same,
much
yeah.
better, yeah.
The same area.
Yeah. Okay, so what we're going Okay, so what we're going to do, guys, is get some biopsy. So here, this is an image that you need to memorize.
So this is classic.
So this is classic. We don't need biopsies even here. So these dilated tortuous vessels here, this is pathognomonic. This is diagnostic of cholangiocarcinoma.
Only
from our data that we looked at recently, only 30 to 35% of cholangio will have this feature, but the specificity is 98%. So basically, once you see them, you can say this is tumor, and this is where you're going to target.
What we're going to do, we're going to get the
So what we're going to do, we're going to get the spy bite, please.
We're going to take the wire out.
We're going to take the wire out.
Losing wire
We don't worry about losing wire position or anything here because we have spy. So that will.
بس بعد شوي من الكاميرا يا
بس بعد شوي من الكاميرا يا شباب عشان يشوفوا. اوكي.
هلا
هنجيب البايوبسي. هتحطوهم بفورمالين. So this goes into. So the. Okay. So the view that you see here, this is diagnostic of cholangio.
Yes. So this is
this is spy bite max here. This is a spy bite with some enhanced tissue acquisition features.
So the jaw,
has been changed a little bit to capture more tissue.
And what we like
to do is get 3 passes.
The trial.
So there's a trial published recently, a randomized trial that there is not much gain above 3. But the biopsies are really for chemotherapy. If oncologists want to give chemo, they want to see pathology. So here's what's happening now. Yes.
Can you move away a little bit the micro?
The monitor. Okay. So they need the monitor moved, guys. Maybe this way a little bit.
Yes, better.
No, they want the monitor. They can't see the spy. Well, that's what they said.
I think the camera is not focused.
Okay, so this is important what I did. I couldn't push the forceps out, so I pushed the scope towards the hilum. Once you push the scope towards the hilum, then it kind of straightens the spy a little bit, and then you can obtain biopsies. We don't want to obtain biopsy from this bland part here. I want to come back again, and this is where the vessels are open. So we're gonna push, close, and then we're gonna get a tissue, and we're gonna put it in pathology, in formalin, sorry, and send it for PAT. So keep it closed. Ali, this is like a normal biopsy, in formalin. So you see here how we see like 2 different ducts, but they take us to the same place, no change. Basically, it's tumor in between, and it's like a tunnel on this side, takes us here, and tunnel on this side. It's really fascinating. Do you guys see that? On the other side, and it also ends up the same place, huh?
Same place.
Okay, so let's get another pass here. Hey, Sakura, please, I'm not the line on my.
معين.
قرب شوي لعندي.
دكتور معين.
طيب هناخد بايبسي ثانية. Yes.
So the guide wire is still there, or you remove it?
Yeah, good question. So the channel of the scope, the therapeutic channel of the spy scope can take either or. So you have to remove the wire to put the forceps. It's a 1.2 millimeter channel. So you have to remove the wire to get the forceps out. So I pushed the scope up to the hilum again or to the intrahepatics. That way I can get the forceps out easily. So this is something you have to remember because you're gonna feel resistance on passing the scope and people get frustrated. All you have to do, or for pushing the biopsy forceps, and all what you have to do is advance the spy scope to the intrahepatics and then it comes out easily. Open, close. Okay, so here my plan, I think, is to get a wire on the right side again and put a stent on the right side. And maybe if we can't opacify the left side, do a hepatogastrectomy for the left side. That will be what I do in my practice. اوكي هتروح على اوضه تاني وبنرجع. هلا علي هنعمل لا هلا اعطيني اعمل كلام.
Okay, a 76 years old female presented with jaundice and abdominal pain. MRI abdomen showed 1.1 centimeter proximal CBD stone. ERCP was done. It showed the CBD of 14 millimeter with 11 millimeter CBD stone, and a plastic stent was inserted. So today we will redo the ERCP with sphincter macrodilation and stone extraction by Dr. Yasser Shaib and Dr. Ammar Ghazali.
لا كتير رجع. Okay, so we have started the procedure. We already removed the previously placed stent. As you can see endoscopically here, there is a large diverticulum next to a previously cut, previously done sphincterotomy. We removed the stent with a snare, and now we're cannulated with a wire, and the sphincter tome is inside the. We're gonna inject contrast now and evaluate what's going on. Inject, please.
We don't have the fluor.
Okay, it seems that there is at least one large filling defect right at the tip of the sphincter tome, where the tip of the sphincter tome is now,
yes,
above
sir.
the scope.
Yes, sir.
Now,
we cannot see the fluoro.
Can you show the fluoro? The X-ray, هيدا. Ooh. There's a pretty large stone. I think it's at least measuring, gauging it by the scope.
Yes, sir. Yes, sir.
Yes, we're fixing the fluoro.
Okay.
So now I'm thinking of what will be my next step. That stone seems to be large enough to warrant more intervention. It's unlikely that it will come out with a simple balloon sweep. However, so we'll start by. I'm most likely here because she has a previous sphincterotomy, and in the presence of this large diverticulum, I'll go straight to dilatation. As you know, even with native papillas, you can go straight to dilatation without doing a sphincterotomy. The results have been shown to be almost equal. So doing a sphincterotomy is not always a must. Most of us, at least I, usually do a sphincterotomy before doing a dilatation of the papilla.
Okay.
So right here, if we can see the fluoro, you can see that there is definitely a large stone measuring, I would say, probably around 1.5 to 1.8 centimeters. So you can, now we're gonna keep the wire in, exchange, and go for the balloon dilatation. We'll use a CRE balloon. We'll take that. Show you.
Yes, sir. Can I ask you a question?
بعيد بس I have to push it down. شوف. I have to dilate. Yes, sir.
Yes.
Dilatation.
Another option to catch the stone with the Dormia basket trapezoid and do electrotripsy without doing sphincteroplasty, without doing dilatation. What do you think? To crush the stone
yes,
with...
this is always an option. This is what we have at our disposal, so we can either go for try to grab it. I think still that this stone, even if you catch it with a basket, it will be difficult to pull through the ampulla here. So I prefer to start with the dilatation and then try a balloon, and after that, if that doesn't work, then I might go to a basket. This is probably going to be quite a challenging stone, and
because of the presence of
okay, so we'll go ahead. As you see, we're securing the wire inside. We're using the Olympus 180V scope. The V on the scope helps you to hold the wire in place, and then you can exchange with more ease and more confidence that you're not losing the wire.
The presence of the diverticulum cannot cause more risk of perforation with balloon dilatation.
So I'll dilate to 1.2, but then about 4.
Yes, sir.
But after I do the dilatation, I'll put the balloon and do occlusion cholangiogram.
Yes, sir.
Yes. So now we're using the CRE balloon.
Yes, sir.
The wire-guided, the usual CRE balloon.
Yes, sir. Do you hear us?
Yes. And a challenge here will be that diverticulum, because the bile duct will be passing next to the diverticulum, and every time you try to pull the stone out, it might give way and get stuck at the shelf that's formed by the diverticulum.
Do you hear us? Yes, sir.
So right now we're getting our balloon ready. You have contrast in it. We'll inject, dilate, and using contrast inside the balloon to make sure that we have the enough dilatation at the ampulla. Yeah. And let's do, and then we can go to. So this is probably the most critical part of this procedure, doing the dilatation here.
Yes, sir.
Once we do it, now.
Yes, sir.
Yes, sir.
We have two questions. First, with this diverticulum, what is the risk of perforation? First question. And the second question, if it was a naive patient and you go for sphincterotomy, how big you will perform the sphincterotomy? Total sphincterotomy or little one before microdilatation?
You know, if you do a sphincterotomy, you'd better do a good sphincterotomy. You want to cut the muscle if you do a sphincterotomy. Doing a small, gentle sphincterotomy is not going to help you. However, the studies have shown that you can go straight into dilatation. And the diverticulum will probably be a risk for perforation more with the sphincterotomy. Right now, my worry is pull the wire back, please. So as you can see, the wire, our wire is kind of deep and it's pushing us back. Now we have the wire secured in place. The balloon is in place, and we're ready to do the dilatation. So inflate. And you can watch fluoro now, if you go down a little bit.
What caliber are
Can you go
you
down
using?
on the fluoro حدا هون? This is 12, 10 to 12. So I'm not planning to go more than 12. We have the 2 balloons available. So, but if I'll go to 12 in this patient.
And how long
I
you
need
will
a
how long do you
fluoro down.
you will
I'll keep the balloon inflated for حرك الفلورو تحت. Yeah, 1 second. We're trying to fix the fluoro here. بس الماشين الفلورو بس 2 سم. Okay. Okay, so we have the balloon in place. We'll go to 2 centimeter, to 12 millimeters, sorry, and hold it there for a minute. And then we'll go in with an extraction balloon. Okay, so this seems to be working. I didn't see much of a waste, but at least we know it's dilated to 12 millimeters. Okay, we're holding it for a minute. And now you can see on the cholangiogram, you can see the stone, actually a better view of the stone. Right above where the scope is. It is elongated right in the common hepatic duct, above the clips of the previous cholecystectomy. Yalla. Okay, we'll leave you for a few minutes and come back.
طيب مرحبا. هون اخذنا البايوبسيز وخلصنا. بدي اياكم تشوفوا السباي. هلا هون عملنا تريك حلوه. We recently described it. حطينا 2 واير بالسكوب. واحد وقدرنا نستعمل الكولانجيوسكوبي حتى نحط واير بالرايت انتيريور وواير بالرايت بوستيريور.
اخذنا صوت الاشعه اللي هون.
لا بدنا نفرجيهم. بدك تيجي من هون يا حبيبي.
هن عم بشوفوا
عم بشوفوا هيدا؟ طيب بس بعد لهم شوي. عم تشوفوا السباي جلاس؟
Yes.
اوكي فنحن عندنا 2025 وايرز. الشانل هذه 1.2. ال 025 واير معناته 0.65 ملم يعني 2 wires 1.3 millimeter, but you can squeeze them inside the channel. فاستعملنا cholangioscopy for double selective wire cannulation of 2 ducts. اللي هنعمله هلا هنعمل exchange of both wires. ايه
معين
both wires, okay? Hey,
you have two guide.
فيك تعطيه لعلي بليز عشان اعطيني الاكس راي بليز. Yeah, go ahead please.
You have 2 guide wire on the right.
Yes, right, but the endoscopy. اعطونا الاندوسكوبي فيو. Yeah, go ahead.
You have 2 guide wire on the right side.
Yeah, right anterior, right posterior. Okay. We couldn't selectively cannulate the left. I think the left is going to need a hepatogastrostomy. So here I just need my endoscopy view to exchange. Just hold on. The plan is to dilate the hilum, put 2 stents, and depending what Zahir wants, we can do hepatogastrostomy today or at a later time.
Can you magnify the fluoro?
طالع عندك الاكس فيلد.
Yep. Okay, good. So now we're both okay, go ahead, please. Go ahead, go push. So here, be careful that my elevator does not squeeze well, huh? So we can't lose these wires. Fluoro, good, off. So after this, we're gonna do 8mm hurricane, dilate both sides, and then put metal stents. So this is type 4 Klatskin. These are very complex structures to manage. One of the most difficult ERCPs. But I think cholangioscopy has really facilitated our understanding and how we treat these guys. So we can go back to the endoscopic view here. And we're going to dilate one wire at a time, and let's just put water on them so that. Balloon for a hurricane? Yeah, one balloon for both, huh? One at a time. عرفت علي؟ تستعمل نفس البالون للجهتين. فهنستعمل الهurricane 8mm diameter both sides. ونرجع بنشوف زاهر شو بده يعمل باللفت.
Technically, it's impossible to
تروحوا على أوضة ثانية نحن. Technically impossible to what? Sorry?
To put the stent without dilatation.
What's the question? Sorry.
Technically impossible to put stent without dilatation.
I mean, we have to. They want us to put metal stents, so it will be impossible. So here we have to dilate. These structures are tight. Okay. Zahir عم بقول من we drain right anterior, right posterior, which is 60% of the liver. That might be enough. So I think that's acceptable. And then if she still needs the left side drain, you can do a hepatocoagulation. Okay. Okay, we'll show you the stent placement. المشكلة يا
افضل حط في ميتاليك ستاند، عندنا الميتاليك هون.
على جنب على جنب.
Yeah. We're on. Okay, so as you can see on the fluoro, now we have a balloon up the duct and an extraction balloon. Go up please to 1.5. It's the extraction balloon is up to 1.5. You can see the stone better. Inject. And I'm evaluating the duct better now. It looks like it's a little narrowed. And even if you look endoscopically, you can see the impression of the balloon in the diverticulum, which could pose a problem with the stone also. But here we can see that the dilatation seems to have worked, and the 1.5 centimeter balloon down is passing easily, and we can see an open sphincter here. So right now I'm gonna go try to get that stone out. Wire back. Okay, balloon up. Okay, balloon up. Best she won. Okay. Fluoro, we're on. No. So we're sliding next to it. We have to try to wire back, balloon down. Yeah. Wire, less wire. So I'm having difficulty passing. Okay, balloon up. Not too much, just to pass. Okay, so I got hold of the stone, and it is right now, it's coming down with my balloon. And let's hope it passes without problems. Okay. Inject, please. So we're trying to, again, you can see the So this is the balloon right below the scope, and beneath it is the stone. And right now we're trying to get that stone out. Drop the balloon a little bit. Sometimes the balloon might actually prevent you from pulling enough. So I drop it. So I drop the balloon and so balloon extraction, stone extraction. I'm trying. Again, I think that that diverticulum is causing us some kind of a problem, because every time we try to pull the stone in, it goes into the diverticulum from within the bile duct, preventing us from having a good grab on that stone. So here we go again. Again, I have the stone engaged, but هون يبطل.
That's it. No.
So again, I'm just trying to
Yes, sir.
extract it. بدك تروح على غير محل.
Yes, sir.
Yes, sir.
You can try another dilatation or not for a 13 millimeter or 15 millimeter?
We can, since this is one option, or to just go for the basket.
Yeah.
My concern here is that with the diverticulum, no matter what we do, that stone will always push itself inside the diverticulum.
But maybe with the basket it's better.
Here we go. Balloon down. So you see, the balloon came out. It's not a problem of size, because the balloon came out, but the stone did not. And that's because the diverticulum is allowing it to slide on the side. Okay, we're gonna go in again. Balloon up, 1.5. And here we go, another extraction attempt. Eh? Here we go. نزل شوي جاك. So we're still stuck with this stone. We might have to resort to the, because I don't think it will be easy to pull it through with the balloon, because it will continue to go into that gap that the diverticulum is creating. Yes. Okay, so balloon down. Now I'm going to obtain another cholangiogram. Balloon down all the way. شو الاسم؟ So we're gonna re-establish access here. Okay, wire N. Yeah, as you can see, I'm still on here. The sphincterotomy is wide open, but between the diverticulum and the size of the stone, it's giving us hard time. Balloon up بس هيك to clean the duct. Cleaning the duct. Lots of debris are coming out. Okay. Am I still on? Because I think the stone might be coming out here. Okay. Here we go. It's still live. Okay, we got lucky, it seems. And balloon down. Balloon down. When I was getting ready to switch to a basket, I did a final try, and here is a big stone, if you can see it. The stone is out, and hopefully we can confirm the clearance of the duct. Hello, good job, Malhem. Yeah, I'm happy we didn't have to do more. This is a stone here. Wow. Okay, excellent. Yes. Yeah, you're switching to another room, Allah? لا. ها؟ لا بدي ارجع افوت اعمل. ها؟ شو الحظ؟ ها؟
يلا dilate. Off. اوكي. عم نعمل dilation لل right anterior و right posterior.
فيك تاخذنا الاكس راي صورة الاكس راي. لا ماشي بس ياخذ الصورة الاكس راي عم بيشوفوا هنيك الاكس راي.
بس شوف لنا اذا عم بشوفوا الاكس راي بليز.
Are you seeing the X-ray?
اوكي داون عليه. داون.
We don't have the fluoro.
خليك اعملها كذا مرة.
You don't have the fluoro.
بدنا الاكس راي.
فيك تقلب الكاميرا على الفلورو. إذا في قلب الكاميرا على الفلورو.
يعني مش الحال. اوكي. داون علي داون. اوكي علي هون ارجع حط البالون لفوق.
Can you focus on the fluoro?
To 8.
Can you focus on the fluoro, cameraman? على الاكس راي.
Yes, thank you.
اوكي هون في
بنشوف
الويست ساين.
اوكي خلينا نحضر اول ستاند. شوف metallic. Uncovered. Okay, down on the balloon. Down. هلا هون هنحط metallic stents. The issue is we don't have dedicated hilar stents. So we're using regular biliary stents to do this. It'll be more challenging, but hopefully we'll be able to do that.
So Moin.
Yes.
You will put the first
yes,
stand.
Go ahead.
You will put the first stand before the second dilatation.
We do two dilatation.
Okay.
We did two dilatation.
Okay, عملنا dilatation of both right anterior, right posterior.
Moin, I have a question.
Zahir has a question. Go ahead.
How to choose which the right or the left drain before?
So right, first, very importantly, to look at the scan. If you have a segment that is atrophic, you forget that. So you focus on the segment that's not atrophic.
No, I mean the stent now. How to choose technically?
Yes. So two things. One, I thought the right posterior was tighter, but also the right posterior has an angle to it. So it's harder to push. Right anterior is straightforward. So we're going to go right posterior. So this is what, a 10-10? And what stent is this from who? Boston Orthodox, okay. So don't pull on the wire more. So of course, this has to be uncovered because going through the hilum.
لا فيك ما الباقي الواير الثاني موجود فيك توقف وتحط الثاني.
أعطينا fluoroscopy please.
اوكي. اوكي.
So هون شفنا
the fluoroscopy.
اوكي خلينا نبلش نعمل deployment علي سلو ودكتور حلال constant fluoroscopy.
Okay.
Go ahead. Go ahead. So I'm letting ride over the. Okay, stop for a second. Fluoro shot.
Go out. You have to go out twice.
Okay. Go ahead.
Okay. بدك تشد شوي لبرا.
Stop. Fluoro. That's good. Okay, go ahead. هلا هو بعده حيعمل shortening. هيدا ال end of the stent here. Okay. Go ahead علي. Stop for a second. Fluoro. Fluoro, Dr. Halal. Good. Go ahead.
Excellent job.
هلا هيدا هون خلصنا. خلينا نشوف إذا في تعمل ريشيت أو شيء هون فلورا.
فلورو.
إيه عملت ريشيتنج. أوكي. طيب مش الحال. طيب دي علي أي واحد الواير اللي لك؟ هيدا. اوكي فيك تقوم هيدا وخلينا نشوف هلا اذا فينا نحط ثاني واير ثاني ستاند حد. هلا شغله مهمه هون اذا فيك تطلع الستاند بريت الدك هيدي شغله منيحه حتى اذا الستاند عمل obstruction access to it will not be difficult. So now you see how access to the other side might be difficult or challenging. Fluoro shot. Good. So what we do in my practice, we put hilar stents. So the hilar stents are 6 French. The catheter, deployment catheter is 6 French in diameter, which means you can push both at the same time through the channel and deploy simultaneously. This is a long wire system, huh?
This is from Microtech, right?
Yeah, so I think this is, okay, I would have reversed the order.
Moeen? Dr. Moeen?
Yes?
We didn't hear very well. Which diameter you use for the metallic stent?
Hold on. Yeah, so here it's 10 millimeter diameters. It's basically what we have here. So, let me see here. The elevator is not really helping me here. Fluoro shot. Can we come down on the fluoroscopy?
Okay.
Ali? علي انت هون لايف، اعطيني شوي تنشن على الواير. يلا اوكي. لا دقيقه شوي، ركز لي بهالاكس راي بليز، الله يخليك. اوكي لا بدي اشوف من تحت. هيك ممتاز. يلا علي شد على الواير، ما توقف فلورات، ما توقف.
بس تقطع هي منها حتى ما تفوت فيها.
لا عملنا دايليشن
مش عاد. اوكي اكسلنت. واو قطع مش عاد.
اوكي طيب خلينا نبلش نعمل هون بليز ديبلويمنت. جو هيد. فانا هلا عم خليها تطلع من السكوب لحالها. هون هيدا الاند بعتقد. لا بعد. اوكي عم اهلك يا انا هيدا المايكرو شوي هيدا مايكرو تك ستنت اول مره بستعمله.
هذا مايكرو تك.
اوكي دقيقه شوي. ها لا اللي عم بقوله وين بدي اشوفه على الاكس راي.
فوق.
اوكي جو اهيد.
هيعمل دبلوم يلا. اوكي بلش بين. اوكي
ضيق عليه. وقف. اوكي جو اهيد. بدنا اكيد يكون من برا حتى اذا ظاهر بالمستقبل بده يحط شو ما كان reintervention will be good to have. Okay, so okay, looks good.
Excellent job.
حملنا.
طيب مساء الخير. طبعا احنا عملنا EUS للبيشنت and we find a small duplication cyst that يعني احنا ما تعملش symptoms of the patients. Okay, ف we revised the manometry. Actually احنا we are sure that this is not achalasia. لكن احنا شفنا الصور بتاعت المانومتري وشكينا ان ممكن دي تبقى حاجه اسمها distal esophageal spasm, but we're still not sure. In another circumstances يعني ده لو عندنا في جامعه القاهره I would have repeated the manometry, but actually this is not an option right now. So after discussing with the relatives and everything, we decided to do myotomy just above the cardia, not including the cardia, and to see if the symptoms of the patient is going to improve or not.
Actually, as mentioned before, here we do POEM by different approach. This is a posterior approach. Posterior approach, usually we do mucosal entry and the tunnel at 5 o'clock. It's not at 1 o'clock. Here we are using hybrid knife for dissection and myotomy. Hybrid knife is designed to do injection, cutting, and coagulation. The setting with hybrid knife is different from other knives. Usually, please camera here on the RB. We are using the RB, the latest Vio 3. We are using end cut Q with the FX 3, okay, and cut interval 3 and cut duration 3. So 3, 3, 3. And we can also dissect during the tunneling by precise sect with 4.5. So now we start with a different approach, as we mentioned. Yes, as we mentioned, with different approach, as we see here. This is the tunnel opening. It's at 5 o'clock. We inject water to see the spine impression, and then we did the mucosal entry. Here we can see the orientation is very important. In posterior approach, we can see the mucosa up at 11 to 12 o'clock, and the muscle will be below.
عكس الانتير ابروتش. The case Dr. Muin did before, we saw that the muscle layer is up and the mucosa was down.
ممكن نغمق لون الميثيلين بلو شويه.
All through the tunneling, it's better to be near from the muscle layer, not from the mucosa. Because the mucosa will be the only barrier between the gut lumen, the first space, and the second space, which is outside the lumen. So we inject in the submucosa. The submucosa has high affinity to the color. Now we are see a bleeder. The bleeder, if it's a small, we can control it with the hybrid knife. It's a large caliber. We can control the bleeding with the hot biopsy or coagrasper. So we are doing pressure of tamponading. We are tamponading the veil by pressure of the overscoop cap or distal attachment or cap. So our pressing, just pressing on the scoop, on the vessel, and we can change the instrument to the hot biopsy. Here we will control the bleeding with hot biopsy. First compressing, then open the hot biopsy and catch it. We'll control the bleeder using the hot biopsy with the more precise sect for coagulation, 4.5 as mentioned before. After grasping the vessel, actually we did wash to make sure that we are, or we did a good catch. Orientation is very important. Where is the mucosa and where is the muscle layer? Where is here the muscle layer? We see here the muscle at 6 o'clock and the mucosa at 12 o'clock. We are using here a gastroscope from Fuji. It's 7 series, 760. Okay, this is a diagnostic scope with working channel 2.8 millimeter. Actually, during doing intervention with diagnostic, not therapeutic scope, we need to go outside. We go outside the tunnel and go through the stomach and insufflate the air from the stomach, and then go back to the tunnel. We clean our knife and go again inside the tunnel and continue the tunnel. In this patient, as we said before, we are not convinced that it's truly achalasia because the cardia is completely incompetent, maybe held 2 to 3. So after discussing that issue and the symptoms of the patient with his relative, we decided to do a myotomy for the lower segment of the esophagus. It may be a different entity, or it may be another motility disorder like distal esophageal spasm.
ممكن نوري الاودينس البدلات اللي تحت رجلينا.
Here Dr. Shaima use 4 paddles under 4 paddles air foot. The first one here, this is the first one is for RB jet to inject with the needle. The 2 is the flow for coagulation
yellow for endocut or cutting, and the fourth one here is for irrigation. Now we are seeing a minor bleeding. We can control this minor bleeding by the hybrid knife. So it's a repetitive manner for dissection, injection, and dissection.
One of the newest things that we are using with the new Irby 3 is that we have a problem with the hybrid knife. Okay. تمام. One of the newest technology of Irby that the hybrid knife was usually not suitable. There was no suitable mode of coagulation used during dissection, as we have seen Dr. Moin. Dr. Maid was using spray coag. So with the hybrid knife, it's different. We use endocut, which makes the procedure a little bit more bloody. So after the new precise sect mode, we can use the precise sect mode in coagulation with the hybrid knife. ممكن نوري لهم المودز بقى يا شيماء.
نوريهم. So now we can dissect with the new mode, with the precise sect. We can dissect with it. It's like a matter of spray coag, less smoke, it's less blood than endocut Q mode. So now we are dissecting using this mode. This is the coagulation mode with the precise sect. Also, we can control the bleeding with the knife. This is a bleeder from the mucosal side. We inject first to avoid mucosal injury. Inject, then coagulate. I think now we are approaching the lower segment just before the cardia, as we decide not to do myotomy for the cardia, maybe 1 centimeter, and we will start to do myotomy.
I'll go out and check, okay? ماشي.
So now we'll go outside the tunnel, check for hemostasis, and we'll check the lens. We did it. So we'll go outside. The blue color will draw the line. I think we reach here. Yeah, again. So we are approaching or reaching the cardia, as you can see here. So we don't need to do myotomy at the level of the cardia, but actually you can see the blue color or the blue sign here on retroflexion. This is the blue sign. So we'll go again inside the tunnel and we will start myotomy.
نقطع كمان سنتي بس مش رجلنا.
Actually, we'll
residual bleeding here. We have residual bleeding here. So we inject. We can inject even without touching. I think enough يا شيرين مش كده؟
I think yeah. I think this is enough to, and we will start myotomy now. So we will start myotomy just 2 centimeter below, 1 to 2 centimeters just below the tunnel opening. We will try at first in the upper part of the tunnel to do selective myotomy. Also, we are using endocut mode for doing the myotomy. We start by doing myotomy fiber by fiber until reaching the longitudinal layer. As you can see, this is a different approach. The muscle at 6 o'clock. This is the posterior approach. قدام شوية بقى. قدام شوية. أيوه. Actually, in hybrid knife, we have 3 types. The first type is the T, the type we are using here in this case, and this is the ideal type for doing point because it has a T shape of the knife. We can hinge, as Dr. Shaima is doing now, hinge under the muscle and then going up and doing myotomy. The second type is I type, preferable in ESD, and the third type in O type. Here we can see selective myotomy. We are preserving the longitudinal layer and did myotomy for inner circular layer. The longitudinal layer is the outer layer. We are trying to save it and not doing myotomy or complete myotomy in the first part to avoid bleeding, to avoid complication, because here we are the outside adventitia. We are trying to save the adventitia and the outer circular layer to avoid delayed complication or to avoid bleeding during myotomy. Actually, you start doing myotomy from outside to inside the tunnel. So we put the needle outside, as we can see here, from outside, from down to inside the tunnel. First, we start myotomy by doing coagulation, then cutting after that. Cutting. We can see some minor bleeding. We are not worried about this minor bleeding, and we can control during dissection and during myotomy by the knife. But our concern about the bleeder outside the muscle layer from adventitia. So when we put the knife outside or from down, we start by doing coagulation because we are not seeing what are behind this knife. And now Dr. Shaima using myotomy by technique, what we are calling this push technique. She puts the knife down and then fix the knife on the tip of the scope and push the scope to make the procedure much more rapid or faster. I think we are approaching the end of tunnel now. We have see here some muscle fiber. We repeat it again and then doing myotomy for at end of this tunnel by full thickness myotomy. Full thickness.
عايزة أخلص الحتة دي full thickness.
Here is some circular inner layers, and also we'll cut it. كفاية.
Final cut.
عشان بس الميكوزا من الناحية الثانية. Now we finished myotomy, most of the tunnel selective myotomy. Now we'll go for hemostasis using the knife. Actually, maybe the edge of the myotomy or the base in the longitudinal layer has some minor ooze or minor bleeding. We did hemostasis and check again for hemostasis. And check again for hopefully symptoms of this patient is improved after doing this myotomy. I hope to help him and to make his symptoms disappear.
صغير 11
After finishing the myotomy or the tunnel and myotomy, we have to go outside the tunnel and check for any mucosal injury. Now, no mucosal injury. This means that no perforation. The mucosa will be our barrier. And after that, we'll go again inside the tunnel to check for hemostasis for last time. And after that, we will close the mucosal entry and close the tunnel. Some muscle fiber are left at the end of the tunnel, so we will cut it.
سيبها بقى خالص.
Actually, I can see that the muscle here is a thick, much more thicker than before. مين؟ احنا خلصنا.
More ولا كده؟
لا كفاية.
طب check for hemostasis the last check. يا جماعة الإبرة بتشد عليا يا جماعة سايبينها في الشارع ليه كده؟ علاء ممكن يا علاء تعلق الإبرة يا علاء أنت إيه يا جماعة أنتوا مش مركزين زي اديني سن كده شيلين. لا يعني الإبرة ما تترميش كده عشان نبقى عارفين إحنا بنعمل إيه.
مش عايزاها تتساب كده فبتتني.
We're checking for hemostasis.
The most common site of bleeding from the muscle is the edge of the muscle we cut it before. So we are checking thoroughly and carefully for this edge, for any bleeder or any blood vessel, and doing coagulation. This is very important to avoid delayed bleeding. This minor ooze, we can control it and stop it with the knife. We check the edge, the right edge and the left edge. We check the right. Now hemostasis is okay, and we will close the tunnel.
اللي عندك ايه اللي جاهز؟
Okay.
ماشي.
Here we will close the mucosal entry or the tunnel using the microthecal 16 millimeter.
عايزه كليبس كده ها.
We'll start by application of the first clip from distal to proximal. Actually, you can adjust and turn the clips to better at 6 o'clock at the tunnel entry. So we'll go back and starting by application of the first clip, which is the first one is a very important clip. This will approximate the two edges to each other.
ثواني. لا. اقفل بس don't fire. Okay.
Okay. Actually, you close, then asking our assistant to fire it.
Actually, I'm having a very good assistant here, Mr. Tariq. Actually, يعني I'm amazed with him. اقفله. لفه وهو مقفول. لفه وهو مقفول. لفه وهو مقفول كمان بس افتح. اقفل. فاير.
It's very important when our tunnel avoid doing a fold by putting the clips on the and pushing down, then grasp, and then after that pull it up and avoid to doing like a fold. I think we need more 2 or 3 clips to close the entry.
Here we are using microtick clip.
This is a different size from microtick 11 millimeter. So we start with 16 millimeter to approach both edges, and we will finish with 16 millimeter. I think this is enough. Yeah, perfect. I think this the type of clip with a short stem may be helpful in the narrow lumen, as we did the case with Dr. Muin in the morning for the Z point.
بس لف لفه بسيطه بالراحه بالراحه. ارجع تاني. ارجع تاني. اوبن. اقفل. فاير.
Perfect.
حط واحد في النص في الاخير ولا؟
You have any questions from floor?
Thank you. Thank you. شكرا جزيلا.
Hello. Good evening, everybody. I would like to thank every participant in this Congress. The lecture of Dr. Shaima will be postponed to tomorrow because she is tiring today. I would like to introduce Dr. Niklas Frommel. Dr. Frommel is a clinical application specialist in RB electromedicine at Germany. He holds a medical degree from the University of Leipzig on endocrine neoplastic disease and looks back to several years of clinical practice in surgery and psychiatry. In RB, Mr. Frommel is focused on the global clinical education of surgical disciplines and interventional endoscopy in pneumology and gastroenterology. Mr. Frommel, it's up to you.
Thank you very much. Let me share my screen, please. First of all, congratulations, Dr. Shaima and Dr. Sherbini, for an excellent live demonstration, and also congratulations to the organizers for an excellent symposium. Thanks for giving me the slot to talk today about our technology in GI endoscopy, and I want to present to you the toolbox for endoscopic tissue resection, introducing to you the variety of options you have when using RB tools. So first of all, part of any endoscopic tissue resection will be the lifting, obviously, and I want to introduce to you, as you have seen before already, the elevation using the RB jet, which is a selective formation of a submucosal water cushion. Why do you need that? In almost all endoscopic tissue resections, aside cold snaring, you will need to protect the muscularis layer from thermal damage, of course, utilizing high frequency current. And therefore, this cushion gives you what we call the heat sink effect. So the energy that you apply to the tissue is dispersing in this cushion and thereby decreasing the risk of injury to the muscular layer. Utilizing it in the EMR, this high pressure submucosal injection has been proven to increase the rate of en-bloc EMR for colorectal adenomas of over 12 millimeters in size compared to the standard needle injection. And I tend to show these two video clips when comparing the needle injection to the normal injection. So you can see here the needle injection of a lesion close to the anal verge in a very well vascularized area, of course, the hemorrhoidal plexus. And that's what's going to happen. You didn't even start your cutting, and what you get is a bleeding. And using a needle-free injection with high pressure injection is what you can do with the Erbijet 2 and EMRs as well as ESDs. And you can see that without puncturing the mucosa, you're enriching the saline in the submucosal space. And experience-based, I can say that you're going to have very few bleedings, even if you're in well vascularized areas as the hemorrhoidal plexus with that. What can happen on top if you inject with a needle is, of course, the either intramuscular or an extramural injection, which will give you a false non-lifting sign and maybe have you send the patient to surgery, although it's not necessary. And I think this is what we all want to prevent: unnecessary surgery for benign adenomas in the colon, for example. Both of these, of course, create an intramucosal hematoma, the needle as well as the Erbijet. And what you need to do to prevent this when applying the water with the Erbijet is choosing not a too flat angle, but rather an angle that comes closer to 90 degrees if possible, so you don't have this intramucosal hematoma, which can then be in need for a salvage ESD, as reported by the group of Jérémy Jacques from Limoges. So avoid a too flat angle of injection, either in ESD or in EMR, whenever you're applying high pressure water jet injection. After you have injected, we now proceed to the example of snare resection or to mucosal incisions in general. And therefore, we have the endocut mode on the VAIO electrosurgical unit. And one point I want you all to understand when you go home today is that when you want to go through the cutting and coagulation cycles one after the other, then you will need to activate the yellow foot switch continuously. So what EndoCut does is actually drying out the tissue. And once the tissue impedance is increased enough by this drying out, a spark will arise and you will get into the cutting phase. And that's the special thing about the VIO3 generator, that you have a spark detection technology. The generator recognizes when you are finished drying out the tissue and when the spark arises. And from there on, starting the time that you have preset in your unit, giving you a very, very precise control of your actual cutting. So the spark arises, you are cutting, going through the cut duration, which has been demonstrated before, where to select it on the VIO3 machine. And then when you stay on the pedal, you're going to go through the coagulation phase automatically. What will happen if you don't stay on the pedal is you're going to start over and over again this drying out. Maybe you're going to pick a few sparks every time you tap, but you're going to start this initial drying out over and over again. In very, very experienced expert hands, this can work and this can achieve good results. But to have a reproducible result and to really make sure that you go through a coagulation cycle after cutting, stay on the pedal. So that's one of my key messages once you shut down your laptop today. We have EndoCut Q and EndoCut I. EndoCut Q is preferably used for snare resections, as you can see that it goes through an incremental increase in the cutting voltage over the first 3 cutting cycles. And this attenuated initial voltage, a bit lower than these 700 volts, gives you more control. So you're going to err rather on the side of coagulation, and especially in a pedunculated polyp, you're not going to cut too quick before you have a good coagulation. Different story with EndoCut I, which has a fixed cutting voltage from the very beginning, and therefore it's very well suited for mucosal incisions like an ESD, where you might need to stop activation after you went through only 2 cycles, but then you can be sure that you have a very good cutting voltage from the beginning. And you're going to need that, as we know that for POA, minimized oozing from the cutting edges is very important, because when you have a bleeding from the very beginning, then all this blood is going to go into your submucosa and impair your visualization. Again, stay on the pedal, do not tap. These are common settings that we know. So for mucosal incisions during POEM, during ESD, but also for STARE, for example, you can use 2, 2, and an interval of 2 or 3. That's a suitable starting setting. For hot avulsion, use 1, 1, 1, and make sure you're tenting the tissue. You're not staying with your forceps on the wall of the colon, but pull it towards the lumen to make sure that the least possible amount of energy is brought into the depth of the wall. For EndoCut Q, look at the polyp. For a stark polyp, a setting of 3, 1, and 3 to 5 has been suitable for starting. If you have a non-pedunculated and broader polyp, then you can also go for the settings mentioned below here from the coagulation from Heiko Pohl. One more thing that the generator is not doing for you is current density, and that's a concept you need to understand to really make good snare resections and other endoscopic resections like ESDs. When you have a high current density, then you have a small contact through which the current is brought into the tissue, like you see with a needle electrode here. This is a cutting current, and you can see a very clean, sharp cut. It's easy for me to go through the meat. Now I have applied the very same settings with a ball electrode, so a much larger surface to the tissue, and the cutting current is not cutting anymore, but it's just coagulating. And that's a matter of good current density. So a high current density means you're gonna err on the dissective side. A lower current density means you're gonna err on the coagulative side. And this is very important when it comes to snare resections, because if you have a too loose snare closure, so imagine this is looking from upwards onto your polyp, and you have the polyp here and you have the snare wide open, placed very wide around the polyp, you're going to have a large contact surface area between the snare and the tissue, which is going to result in a lower current density and subsequently in a less dissective behavior of your mode, although if you have chosen a cutting current. If you close the snare further, you're not going to have this problem. Then you're going to have a higher current density, you're going to have a more dissective behavior. So an appropriate snare closure, imagine this is your polyp and you're squeezing the snare around this polyp here, then you have the smallest possible contact surface area of the snare in relation to the polyp size and its shape. You're going to have the high current density, you're going to have an optimal dissection. But a very, very tight snare closure doesn't mean that your current density is going to go up anymore, but at some point it's going to go down again when the polyp is kind of overflowing over the snare, and thereby you're going to have a larger contact surface between the snare in black and the tissue in red as compared to the optimal snare positioning. And then you're going to have a lower current density again. So it's really kind of an art to have a good snare closure to the polyp. So all the settings, nice and well, but choose your snare closure, work with the current density wisely. This is also important when it comes to submucosal tunneling, and we have seen a beautiful demonstration by Dr. Shaima just before, who was using the PreciseSec mode for submucosal tunneling. And this mode is also working with a contact surface between the tissue and the knife. So let's say you want to be dissective, then use the PreciseSec with only a small contact surface between the electrode and the tissue, as you can see here, and you're going to have a rather dissective behavior because the generator senses a high impedance and you're going to get a higher current density subsequently. If you have a large contact surface, so you go alongside the vessel with the electrode, like you can see in this picture, the generator is going to sense a low impedance. You're going to have a lower current density and it's going to be rather coagulative. And so you can utilize the contact surface to make PreciseSec work the way you want it to. So for the submucosal dissection with PreciseSec, it's important to inject and lift, evacuate the excess saline, do not work underwater. It's only going to give you bubbles, nothing more, because the resistance is going to be sensed as very low by the generator, and then slowly sweep the tip of the knife over the fibers in the submucosa. So you can see it here in the video, you can see a lifting, then you see the evacuation, and then he's dissecting only with the tip of the knife. This video is Dr. Beiner from the EVK in Düsseldorf, and you can see how beautiful he's dissecting. There is no bleeding, there's no carbonization to the muscular layer, and you can see how beautiful he's doing that, just as we've seen before in the presentation from Dr. Shaima. Another thing is coagulation of vessel. So as I said, expose it, go alongside the vessel with the tip of the electrode, and then continuously activate and move very slowly through the vessel once you have dried it out. And we can see this here in a presentation from Neil Sharma from Parkview Health in the US, who's using the PreciseSec mode. So here the generator senses a high impedance, and when it's going through the vessel, a low impedance, and you can see these large vessels which are way thicker than the electrode tip, and no bleeding during dissection. So let's say you have done your ESD or your EMR, rather your EMR. How do you prevent recurrence? So APC in conjunction with snare resections, for example, as a thermal margin treatment has been described in the literature, as well as the ablation of dysplastic Barrett's epithelium after the resection of visible lesions, so a so-called neoplastic Barrett's esophagus. And I want to go into depth on the thermal margin treatment. So I know that all of you have seen this publication before by the Australian group around Michael Bork that was able to prove a four-fold reduction of the relative risk of recurrence on surveillance colonoscopy 1 after 6 months by applying snare tip soft coagulation. So he could show a 5% recurrence with STSC versus 20% recurrence after piecemeal EMR with no STSC. Well, my comment on this, when I first saw it, is like, okay, but Michael Bork is kind of he's a Yahagi of the EMR. So look at him doing at the SNATIP soft coagulation. And I didn't have to search long, and I found a comment from Daniel von Renteln and Heiko Pohl from Montreal in Canada that actually seemed to think the same. So it might seem easy in expert hands, but and all the investigators in the before mentioned trial were expert hands, but it's unclear how it performs in the broader community of endoscopists. So my question would be, is SNATIP soft coagulation reproducible? Maybe, but we know that there is a higher recurrence rate outside Australia compared to this very Australian group by 20 to 50% plus, which is quite a lot. Also look at this publication and try to arrange these pinpoint coagulations to really homogeneously ablate the surface like Michael Burke. Most of you, I know there are many, many very well-trained endoscopists among you, but you will not make it so accurately in each and every patient. That's very, very hard to reach. And the third question that I have on the trial from Burke, do the residuals really come from the margins, or do they maybe come also from the resection bed? We don't know this. Until we have proven the opposite, I suggest this option as a possibility to perform ablation of the bed as well. This is hybrid APC. So again, needle-free injection and lifting. You can see it here before the EMR. So beautiful lifting of the polyp with an effect setting of 30 to 50 on the herbojet. And after the snare resection is performed, you can relift margins and resection bed without a needle, like you see here, to again prevent the deep transmural injury. And after that, you can ablate in a very controlled fashion the margins of this defect. So you can see that the fibers are lifted again, although snaring has been conducted before. And then what you do is an ablation using a pulse mode with 40 watts max and a low flow rate. And you can see that it's quite simple to achieve a homogeneous ablation of the margins, and that you can only also ablate the bed. And once you are concerned that your ablation is quite aggressive, you can easily relift the resection bed, like you see here, and it's relifting. And then you evacuate the fluid and you proceed with your ablation, not only of the margins, but also of the bed. And I think the homogeneity here is quite well visible. What does he say about it? So Levenik, who is doing this, is highlighting that the post-resection base can also be lifted for an aggressive and adequate ablation, because you can take advantage of the heat sink effect and just look at how homogeneous the ablation is afterwards. It's lovely to see. So what's the evidence on this? This is the one trial that's been presented during last year's DDW. So it was only 53 patients compared with or without hybrid APC ablation of margin and base. And on 6 months follow-up, they had no recurrence still. Of course, we have to restrict that the cohort is quite small. Nevertheless, it seems that we can achieve a very low recurrence rate using hybrid APC, and there are further trials going on this topic, so it's still a topic of interest. There is a novel mode on the VIO3 machine, which is the precise APC mode, so it can be done without lifting as well, in a very simple way to have a homogeneous ablation of the margins. That's a mode you might know for treating angiodysplasias in the rectum, or maybe the Gave syndrome in the stomach. So you can achieve a very homogeneous ablation with ease. I mean, look at the way you can go along the rims with a cap. It makes it a bit easier to maintain the distance between the tissue and the APC probe. And you have a very good thermal margin ablation as well, which is very, very homogeneous, as you can see here. But still no lifting, so treating the base I don't know about any data. To wrap this up, first of all, it's always the electrosurgical unit and you. So you can have a waveform and a dedicated voltage that create the tissue effect, but make clever use of the current density. If you want to dissect, if you want to cut something, make sure you have a high current density. If you want to coagulate something, then you're going to go for a rather low current density to be coagulative. In precise sect mode, the generator is even reacting to your behavior, to your contact surface between knife, electrode, and tissue, and is adapting that. So if you have a small contact surface, then it's supporting your dissection. And if you have a large contact surface, then it's supporting your coagulation, a unique feature. And there is hybrid APC or APC-assisted EMR, which can provide you homogeneity and reproducibility compared to snare-tip were able to demonstrate that. Are the base or the margins the origin of recurrence? Let's see. There are trials investigating that as well. And precise APC is able to ablate even without cushioning in the margins. But at the base, we're still waiting for data. So far, thank you very much for your attention. And again, congratulations on an excellent event to the organizers. Thank you very much. And by the way, I'm happy to take any questions if you have some. Dear tech team, I don't have any sound, unfortunately.
I have a technical question. Does the shape of snare, oval, or trapezoid play any role in the quality of polypectomy?
Can you repeat the question, please? I didn't get it properly, but I hear you again, but it was hard to understand for me. Sorry.
Does the shape of the snare, oval, or trapezoid play any role in the quality of polypectomy?
My comment would be that it always depends on the lesion that you're treating. So current density is, so to say, a physical concept which can apply to any snare. May it be a monofilament snare, a polyfilament snare, a ductile snare. So what plays definitely a role is the wire. Is it a monofilament, a very thin one, or do you have a polyfilament snare, a braided snare, which will give you a lower current density baseline because it's thicker and thereby generating more contact with the tissue. But at the same time, if you have a very small contact surface between the tissue and the snare with a braided snare, then you're going to have a high current density. So I would say it always depends on the handling, on the closure, on the lesion, on the tissue. So I wouldn't say there is this single one snare that fits it all.
Okay, thank you. Any question? Okay, thank you, Dr. Niklas, for this nice presentation.
Thank you.
يعطيكم العافية. نشوفكم بكرة الصبح إن شاء الله.
ليك فيك تصور لي نشوف كيف. بعثولي واتساب اشوف كيف. قال لك شو المشكله.
سوري نص دقيقة من الوقت بس بليز.
فهي تسحبها عشان تترك بس هي الصغير يختفي بدك تشوفها، هذيك الكبير نعملها عشان تشوفها فيها. بتضل هذيك تروح عشان تضل الشعر. بدك تكملها نفس الوقت. أو إذا كنا سبيكر يبغى أحسن وأحسن. اوكي اذا حتى ستاندرد هي اول وحده تعطي فول سكرين ما بتنفع الستاندرد. شو بتعملوا؟ بيروحوا على بلاتينوم بتحضروا انا اصلا بدفع بالفعل روحوا على الاوتيل بالباص مش هلا عشيه حتى لو بس هو يعمل نتعشى سوا انا ونسى رح نكون بالفيلا فنرجع نتعشى سوا هلا نحكي تواصل معهم مع اداره على الجروب مع اي ساعه كونوا تحتوا بس لا خلص رحنا نحن ميرسي بوكو يلا اذا رحنا خلصنا بكير بكير يجون وشوفوا مع بعض نرجع شو بدك تبين السكرين تبعك اللوجو شو بدك تعمل كذا انت بهمك انت ما هي تجي على الديفايس وعندك انت شو بدك صدق نحن رايحين بس اذا بيسبقونا او نحن نخلص هون من نفس السكان اخلص الجواب الثاني
يلا انطفي شوي هلا بدق لك. هلا بدق لك لحتى اخلص الكابل الازرق هلا بدق لك. لا ما خلص
الشباب منطقه الشيء اللي يحول الكهرباء.
لا لحظه بس
ده كمان سكرين.
اوكي.
The FDA did post-marketing studies indicating a 5% rate of culture-positive scopes despite reprocessing. That's a huge failure rate. 1 in 20 patients is at risk. That's something that should really wake us all up and have us look at what we can do better and how we can redesign scopes. Disposable types of scopes will help, but it's not the long-term answer. Either the reusable scopes have to come out of something better, where complete sterilization is actually possible, or I think the future is going to lie with disposable scopes.
Clearly, where the field is going is towards use of single-use device. And the more we try and the more we get familiar with it, because it's going to be a game change for the field of interventional endoscopy.
Once I began the procedure, I completely could not tell I was using a disposable instrument. I forget I'm using a disposable scope when I'm working on this.
I think what we're living through right now is the beginning of a transformation in healthcare, where we're going to look back 10 years from now and say, I can't believe we were using, scopes that we reused over and over again. So it gives us a nimbleness to address clinician needs. It gives us the ability to iterate on a pace that has never been seen before. And it manages some really serious problems in endoscopy in a way that no one's ever been able to do before.
الشيء اللي برا يحكي من هون. اللي برا يحكي من هون. هيك برا الشاشة. يحكي من هون 17 أمبير. وهيدي عطيتها زي أنجا سهلتها اللي برا 17 وحدة. 20 4 12 أمبير هي كلها سوا. هذيك 20 أمبير. لطيف شو حافظ
The Acquire Endoscopic Ultrasound Fine Needle Biopsy Device is a new biopsy device designed for the targeted sampling of submucosal and extramural lesions in the gastrointestinal tract. It's able to do this through the accessory channel of a curvilinear echo endoscope. The system comes with a handle and customized sheath similar to our Slimline family of needles, and it provides the same great performance you've come to expect from our products. What differentiates the Acquire FNB needle tip from FNA aspiration needle tips is its cutting surface. While other needles may only aspirate cells and perform minimal tissue cutting, the design of the Acquire FNB needle provides an increased number of cutting surfaces, thus increasing the chances of getting a visibly larger tissue sample for histology. This tip design is similar to percutaneous biopsy needles used in interventional radiology. The Acquire needle also has custom sheath sizes, designed to improve passability and help advance the needle out of the sheath. The 3 needle points are designed to afford greater control at the puncture site. They also provide stability to the tip at all times, allowing for easy penetration. To facilitate puncture and potentially minimize tissue tearing, the tip of the needle is electropolished, a manufacturing process that removes all imperfections. Aided by aspiration, as tissue moves through the needle tip, it's pushed into 3 symmetrical cutting heels. These are fully formed to maximize sharpness and cutting capabilities. In addition, these heels cut tissue from 3 different angles, making a more circular cut before it's pushed into the needle. Compared to the FNA needle tip designs, the Acquire needle is designed to capture a larger volume of tissue with minimal fragmentation. Along with the Acquire's optimized tip design, the system is also made of cobalt chromium, which delivers superior penetration and leads to less needle deformation than stainless steel alloys. The Acquire fine needle system features control zone and lubricomp on the handle for actuation, making it one of the most versatile biopsy devices on the market.
شوفوني ازاي عامل لوب بس ما بظن اكيد بلحقوا يخلصوا وينه برضه
Janssen Immunology has been contributing to science and medicine for the past 23 years, providing innovation in molecules, formulations, devices, and even clinical trials design. On the occasion of the World IBD Day, this year, 8 renowned IBD experts from Lebanon came together to share their experience with Janssen Immunology portfolio and showcase how the available treatments improve their patients' lives.
During the last 2 decades, Janssen has been playing a crucial role in the advancement of IBD therapies. We, as the Lebanese Society of Gastroenterology, expect to maintain a fruitful partnership with you to offer our patients through innovative therapies.
Let us travel back in time to 1998.
I remember the IBD patients that I used to see in my clinic when I was still a resident. As physicians, we really struggled to find the appropriate treatment for each patient. That's why we often opted for surgery, given the limited options that were available back then.
Fortunately, Janssen launched Remicade, which was a real breakthrough at the time. Honestly, I couldn't wait to visit my patient on it and witness the great results seen in clinical trials of my own patients.
Also, it was great to see that Janssen didn't stop there, but rather introduced Symphony, which another innovative molecule offering UC patients the convenience of a once-monthly pain-free injection.
However, our patients were still asking, searching for treatment that better suit their needs. This is where Stelara came along, providing a complete solution for our IBD patients. I still remember how it changed the life of one of them who had Crohn's disease. He is a medical student who had almost lost hope, but had durable control of this disease till graduation. His family is still grateful and thankful till date.
As an IBD specialist, having in my disposition a large arsenal of therapies allowed me to provide a personalized treatment tailored to every specific patient. Now, with Stelara also in ulcerative colitis, we are moving our patients' experience to a higher level, especially if we provide them with medication early on in their disease course.
Nowadays,
هو بيجي لا هو عم يعمل مش داونلود كونفرت فيديو تبع بس طفيته
It is not enough to have a array of patients. However, we need to ensure patients have access to those medications.
Global guidelines highlight more and more the importance of considering patient status and preference while prescribing a medication. Therefore, it's our responsibility as physicians to take those into account in every decision we make along the patient journey.
And this journey continues. Our patients rely on us.
To provide them
ما فيني
with the
المفروض
best
هذا عم
possible
يختاروا
solution.
هو اكيد هن عم يختاروا ضعيف
What the future will hold.
هني وقتها كان المؤتمر ما كان معنا ضعيف بعد بالاول بعد في لك في عندي ضعيف
لا
يعني صرت هون انت هون عندك كل هذه الناس اللي يستحملوا في فيديو 4 دقائق كل واحد.
Break the silence. Join our mission and give your patients their best chance to live free from IBD.
سبعة ايدك كم فين قطع؟ وين صرت فيهم ايه؟
مش حاطط تايم عليه
إذا قطع دعاية لك الواحد مش ضروري نبقى لإهنا بكرة عشية يعني.
لك هاب قطع الدايت طبعا هي نفس الشركة بس هون ما فيني اقطع شيء فيهم هلا بس يصير
بس هو
شو زيرو هيك بالاخر 5 دقائق؟
5 ثواني
5 ثواني
دي كله بيقرجوا هلا
ايه كفي 5 ثواني مش مشكلة شفنا الأكثر
كبير ايه 2 3 4 دقائق
هو صور لأن
هذا ما فيها نقطة
ايه صورة هي
العنوان الكبير
منيح بس هون القطع خلص ما بأثر صورة ما شفنا
بنعملها سكرين شوت
بعدين بدي أقطع له فيديو ومدري قديش فبك كل فيديوهاته يقطعوا
ما بعرف ليش فلسه حملت هالبي دي اف ونزلت فيه امبارح عملوا عيوني انا امبارح بس كل الليل عم ظبط البي دي اف من ورا شو اسمه لا شو هي حتى جريدة النيوزليتر تبع كل شهر
تبعت فيه كلهم صور هو في فيلم بعد
ايه اول فيلم كنت قطعن انا بعد ما صرنا بالنص
شوي مش كليك 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 كليك
اوكي
كل ثانية كليك مثلا كليك 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 بتطلع الصفحة لاحظت الكليك كليك 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 دغري اجوا فكر انا ما حدا عم يحضر كله مفتح عيونه
لا في 30 واحد فتح لي عيونه نحضرهم هون فيديو مش بقطعهم هو 5 6 فيديوز لنفس الشركة
لا حتى ما حبقطع قلبي
يعني 4 دقائق
هذا واحد 4 دقائق
ما كلهم هيك سجل الصوت اشوف عشان اشوف بس دكتور روني ما فيني فوت فوت على هون
الو
هذا لا
مرحبا يا معك
تجيب بنات عصامية يضلوا وحده لا 9 نروح هون ده نروح نتعشى للساعة 9
أصل مين قال لك إنه معنا إذا مش بدك تطلع عليه مش معنا طيب خليني هلا عم تعمل تشيك ان يعني طيب خلص خليني بس اتاكد مره انا ما عم
أنا فصلت له. شو بدنا نعمل؟ هلا أنا عم
يخلصوا الدعايات.
سطب.
application. خلاص.
اوكي
مش عارف. بعد ما فاتوا 8:30 لا
3:30 2:30
عاش فاتن هم
لا 2:30 يعني 2:30 الصبح ل 3:30 بعد الظهر خلص يعني.
لك ما هلا اني بدي على اكونت اقدر المفروض اشوف نحضر ايش عم بيعملوا ايش عم بيخبصوا اثنيناتهم. فت على كر لقيته مش فاتحين.
مش فاهمين انا ميتنج
ميتي فيني اذا فتح يشوفوا لو فت انا ما هيك
افتح
لا
انت بتفوت اذا اسمك ساينس برو ما حدا بيعرف بتفوت تسأل يعني ولا تساعد؟
انا بدي فوت ساعد.
بعت لهم انا اقول لك شو الشغل.
شو هذا ما عندهم شيء.
ست بس.
لا اكيد مش ست.
لا ما في حدا بالموبايل ما صوتوا حدا كيف تفتح اجتماع كلهم ساينس برو
وهيدي
منور نقاط هول حتى بس ما صوتوهم بركي ما بدك تبلش هذا 7 ميتينج هلا 7 ميتينج فيك تحكي معه اذا هذا ما فيه
وين الايرفونز؟
بس ما في ميكرو تحكي معه
بجيب الايرفونز
خليك فاتح.
أكيد رسول لا كتبت اسمه هذا أكيد رسول وين؟
عم تسمعوني؟ الو
ما اقدر هيدا صوت منه
شو بعرف ليه؟
عشان ساعة ما تعملوا الأدمات تخرب لهم الميتنج تذبحك ليه بعد عن الأدمات
دير قصاص من هونيك
دغري فعلتني ميوت.
خلص ظهر
ما عم بيعرفوا يعملوا هو فايتين بالحيط. ليش الماوس تبع
شو بدي هاي وفوت بغير لابتوب
ما عم بيقدروا يحكوا خلص ما بقصر راح اطلع اظهر ححكيهم برجع بدق لهم
ليه؟
ليفت فورورد
بقول له ابديت هيك ناطرين خليه يخلص ابديت الزوم.
هذا شو بعده بأول فين؟
صار الثاني الثالث.
طب قرب شو ناطر؟ حضرنا قرب هذا بالقعدة ما له قلبي
ليك حسيت ولا؟
تبع قرب الفرس كلهم صور؟
لا في واحد فيديو كان
لمين؟
بوسطن شيء هذا
ما
اولمبس او شيء هيك شيء كاميرات ما فينا نشيل المجتمع نرجع عشان لا يعني لا كمان لا سترو ولا شيء مشان مكين
عارف؟ لا شوف اذا ماشي حالك عم نسأل عنكم نحن نهتم نحن خلصنا هلا اليوم فإنه المفروض نطمن عليكم يعني بدك كثير ايه هو اصلا تمام خلاص يعني
خلاص اقطعوا كيف بدهم اللي فور اول يطلعوا كلهم منه خلاص خلصوا الدعايات ايه
خلص
هيك
انا هوست
انت الهوست
انا